Good morning, honorable members. Good morning to some leaders who have joined our meeting for presentations to make. Good morning to the Department of Health and to our staff in Parliament. Before we start our day and our meetings, may I invite you all for a moment of silence and meditation, and also reflect and remember all the Roman Catholic members in the world, in our country, and maybe some of them in our platform. Give our condolence to them for the loss of Pope Francis, who passed away yesterday. He did his best. He gave his all in the leadership of the church. Just a moment of silence, honorable members. Thank you. May the soul of the departed leader rest in eternal peace. Honorable members, we meet today and this week for a series of presentations of institutions that report to us and also to the Department of Health. These are institutions that are actually in the core of running research, running governance of health in the country. They will be presenting to us annual performance plans. They will be presenting also their strategic direction as to what they want to see themselves doing. I need to indicate to you that the Auditor General will not be one of those who will be joining us this time around. They said they reflected on the plans and they did not have anything immediately to reflect on. You might be aware that the AG is currently working on audit outcomes, and we may actually see them in the course of the year when they come forward for that. But so we will miss their presentations. They did write to me, discuss with me over the weekend, and they forwarded a letter, which I have since forwarded to the honorable members, that we will not have AG this time around. We will, however, have 4 presentations today. And before we get into which presentations are those, I would like to just get the secretary of our portfolio committee to indicate the members who are present today in our meeting. Honorable Ms. Machalamba, over to you.
Good morning and thank you, Chair. Present is Dr. Lomo, Ms. Kego, Ms. Clark, Dr. Leroux, Mr. Van Staden, and Dr. Litlape. I've received apologies and Mr. Zungula. Thank you, Chair.
Okay. Thank you very much. Honorable members, I also have received personal invitations sent to me. Because of other portfolio committee pressures, Honorable Van Staden will be with us until just 12 o'clock. He will leave, but will return back to the portfolio committee after we end our engagement. Honorable Sine is away in another committee, which is sitting physically and will be joining.
Recording in progress.
Will be joining us at 2 o'clock, so that we note that those two, one will be leaving and one will then join us. If we then could accept those, Ms. Machalamba, can you flight the agenda for us? The agenda, honorable members, is going to reflect that we start with the Fiscal and Financial Commission at immediately after our opening. We have since moved the mine workers and compensation fund presentation to be at 11 o'clock. That will take us just after lunchtime. We'll then have lunch, and then 2 o'clock we reassemble for South African Medical Research Council. And then what would have been at 5 o'clock will be brought earlier, which is Office of the Health Standard Compliance. Let me just check and confirm that Ms. Machalamba has done that way. Yes. So this is how the day will be. So I only got a congratulatory message from Honorable Clark thanking that we are finishing a day earlier by this rearrangement. Otherwise, we're going to have a long break on the initial program with the absence of the AG. So the AG not coming in, we then brought in earlier one of the presentations. They have since been informed, Mine Workers Compensation Fund, that they will have to be here at 11 o'clock. If then, honorable members, I can request you, if you would want us to adopt this agenda as our working agenda program for today, may I get by indication by honorable members? See any hands? Okay, so, okay. Any takers? Okay, maybe see. There's a hand that I saw it disappeared. Both of my. Let me just see. Right, Honorable Van Staden and Honorable member, we do not hear your apology, and now we have joined Honorable Dr. Harper, starting with Honorable Van Staden.
I propose to move for the adoption of agenda, Chair.
Thank you. A move for the adoption of the agenda. Honorable Dr. Clark, yes. Dr. Leroux or Honorable?
Yes. Thank you, Chair. I second that proposal.
Okay, thank you very much. I would imagine Honorable Teko was going to endorse that.
Yes, Chair. Yes, Chair.
Thank you very much. Honorable members, let us therefore start. I hope that those who are leading us in the presentation of FFC have joined, and they would be given a time slot. Honorable members, we have allowed them to do about 35 to 45 minutes presentation. We'll come back with clarity-seeking questions, and then they will come back with responses. Mainly, honorable members here is to listen to their plans. It's not like what have they done, why they didn't meet this and that target. Some of them are pulling back things that they have not been able to do in the last financial year, and therefore they are inserting it into their plans coming in. But FFC is going to be indicating their observation, reflections on having looked into these annual performance plans, and then we give them a slot now to present. For those who are leading, I'm not informed who leads. They can just start and introduce themselves. Thank you very much.
No, thank you so much, Chairperson Dr. Dlomo. Good morning to yourself, and good morning to the honorable members, the Department of Health, my commissioners who might be on the platform, and FFC researchers and other support staff from Parliament. Thank you so much, Chair. I am the Chairperson of the Financial and Fiscal Commission. Patience Nombeko Mbava, the Chairperson of the FFC. Chairperson, thank you so much for the introduction that you have provided and contextualized our presentation. Our presentation indeed is to provide the committee with an analysis of the performance of the department and its entities. I would like to request the FFC researcher who is handling the presentation to please flight it.
Good morning, honorable members, and good morning, Chairperson. May we have, may they allow us to, because it's restricted, I can't share it on my side. Can any official allow me to share the presentation, please?
Thank you, Sabelo. I think they have allowed you to share.
I hope it's reflecting, Chair.
Yes, please do a presentation mode. Thanks so much. At the bottom there, yes, thank you so much. Thank you so much, Chairperson and members. I'm going to go through the first few slides as an introduction on the agenda. We will just touch on the role of the FFC in this process, Chairperson and members, and then we'll go through the agenda in terms of our understanding of the health sector, the budget and performance analysis of the department and its entities. We'll look at the annual performance plans, and specifically we'll look at the conditional grant performance as well. And then we'll also talk about the national health insurance, our thoughts there. And finally, we'll close with the recommendations of the FFC. If you can go to the next slide. In this instance, members, I'm just wanting to introduce the FFC. What is the FFC and what is the role of the FFC? If you can go to the previous slide. Thanks. If you can just pause here, Sabelo. Briefly, members, the Financial and Fiscal Commission is a constitutional institution which is mandated under Chapter 9 of the Constitution to advise Parliament and yourselves as members of this committee on the equitable share, allocations of revenue, government guarantees, provincial taxes, provincial loans, municipal loans. These are legislative of the FFC have been considered. The FFC not only stops with only these legislative prescripts, we also provide policy recommendations. These policy recommendations are evidence-based. We look at issues of fiscal policy, the budgeting process, financial management, fiscal sustainability, all those issues. We also, members, we consult with Parliament and the legislatures, particularly during the annual division of revenue bill process. We also provide research and analysis. In this research and analysis, we conduct research on various issues that have fiscal implications, and we look at expenditure and the fiscal proposals and implications of budget allocations. So this now touches as to why we are here today. We are here today specifically to provide our research and analysis on the health sector. Next slide. Thank you so much, Sabe. We make recommendations, but we specifically are guided by the Constitution. There are certain criteria that we have to consider when making these recommendations: the national debt, fiscal capacity and efficiency of the provinces to execute their mandates. These are very important when it comes to our recommendations. Next slide. Thank you so much. I'm going to pause and hand over to the head of the research unit, Chen Sang, to just take us through his overview. Thank you, Chen.
Thank you, and good morning to Honorable Dr. Chair and honorable members. My name is Chen Sang, Head of Research. In terms of this briefing, we start off with contextualizing South Africa's health sector. As you would have recalled through various engagements that we have had in this House and this portfolio committee, is that South Africa is, especially in the health sector, is characterized by what we describe as the two-tier system, or one in economic terms, separating equilibrium markets. So effectively, on the one hand, you have the high and increasing cost of private sector healthcare with limited access and low utilization. And on the other side, the public sector healthcare system that essentially faces input cost pressures and but demand, exceptional excess demand that is to the public. And what that means is there are two things that rest in this gap of the separating equilibrium. One is information. Effectively, that those that could potentially have afforded healthcare can't access, and those that can afford, they don't know how to. And in this separating equilibrium markets. And the other thing is that is sort of sitting in this gap as opportunity loss, and therefore healthcare risk is, of course, the availability and as well as the provisions made for healthcare systems in terms of efficiency as well as effectiveness of that investment and utilization of health. With that, we, of course, as commissioned, we've also conducted a series of research on the matter of National Health Insurance Act of 2023 and signed into effect. And essentially, we see this act as essentially that centralizing incentive and law to address and fill those gaps in terms of the separating equilibrium. Just to re-emphasize, one is information, that is information loss in the separating equilibrium, and the other one is utilization and access to healthcare. And with that, the Honorable Chair members, I shall hand over to my senior researcher to start off, Sabelo, to start off with the presentation. However, just to re-emphasize, lastly, the fact that we, in this presentation, we or we present this research before you from a financial and fiscal perspective in the main. However, as we always say, finance follows functions. So next slide, please, Sabelo. If you may start off with the mandate and the purpose of the departments. Thank you.
Thank you very much, Chen, and good morning again to the chairperson, honorable members, and all other members and officials present in the platform. Yes, I will take you through the National Department of Health performance, that is the funding, as well as annual performance plans. So as a start, this is just the mandate of Department of Health, which is to lead and coordinate health services to promote the health for all people through an accessible, caring, and high-quality health system based on the primary healthcare approach by setting out the responsibilities of the 3 levels of government in the provision of health services. This acknowledges that the health services is relevant or could be performed by different levels of government, not only one national government. And then key to highlight that there are a number of programs that are being used by the vote or the department to fulfill its mandate, and there's 6 of those. Also, it is important to note that in fulfilling that mandate, these resources are allocated through these different programs, and they are in the form of conditional grants, and then some are just direct funding. Then now, what we found, if you look at the budget, is that the largest percentage of resources are allocated through conditional grants, with a spending of, for example, 2025-26 conditional grants were up to 93%, close to 93% of total funding, and then this shows just a slight decrease of 1% if you compare this allocation of conditional grants to the last year, 2024, which was 94%. And then we have noted that there are also several entities that are also important in the sector, which will also be discussed and elaborated on later on. Slide 9 here, it shows the budget and deviations, that is 2023 and 24 versus 2020-24, and the 2025 budget, as we've seen, as presented. Key to note here is that allocation for the health vote has been revised up. If you look at what was happening before, that is 2024 division of revenue, it has been increased by 1.7% in 2025 budget, from 63.7 billion to 64.8 billion in 2025. And then, as we've indicated, there's an increase of 1.7%. This increase is mainly to support the employment and medical doctors, increasing availability of medical supplies, and preparatory work of the NHI. As the President indicated earlier on in State of National Address, that there's a lot of work that has to be done for preparation of the NHI, and this is again is in line with what the Commission recommended in its submission for dividend of revenue for 2021-22. This graph, what we see here is that previously in 2022-23 and 2023-24, we've seen that there's been a decrease in the allocation. And then now this 1.7% that we're talking about here, 2025-26, follows those decreases that we've seen before. And the budget deviation here, what we are saying here, we are just trying to show the performance, how the all programs were performing in 2023-24 financial year. So key to note here is that there's been an overall underperformance across all these across all these programs in the 2023-24 financial year. For example, you will see here the overall performance was, if you look at the bottom blue bar, was 3%. That was underspending of 3%. And then you see that overall, all these programs were underspending. For example, administration underspent by 15%, national health insurance by 7%. But here, what we see is that going forward for 2025-26, we see some minor adjustments that have been made. For example, the overall adjustments is, you can see here the orange bar where we are. And then this is against, which is 1.7%, is against this underspending that has been happening in previous years. Here, this deviation, this slide is on the deviation, budget deviation by program. And then again, it just shows what has been happening. You see the primary by program now, the primary healthcare program, is 0.6% for, that is the difference between 2024. Here we're comparing what was allocated in the MTF 2024 and 2025. And then you see the adjustment here. The difference now is the orange bar. You see adjustment here is 0.5%. And then you see there's been minor adjustments on all these programs for 2025-26. This slide just shows some of the annual performance plans, the targets that have been set by program. Key to note here, though I'm not going to go through all these annual performance plans. On administration, for example, this is the annual performance plan. It's just to strengthen the financial management, to improve efficiency. And then the aim here, or the goal, is to obtain unqualified audit. And then again, there's a target for improving employment equity and workforce skill development. That's program one. On NHI, one of the targets that have been set by department is to establish an accreditation framework for healthcare providers. And then to set up again, which is one of the most important things that the Commission has also made a recommendation on, or submission or recommendation on, is to set up that electronic medical record information, which is key for the implementation of the NHI. On communicable, non-communicable diseases, and then the most important thing here is to revise the ARV treatment guidelines, and also to implement the TB program, and then HPV screening, improving the psychiatric hospital. On primary healthcare is to improve public healthcare facility quality standards by expanding facilities. And then ward-based primary healthcare output teams that will be conducted, and then conducting assessment focusing on improving water, sanitation, waste management, and food services. Those are just some of the targets that we decided to put on. And then now, going deeper to the economic classification, we've seen that there's been a 1% adjustment that is an increase for 2025-26 budget. And then now going now through the economic classification, where is that money added or Then what we see here is that firstly, we thought that the commission is important just to go back and see how this program or how the spending has been in the past, and then compare to what now is being allocated, whether is it in line with the spending program, the spending, historical spending performance, or is not in line with. And then here, what we see is that what we are saying is that the commission knows the budget response and planning is inconsistent, for example, with the spending, underspending of 3% that we've shown. So that 1.7% that we've seen, we're saying is consistent with that underperformance that we've seen of 3%. Again, drilling to the compensation of employees, it shows that there's been consistent underspending in the program with 10%. You see here is 10% admin compensation of employees, 10% underspending. And we see the adjustment here, the orange bar, that it has been adjusted it has been reduced by 0.5%. And then we're saying, no, this is in line with the spending performance. And across all these, that's what we see. But again, key to note here is the performance with respect or allocation with respect to the payment for capital. What we see there, we see a significant upward adjustment for capital assets. And then this upward adjustment is for buildings and other fixed structures. So here, with respect to headcounts, the budget reduces the total planned, that is 2025 budget. What we see is the reduction for the headcount for 2025 by 12.1%. That is 127 personnel compared to the 2024 budget. Primarily, what we see here is a significant downward revision is in the levels of 13, as you can see here in the graph, by 29.7%, levels of 13 to 16. This indicates a planned reduction in the specialized professional positions. Again, what we see here is total cost of personnel post-field for 2025-26 budget has been revised up by 2.3% relative to the 2024 baseline for the same financial fiscal year. This is driven by an upward revision in salaries for level 7 to 10 and level 11 to 12. This suggests that the Accounting Commission suggests reprioritization towards the middle level and senior management roles. Then lastly, the Commission supports here, knows, acknowledges, and supports, because the Commission has realized that the department earlier on has announced that a 1.778 billion will be allocated for the creation of 1,750 new healthcare positions. This includes doctors, nurses, and some other healthcare workers. And then Commission appreciates this because it's so important. We've seen that there's been a gap between the medical doctors that we need, the country needs, and nurses that are needed, particularly for the preparations of the NHI. Then we need these specialized personnel. Then the Commission supports that. With respect to conditional grants, there are a few conditional grants that are being implemented by the department. The first one that we'll talk to is the district health program, which has two components. Has a component of the HIV/AIDS and has a component of district health component. And then here, what we see is that the total allocation is 28.3 billion, which is allocated through this grant, of which 24.9 billion is for HIV, and then the 3.41 billion is for the district health. And then here, what you can see in terms of these changes, you can see that there's been some changes across in all provinces, but those changes are not significant. They are just minor. They are all below 0.6%. The next grant that we did analysis on is the Human Resources and Training Grant, which also has two components. And then there's a training component fund, and then there's the statutory human resource component. And then a total of 5.6 billion is allocated for human resource and training grant for the 2025-26 financial year, of which 2.6 billion is allocated towards the statutory human resource component, and 3 billion is allocated towards the training component. And then again, looking across the provinces, what we see here is that there's been an average growth of 2% in 2025-26 for all provinces, if you compare the 2024 baseline budget and then 2025 one. And then key to note here is that the Northern Cape province has the largest growth of 3.2%. As you can see here is the largest, followed by the Northwest and then Eastern Cape, whereas Gauteng is one with the least growth. The other grant is the National Tertiary Services Grant. Again, comparing the budget allocations between 2024 and 2025, what we see here is that this grant, there's been some changes in the 2025 budget. For example, you see the Northwest has received a significant growth, followed by the Eastern Cape, and then the average, followed by Limpopo and the Eastern Cape. Average growth for this grant is 5.8%. And then this growth that we see here is because of the allocation that was not allocated in the previous MTF, which has been allocated now. Hence, we have this growth. And then this is the National Health Insurance Conditional Grant. What we see again here is that there's been adjustments to all provinces for 2025, 2026, and then 2026, 2027. We see that there's been growth across all provinces for this grant. And then this is mainly to prepare to complete the preparatory work that is needed to implement the national health insurance. I think later on in the presentation, analysis will be done on the performance of national health insurance, comparing both the direct and indirect conditional grants. On that note, Chairperson, through you, let me hand over to the next presenter. Thanks.
Good morning, Chair. Good morning, Chairperson and honorable members. I will be taking you through this part of the presentation that focuses on entities, looking specifically at their budget and performance indicators. However, what is important to note is that only 6 health entities were selected for this analysis based on their relativity and contribution towards the medium-term development plan outcome on improved access to affordable and quality healthcare. On the other hand, it is also important for us to highlight that the data on the performance of these entities, of these selected entities, centers around the critical performance targets that are aimed at improving access to affordable and quality healthcare in South Africa. Next slide, please. Next slide, please. So basically here, looking at the financial performance, the analysis presented on this slide shows us that the South African Medical the Medical Research Council budget allocation saw the largest increase of 22.4% for the 2025-26 budget year compared to what was estimated in the 2024 budget. Therefore, this exposes inconsistencies in the National Treasury's budget allocation over the medium-term expenditure framework. In addition to what we have seen, we also see from the analysis that the National Health Laboratory Service will see an upward revision of 0.4% in the 2025-26 relative to 2025-26 relative to what was outlined in the 2024 budget. This reflects the entity's commitment to its 2025-26 annual performance plan of expanding services to priority programs such as HIV and TB care. So what we lastly perceive on this analysis is that the 2025 budget deviation for the 2025-26 fiscal year compared to the 2024 budget amounts to a 9% increase in the allocation to the South African Health Products Regulatory Authority, and with a further 11.3% increase estimated for 2026-27. Next slide, please. So here in the next few slides, we hone in on the non-financial performance of these entities. So we begin with the Council for Medical Schemes. So considering key regulatory outcomes of this entity, the results show a decline in performance between 2021-22 and 2025-26, particularly in terms of processing amendments of interim rules, accreditation of broker applications, and the implementation of governance interventions. Next slide, please. So for Mine Works and Compensation Fund, the results further portray a steady decline in the number of controlled mines that have been inspected yearly since 2021-22, and some decline in the number of claims that are finalized, particularly since 2022-23. This further aligns with projections that the claims will decrease due to the declining rate of tuberculosis incidents and an increase in the dust control measures that are implemented in mines. Next slide, please. With regards to the National Health Laboratory Service, the selected indicators show high levels of performance in some targets since 2021-22, with about 88% or more of the entity's targets for HIV, TB, and cervical testing being achieved. Moreover, it is also perceived that blood alcohol testing performance has shown a dramatic improvement since 2021-22, which may indicate improved skills and capacity in this area. Next slide, please. In terms of the Office of Health Standard Compliance, we also note that performance has consistently improved in the recent years, particularly in certification enforcement, showing in 2021-22. However, of great concern to the Commission is the underperformance of compliance inspectorate program that achieved at most 21% of the entity's targets across both public and private health institutions. Next slide, please. So finally, the Commission commends the South African Health Product Regulatory Authority's improvement concerning evaluation and registration targets, showing signs of increasing efficiency in some key performance areas. However, the Commission believes that there is substantial scope for improvement in licensing practices and detecting safety signals in clinical trials, as both data and performance in these activities are lacking. This brings me to the end of this section, Honorable Chair, and I would like to hand over through you, Chair, to my colleague Gianni to continue with the rest of the presentation. Thank you.
Thank you very much, honourable members and chairperson. With your permission, I'll take you through the next section, which focuses on NHI. On the following slide, just to end off the entities, the South African Medical Research Council is responsible for the health and quality of life, primarily through research and development. This is its core mandate. The Commission would like to note that it is worrying that research outputs were estimated to decline in the 2024-25 fiscal year compared to the previous year, as this could signify underperformance of its core function. However, research outputs are expected to improve somewhat for the 2025-26 fiscal year, which appears to be somewhat aligned to the increase in the budget allocation when you compare the 2024 budget allocation to the 2025 budget allocation for the 2025-26 fiscal year. On the following slide, I will take you through the NHI, and as was acknowledged at the outset of this presentation, South Africa's health sector is characterized by significant disparities in access to healthcare. In order to address these disparities, the government has decided to use the National Health Insurance, or NHI, as a vehicle to achieve universal health coverage in South Africa. And this essentially seeks to ensure that every member of the population has access to essential and quality healthcare services, regardless of their income level and regardless of their geographic location. However, the Commission does note that the NHI will require significant reforms in the healthcare sector, and these include, amongst others, investment in infrastructure, human resources, as well as systems and technology. On the following slide, the Commission looks at the various funding and implementation of the NHI, specifically with regard to conditional grants. So the NHI will be phased in using both direct and indirect conditional grants. The direct NHI conditional grant is comprised of the National Health Insurance Grant, and this seeks to expand the healthcare service benefits through the strategic purchasing from healthcare providers. On the other hand, there are three indirect components. The indirect NHI component includes both personal and non-personal services, and here the personal services component aims to expand the access to healthcare service benefits through the strategic purchasing of primary healthcare providers. And here, the focus area, the priority areas include oncology, mental health, GP contracting, HR capacitation, and contracting of health professionals. Now, the non-personal services component aims to develop and roll out new health information systems to enable the health sector to address deficiencies in primary healthcare facilities in a systematic manner. And here, priorities include medical stock and patient information systems. Then the further indirect component is the Health Facilities Revitalization Grant, which not only aims to improve spending and performance, but also monitoring, evaluation, and preparation for infrastructure development in the NHI to strengthen infrastructure delivery. So here on this slide, the Commission compared spending performance, emphasizing the performance of direct NHI grants against the indirect components. And what is crucial to point out here is that the figure illustrates the Commission finds that the direct NHI grant has performed consistently better than the indirect component. So the figure here illustrates the proportion of each grant that was spent in a given fiscal year, with data spanning from 2018-19 to 2023-24 as a percentage. So there's been underspending, for instance, in the personal and non-personal indirect component, and severe underperformance in spending in certain years for the Health Facility Revitalization Grant, whereas the NHI direct component has seen 100%, near 100%, or 100% performance in the NHI direct grant in terms of spending. Honourable members and Chairperson, with your permission, I'll hand over to the Chairperson of the FFC to take you through the recommendations. Thank you very much.
Thank you so much, Gianni. With regards to the health entities, the Commission notes that significant deviations in the budgeted allocation for some of the entities without explanation. So there has been some deviations. So this creates a degree of uncertainty, which may undermine the credibility of the National Treasury's spending estimations and policy priorities over the next 3 years. The Commission therefore recommends that spending allocations be closely linked to the entity's performance outcomes. The Commission also recommends that budget allocations to entities be aligned with their core mandates, as well as with the government's policy priorities, which should be made clear and transparent. Furthermore, the Commission notes the lack of data on performance outcomes in certain entities, such as the Health Products Regulatory Authority, and recommends that data collection and management be strengthened across all entities, as this is crucial for enhancing transparency and improving service delivery. Next slide. With respect to the NHI, the Commission is of the view that an integrated national information system of patient and doctor registries with real-time data will be necessary for operationalizing the NHI, informing healthcare financing and provisioning decisions using a demand-based costing methodology. The Commission therefore reiterates the need for the development and implementation of a single electronic system that includes live health record information, as the Commission recommended in its submission for the 2021-22 Division of Revenue, as well again on the 2025-26 Division of Revenue. This was also reiterated by President Ramaphosa in his State of the Nation address. The Commission also recommends that National Treasury review the funding framework of the NHI and ensure that all funding allocated under the National Health Insurance Program is for activities and infrastructure directly related to the program. In terms of healthcare efficiency, the Commission urges the Minister of Health to prioritize maintaining and improving the quality of healthcare in existing public hospital systems through reprioritization of resources and funds to achieve allocative efficiency, as we have recommended as a Commission in our 2025-26 Division of Revenue submission. The Commission further recommends that the Minister, together with the provincial departments of health, strengthen accountability mechanism in public hospitals and provide guidelines to improve management practices and enhance transparency. This brings us, honorable members and chairperson, to the end of our presentation. Thank you so much. Over to you, Chair.
Yes, Dr. Mbava and your team, wonderful presentation. Some of us would have expected that your last recommendation should have been the first one. The attitude of staff in our public hospitals, and maybe even in private, but public mainly. You know, there are certain individuals who do a job, both public and private. They have a very good smile and a good attitude when they work in the private sector. But when they do moonlighting, but when they go back to their original workplace, which is public hospitals, their attitude suddenly switches off. So those are real challenges that I'm glad you are recommending. I've seen hands. The first one is Honorable Clerk. Let me just see and put my Honorable Clerk, you're number one. Let me prepare members that when you come to the next presentation, Honorable Van Staden, if he has questions for the second presentation of Minds and Works, he will be number one, so that you can allow him to leave at 12. Here I'm seeing the order of Honorable Clerk, followed by Honorable Dr. Leroux, followed by Honorable Dr. Letlape. Let me see if I see other hands. For the fourth one, Honorable Kleko. Fifth hand is that one of Honorable. No. Please rename your gadget Zoom user. We will not recognize a Zoom user. Please get your name well. For now, we are a Zoom user according to my slot, and we'll give you a name. Please rename your gadget. If you need assistance, somebody should assist you there, who you are. Number one, Honorable Clark, followed by Honorable Dr. Leroux. Third one, Honorable Dr. Letlhapa. Fourth would be Honorable Dr. Honorable Tembel Amxheko. There's someone who insists to be in here because he's a Zoom user. I need to know before I give that person the slot after Honorable Xheko. And those are the hands I have for now. Start, Honorable Clark.
Thank you, Chairperson, and good morning to everybody. Thank you for the presentation. I always enjoy listening to this presentation because it really advises us of, where things are having to be improved in terms of our system. So the following questions to the FFC. In the FFC's opinion, why has investment in public healthcare failed to give optimal results? Apart from investing more money and other solutions or recommendations, do the FFC have to optimize public health investment, and what would be the results? What is the reason for the department's underspending? Regarding the planned reduction in specialized professional positions on page 14, what positions are being scaled back? How many of those positions, the reasons for this, and what would be the impact in terms of service delivery in terms of those positions? The 466 million for NHI, what is the specific breakdown for that? Does the FFC have an explanation of the OHSC only achieving 21% in its compliance inspectorate program? And I'm just wondering, Chairperson, if this is got to do with the self-assessment system that's been put in place as well, if we could just get clarity on that. And then regarding the FFC's recommendations that the Minister reprioritize resources and funds and strengthening of accountability mechanisms, has the FFC reached out to the Minister and the provinces regarding the recommendations, and how will the FCC hold them accountable for these implementations? Now, also they gave us a whole range of key performances that are expected in terms of the NHI. And I would also just like to know if there are any timeframes that are being put in terms of those key performances that were presented to us, because there's nothing on the presentation. And just in terms of the information system, Chairperson, for a fact, we have visited a range of hospitals, and I've also done so in my own capacity with my colleague, and every hospital we go to, the information systems are still not in place. So that seems to be a real problem, that public hospitals are not getting their act together in order to get those information systems on track. And then the last one is, how's the recommendations that you've put forward monitored in line with consequence management and your recommendations from Treasury in terms of the review funding of the NHI? Thank you very much.
Thank you, Chair. Is it okay if I go next?
Yes, Dr. Leroux, go ahead. Thank you.
Thank you very much for the presentation to all the presenters. I just have a few questions and one or two comments. I think perhaps the first thing in terms of a comment is just if both for me, and I'm a medical doctor, but I still found some of the language quite financial and quite jargony. And I would just request that perhaps in future presentations we could remember that the members of the public that are listening to this, as well as the members of the Portfolio Committee, are not necessarily kind of in understanding the jargon. And I'd like to ask that perhaps the presenter who spoke about the separating equilibrium could just explain that a bit more in detail for us to understand what that exactly means. Also, just in terms of the on the slides, there were quite a few slides where they spoke about the difference between actual and main, but I didn't actually know what that meant. What are they talking about, actual and main? And then they compared that to the budgets that was allocated. And if I could also just ask that would be clarified. Then in terms of the presentation and the recommendations, I would like to just echo the question of my colleague around the allocation, significant decrease in senior staff and the allocation of slightly more junior levels of staff. I recognize that some of that has been happening in the appointment of quite a lot of doctors in the last month or so, since that allocation has been given to try and absorb nearly 1,200 doctors. And I just wanted to get the Commission's perspectives on that. From my perspective as someone who's worked in the public sector for a long time, I'm concerned that we're getting a whole lot of junior staff in without adequate supervision, and it is concerning to me that we are losing senior staff. What was the Commission's findings along the senior staff, that allocation and significant decrease in that, and what are the thoughts around that? Because if we don't have senior staff supervising and supporting and teaching junior staff, we are not going to get the specialists of the future or adequately skilled specialists of the future. And I think that this idea that doctors, as soon as they kind of come out of finish their ComServe, are the complete kind of article is not true, and we need to be aware of that as both as this portfolio committee, but also as the Commission. So just wanted your perspectives on that. Then I get also in terms of the electronic records, I mean I think that the recommendation that you make is a very, very ambitious recommendation that the whole country should be on one live system. And I wanted to ask, I mean, I think that, of course, we've been asking for electronic systems and better electronic systems for a long time now. But I also think it's important that we recognize that to have a live system like that is being recommended would be extremely challenging and extremely expensive to look at. And I don't know if the Commission has looked at other countries that have managed to do this on a national basis, and whether there's any recommendations that can ask about that. But I think that we do need to think about that very carefully, because that is an incredibly, I think, challenging recommendation to put in place for a national system that is live. And perhaps we should be thinking of starting it in a stepwise fashion. Finally, the last recommendation in terms of improving efficiency in healthcare, again, it's fairly unspecific. The Commission urges Minister of Health to prioritise maintaining and improving the quality of healthcare in existing hospitals through reprioritisation of resources. Could I get a little bit more understanding of what exactly you're asking for that? In the second last recommendation on your list of recommendations, what do you mean by that? And have you got specific things that you feel the Department of Health should do in that way? That's all from me. Thank you very much, Chair.
Thank you, sir. Honorable Dr. Litlape.
Thank you, Chair. To start by saying, I guess the person that can be recognized is Honorable Mutubatse. He's just sent a message. He's having problems identifying himself on the gadget. My questions go back to just some basic understanding. When we talk about the Department of Health being able to set out the responsibilities of the three levels of government in terms of the provisions of health services, what do we mean? And the certain responsibilities that are conferred on provinces by the Constitution. Because one of the problems that is coming up is the fact that you can't have a national anything, national health insurance, national this, if health is not a national competence. And what is the Commission's view on that? Because part of the problem is that when it comes to certain things, the Department of Health can't get people to account because they say it's their own responsibility. If I give you an example, with this money that has been made available to employ 1,200 doctors and 200 nurses, the proportions of which are an enigma for me, because we need more nurses than doctors. But be that as it may, at the National Health Council, the minister is pleading with the provinces and the MECs to use the money for the purpose that it is intended for. But he's aware that they can use it for anything they want to, and there's nothing that he can do. How do we change that? I hear a lot about most of the budget being a conditional grant, but when it gets to provinces, it can be used in any way the provinces deem fit. If it is a conditional grant, are the different amounts attached to different line items? For example, so much for laboratory services, so much for human resources. And if it's money for human resources, is it broken down according to money for frontline, money for managers? I hear a lot about preparatory work for NHI, a commission recommendation from 2021 to 2022. And concerned about the fact that the budget seems to have gone down, and even with the 1.7% increase in this period, it seems not to take us back to the levels of the budget of 3 years ago. Just a comment on that. And we talk about an NHI underspend of minus 7.6. But we have no money to employ healthcare professionals. One of the issues that comes up out of your presentation is the fact that it looks like the emphasis of the NHI is to bring in the private sector. We talk a lot about outsourcing of services like oncology, mental health, GP services. You go to Charlotte Makake, it's an absolute disaster. Money has been taken back to Treasury for oncology services. We are destroying the capability inside the public sector. And I'm just concerned about the fact that we don't seem to use this as an ability to rebuild the public healthcare system. Any system that wants to offer what we want to offer, universal quality healthcare, has to be largely dependent on employed healthcare professionals, not contracted outside providers. I'm not saying the contracted outside providers don't have a role to play, but that can't be the key focus of how you want to build a national health system. And I'm concerned about ignoring the public healthcare system. Instead of rebuilding the public healthcare system, making it the place of choice for healthcare professionals for employment, we don't seem to be going that way. We seem to improve our capability for contracting with private providers. Now, on what Dr. Leroux has raised about the integrated national information system, it is key. And contrary to what he says, it's a key factor to an efficient system, and it can be done. Many people have done it. You know, we've done it in the banking sector. All of us carry multiple banking cards. But anywhere you go, people are able to know what your balance is. And when you want to withdraw money and you don't have money, you are told that, hey, Baba, there's no money. You know, contact your branch. So that thing can be done. But it can't be done in isolation. It has to be part of the security system in the country. You go to other countries, every citizen is issued with a card from birth to grave, cradle to grave. You're given a card and it picks up all your information system, and anywhere you interact with the healthcare system, people have your healthcare information on tap. It is not impossible, but it requires to be done as a national competence. And just for information, if you did an assessment of how much we've spent in national and in the 9 provinces in the last 30 years on information systems, you will be horrified. Now, I wonder, and maybe you could explain to me, because when I hear about NHI, it's about a term where we're trying to fix the public healthcare system. But the emphasis on what divides us is that it seems to concentrate on funding instead of just being truthful about, can we fix the public healthcare system? Lastly, Chair, I want to go back to the beginning to hear from the Fiscal Commission. When Section 27 talks about available resources, is Section 27 open to separateness, where you have a private system and a public system? Or does it talking about one nation, one health system? And the promises of Section 27 of the Constitution, are they to any human being that breathes on our soil? Or are those promises to citizens? Because if the promises are open-ended like the Freedom Charter, then this is not doable. Nothing is doable in this country unless we talk about citizenry and services to citizens and all citizens being in one pot. So that when you build a public healthcare system, all of us as citizens, irrespective of our levels of poverty or abundance of resources, we need to be able to depend on what the state can provide. So the state can't be providing to the poor, and the state officials for their own healthcare go elsewhere. So I just want a view from the Fiscal Commission on those issues about within available resources and the two-tier system and how that is going to work. Because if it becomes the undertone, it means even your NHI will be undermined by the two-tier system. As you've heard, a lot of people are saying, leave what we have alone, go fix it for the poor. So I need to hear from the Fiscal Commission around that issue that poses a problem for us as South Africans. Thank you, Chair.
Dr. Letlape, we have taken 6 minutes.
Only. I've saved the other 6 for the others, Chair.
Let us be rational and allow others to get some time on to get asked questions. Honorable Keko.
Thank you, Honorable Chairperson. Good morning to the honorable members and also the members and the presenters of FFC. I have some comments and also questions to raise, Chair, to the Commission. My apologies that you are not seeing me. I have just moved out of my house to get a better connection. Chair, the weather is bad on my side. Chairperson, I note and appreciate the presentation by the Commission. We usually get their informed position on issues, but I just want to check from them how they view the implementation of their recommendations by the department and also by provinces. Also, Chair, that they have also noted the importance of a better information management system. I like that because it's what we also recommended as this portfolio committee to recommend to our hospitals and other health institutions to better manage their information, given that the electronic systems becomes the best, and we appreciate those establishments that have started on that system. But on that issue, I think we thought alike, Chairperson. I wanted also to have a question around the issue of, because they talked also about entities. How do they view the funding of research in South Africa, given the fact that most institutions that are doing research are sometimes funded by donors outside the country, Do they not see the risk? What is their recommendation regarding that? We are still to have that entity that is on research, but I need to get it from them. And also, Chair, I want to hear them to have a say around the issue of the budget that has been presented with its with the adjustments that are there. How do they see that budget meeting the demand on infrastructural needs, service delivery, including the ones talked about shortage of health professionals? My last point, Chair, is to get their view on the increase of VAT versus decrease of that VAT, given that some of us would think that the increase was to have a budget that meets the demand. But I just want to get it from the Commission, how they view that increase versus the decrease in VAT now. Thank you very much, Chairperson. Those are the issues that I wanted to raise. Thank you very much.
The last member who has identified himself now as a Zoom user is Honorable Mutubatse. Your opportunity now.
No, thanks. Thanks very much, Chair. And my apology for. Can you hear me?
Yes.
Hello. Oh no, thanks very much, Chair. And my apology for the earlier mishap. I think it has been fixed. Just one or two questions. Just to the Commission, how serious that does the department or the other entities, do you think they take your recommendation? I think historically, even now, do they take them serious? Do they implement them? And what is your view on their attitude towards your recommendation? Secondly, I haven't heard you speaking to the provinces in terms of the accruals. Accruals by nature would be budgeting on something that you don't have. What impact does that have on the service delivery? And what would be your recommendation on how to circumvent that situation? You spoke to the digitization of the health system. Do you think there's any recommendation that you can do, because this has a serious impact on the implementation of the NHI? What is your recommendation on what can that be done so that there's a swift flow in terms of the implementation of NHI? Thank you, Chairperson.
Thank you very much, honorable members. Just to add on, starting with Honorable Dr. Leroux, he raised the issue of the difficulty with the slides. I also saw a bit of a difficulty with their slides, whether main or real. But anyway, nevertheless, I'll ask around those slides. With regards to one slide that shows 15% underspending of admin, did you interrogate what does that mean? We just summarize it that way. Number two, you seem to be concerned about the South African Medical Research Council, probably that was raised by Mr. Malungane, yes, saying probably they are actually budgeting much more than they used to do in the previous years. Would you not probably be saying they were influenced by what one honorable member is asked here, that there may be a shrinking budget coming in from other sources and therefore have to rely on National Treasury putting more? I don't know whether that is a reflection of that already. Did you interrogate a bit on the underperformance of Office of the Health Standard Compliance? Is it the capacity the finances, what could be the reasons thereof? I cannot emphasize more the issue that has been raised both by Honorable Motubatsi and also Honorable Dr. Leroux, electronic systems. I'm glad that the Department of Health is here listening. That you, in your view, this could undermine and delay the full implementation of NHI if you have records that are not properly accounted for. And so, what is? Are you able to raise this, or you are raising it with us with the hope that you will raise it with the department, or you also find space to raise this with the department yourself? Please assist us with the responses. If you go beyond the 11:05, I will have to stop you. Thank you very much.
Thank you so much, Chairperson. Let me appreciate the questions. Before I answer some of the questions, I try to check if Commissioner Fowler, if he's got any comments on his side.
Thank you, Chair. Just a one comment on the question of the private healthcare spend versus the public healthcare spend. The private healthcare spend in South Africa tends to be very high. It's dropped from what it was previously. It was around 80%. I believe now it's probably around 50 to 60% is spent on 20% of the population. And the public healthcare spend is the difference between the two, which means that that's spent on 80% of the population, somewhere in the range of 50% or even less is spent on the public sector. So the solution to that is to really get more private spend in public hospitals to ensure that that happens. And the Charlotte Maxeke Hospital had a section on the top floor which was really catered for private sector users to ensure that some of that private sector money goes into the public sector. But with the NHI, that would then resolve many of those issues. The question remains then, is the efficiency of the spend to ensure that you get the best results. Just to note that the private sector spend in South Africa is 6 times the amount spent in the European Union on public healthcare. Thank you, Chair.
Thank you so much, Commissioner Fowler. Honorable members, just on the issue with regards to the recommendations of the Financial and Fiscal Commission and how these recommendations are processed. In terms of the procedure, the process, the recommendations of the Financial and Fiscal Commission are made to Parliament and to the provincial legislatures. The recommendations are made to members of Parliament to assist members of Parliament with their oversight responsibilities. The Financial and Fiscal Commission cannot hold accountable members of the executive because the Financial and Fiscal Commission reports and works with the legislatures. Therefore, it is incumbent upon the members of this committee to hold the Department of Health and its entities accountable for the implementations of the recommendations of the Financial and Fiscal Commission. That's how it works. It's for members of Parliament themselves to receive the recommendations of the FFC, use that as part of their oversight tools to hold the executive accountable. So we are informing you, we are empowering you to use the information we are giving you to hold the executive accountable. It's not for the FFC to go over and above the legislature directly and hold the minister, because the minister is not accountable to the FFC. The minister is accountable to the legislature, which is Parliament. The minister therefore will respond on our recommendations through the legislature. That is the process. I would like now to ask the head of research and his team to answer some of the questions, please, the technical ones. Oh, before that, before you answer, Chen, members, we note some of the issues you've raised with regards to some of the jargon, maybe with the way we write, because remember we are researchers, so sometimes these things are an afterthought. So we take that into account to write in a way that is more clearer and simple for the public. Thank you so much, Honorable Leroux, for that. And maybe also when we explain the data and the numbers, we'll try to be more specific and more granular without actually losing the essence of what we're trying to communicate. Thank you so much. Chen, over to you.
Thank you very much, Chairperson, and thank you again to Honourable Chair, Dr. Chair, and Honourable members for the questions. First thing is that the moonlighting, as you, Honourable Dr. Chair, put it, is well and can be then identified and addressed in terms of how a NHI digital system of both the doctor or health professional side and patient side coming together, because through this data and information system, one should be able to identify if those doctors are moonlighting and double dipping, and also to look at their productivity in those two different sectors. And at some point through the data, there will be evidence that we will that can be addressed through reprioritizing, or actually, in fact, legislates a limitations on a doctor's, say, availability to one or the other sector, in order to ensure a fair and equitable distribution, and ultimately their capabilities of time and efforts. So just to quickly come forward, though, just not to lose the point on the benefits and why the information system is so very much key to the system of NHI, is that, and as earlier Honourable, I think it was Lape said quite correctly, it is implemented quite widely across the world, except to different extents. But those countries that have all implemented NHI, they all have it. They must have it, in fact. And if they make good use of it, they were able to identify and narrow down and optimize the returns on the investments or the funding to those functions. They're even able to use the database to see what are the prevalence, those high risk diseases or treatments that's required for public. And in so doing, that's the reprioritization and the efficiency, the effectiveness of investment and use can be implemented. Places like Taiwan has, of course, the national health insurance, and so everybody gets a card. It's basically like your ID card that will load all of the treatments, the doctors that you have seen, and all the what are the ailments. You're basically, as you put it, Honourable Member, it's like put it so correctly. Instead of doctors, or when we step into a hospital, seeing a new doctor, and then there has to be another 30 minutes of consultation, immediately everything is already loaded onto the screen to show the patient history. And not to mention as well that for patients, it also saves a lot of time and information inaccuracies, right? And I'm sure our Honourable Dr. Chair and also other medical doctors on the floor would agree that that is one of probably the most severe risks to diagnostic errors. is to not have that information accuracy. And so that is the information aspects, information system aspects to it. I want to also quickly jump to the points about the technical side on the separating equilibrium and addressing the. So maybe to put it this way is that the separating equilibrium is basically that a market that has operates in two different price points effectively, and with different price points, two separate price points for a single service. Ultimately, it means that those that are at the, say, higher cost ends are not getting, obviously, the optimal cost efficient services. And then on the lower end, they may not get the quality of services. And so what that means is it's losses to both sides of this price point, right? So in fact, for example, if I go buy a McDonald's meal, and then if I have to spend 200 Rand on the same meal as opposed to 50 Rand on the meal, there's a question about what, you know, that's where is that maybe 150 Rand dollar meal, and the price difference there is cost to both sides of these markets. That's why we call it in economics separating equilibrium. And what that also, as I emphasized in the beginning, is that in the health sector, it means information loss. It means efficiency loss, because information is money and time is money, and all the other costs is, of course, money as well. So all of these things becomes inefficiencies in the healthcare markets as a whole. Actually made, just to help honorable members, is that actual is basically how much is spent. And maybe to also to help is from in the word main or budgets or any other kinds of, say, medium-term estimates and so forth. At the end of the day, it's just an estimated amount of money that is yet to be spent or yet to be collected. And so in actual fact, one would understand from a financial and fiscal point of view is that you have to know or look at what you actually spent in order to decide or use that information to inform on how you will budget better. And what does it mean? It means that to come up with an estimate that is closer to the actual, that will become real in due course when you either spend or collect. Just maybe on that same point, very poignant by Honorable Tembaland, apologies for the pronunciation, is that the VAT increase will impact the entire sector of health, because and this, of course, the medical doctors would know this very well, in the health sector, of course, all instruments, all needles, all products, even the consultation times and services, emergency services, everything will come under this VAT increase. There's no exemption. There is no zero rates on healthcare service. And in fact, it's one of the core, we call it the core inflationary items, especially for the poor, because of course they have much smaller budgets to work with. And so whatever spending pressures that you put on.
With 3 minutes. The team is left with 3 minutes collectively to respond.
Understood, Dr. Chair. And so in effect, it's not just that, it's also in terms of the VAT increase, it will also affect, because we're thinking hospitals here to provide services. So all electricity, water, sanitation, refuse, everything will come under effect of this VAT increase. I want to also say that in terms of the NHI is not exactly to contract in the health private sector. The point here is to actually improve the efficiency of the public sector healthcare in order to make it more accessible. And then I'll come to the Section 27 the points about the accessibility of the healthcare sector. Is that in fact, private sector is not in itself efficient in a way, right? Because in terms of costs, it may not be efficient. And all of the underutilizations of it, say whether it be emergency room sitting empty or a doctor's time sitting empty because the cost is too high, so there are not enough patients able to access it. And so there is an opportunity for the two markets to merge. And to merge it, as I said, is, as our research showed, is to have an information system that can basically bond these two markets together. Section 27 does allow for both private and public sectors to exist, because the key word here is the provision and accessibility of healthcare. That is universal. It means that if you are in need of healthcare, there will be the service and provision for you to access it. Whether affordability question, that's the other matter. And so in this sense, public sector is basically the universal healthcare services provision for that purpose in terms of the Section 27. So a very good question, perhaps on this directional point is to improve public sector healthcare system, as Honorable Dr. Chair already said, is to improve that to a point where it will be able to accommodate the general public at the universal level. Honorable Dr. Chair, I know that we are on very tight timelines, and also with the extensive questions that have been received, perhaps we would be able to respond in writing after this briefing. I hope I've covered most and all key points of the questions asked.
Thank you so much to FFC researchers. Chairperson, I think we have on our side exhausted the questions, and if there's anything that we have missed, members are more than welcome to write to us, and then we can respond in writing. But we thank you so much for the opportunity to provide our analysis on the health sector. Thank you, Chair.
Thank you, Dr. Mbava. The most important thing that you said after your presentation and responses and all that is to say, committee members, we give you these recommendations for you as our sort of advice to use them in your oversight. So I hope that honorable members are really picking up that, say they've done some work for us, interrogating annual performance plans of entities and also of the department. They are making these recommendations for us to take forward and engage. That is why on the last day of this week, we will then be meeting with the minister and his team to deal with these things. We really want to thank you very much. They were very clear. Here and there, you had to tweak them and explain some of them, but we understood them well. And I would really say we endorse a lot of them. You have really introspected them very deeply. Please continue supporting us like this in future, because we really appreciative of this. I was really glad with your emphasis to say these are recommendations you make to us for us to use them as and when we wish to do that when we meet the Department of Health. With that, thank you very much. I know you have quite a lot of other things to do. We'll then release you, and thank you very much with your whole team and other commissioners who are here supporting us with this input. If there are any other outstanding matters, honorable members, we are free to really follow up with Ms. Majalamba for the Financial and Fiscal Commission to assist us with the responses further. Thank you very much. You are now released.
Thank you, Chair.
Yes. Honorable members, do stretch a bit, and I would really want allow Dr. Kisnasamy to put his presentation so that we don't go through that hiccup as we start, because the next will just be in the next 4 minutes. Start with them, grab a cup of tea, water, and then stretch a bit and then come back So my work is now 11:04. At 11:08, we should be ready with the presentation already projected to start. Thank you very much.
Chair, is it being shown?
Dr. Barry, indeed, it's visible, thank you, but it's not in presentation mode.
Okay, I hope we're not going to have this problem again. I've gone on to, let me see.
Oh, you want to start a meeting, Dr. Kisnasamy?
No, Chair, I'm just checking my slides. It's always a problem with the slide sharing and when it goes on to presentation mode. So it might be that I'll have to make that small and continue without presentation mode. I don't know what goes on with Zoom on our inputs. We do apologize to the chair. Is it on presentation mode? Okay, I'm gonna have to. Yeah, okay. Let me just swap. Okay, bye.
While Dr. Kisnasamy is doing those final touches on his presentation, let me welcome him. He comes from Mines and Works Compensation Fund. He has recruited quite a lot of people. He has invited quite a big number of citizens to be here. Some of them are coming in from outside our country. Welcome to those leaders who are coming in from Stop TB in Geneva. Honorable members, you might have been aware that I was actually invited to go to Stop TB programs in Africa, and we were welcomed by Stop. It was actually organized by Stop TB in Geneva, and some of them have been a part of this meeting, but they're very keen to see what is South Africa doing, especially when there was quite a lot of TB that came from TB mines, from our mines, and actually affected citizens, not only just of South Africa, but of the SADC area. There are some members who log in here who come from such councils in Mozambique and also Eswatini. There's leadership from the trade unions that is logged in here. There's REN Mutual that are part of this, professional societies. There's risk committees of these countries I've mentioned. Academic institutions, some of them are logged in here. Mineral Council, and mining companies representative are also logged in here. But all of them for us to participate by listening, and Dr. Kisnasam will then take us forward in the presentation. Over to you, Dr. Kisnasam. You might add some of or two of those that I might not have known they are coming to join us that have since joined. Over to you. Present not more than 40 minutes so that we can then engage with you. I know we are quite fast. Combine your presentations in less than 40 minutes. Thank you.
Thanks, Chair. It says host has disabled screen sharing.
We can see you. We can't see your presentation. We can see you where you are with your gadgets hanging over your ears. Let's see your presentation now.
Chair, I need screen sharing rights.
You have the screen sharing rights, Dr. Kisnasam. Which gadget are you using? I've given you co-hosting rights on both of your gadgets. Thank you.
All right. Thank you. That's appreciated. Thanks, Chair. Let me just go on to
Slideshow.
Slideshow. Is that showing now, Chair?
Yes, going well. Thank you.
All right.
Slide number 1
Good.
on the screen.
Good morning, Chairperson, members of the Portfolio Committee, and colleagues, and also thanks, Chair, for acknowledging the role of many of the stakeholders and role players who work with us. This is a very important program, both nationally, across borders, and also internationally. As you mentioned, the Stop TB Partnership and the work that's being done with TB in the mining sector. Just by way of the legal framework is ODIMWA is the framework in which the MBOD and CCOD and the Mines and Works Compensation Fund works. And that sets up the framework for the delivery of compensation services for current and ex-mine workers. Of course, the legislation goes back to 1912, but we'll discuss that later. There's the preventive aspects is actually dealt with through the through the Minerals and Petroleum Resources Department, which is the Mine Health and Safety Act, which looks at the occupational exposure limits and sets up the framework for occupational lung diseases and prevention of injuries. And then the compensation for other diseases and injuries other than the occupational lung disease under the Department of Employment and Labor. And one of the issues, Chair, was a joint portfolio meeting at some stage, which I'd requested of the Portfolio Committee on Health, and hopefully that will take place sometime this year. The legal status, the fund itself is listed as a 3A public entity. And unfortunately, the MBOD and CCOD are still directorates within the Department of Health. And part of the legal reform process is to take the MBOD, CCOD, and the fund into a Section 3A entity. We've mentioned this before, but for any new members, we provide the medical assessments. The MBOD stands for the Medical Bureau, and the Compensation Commissioner is the CCOD. So we provide the medical assessments for mine workers and ex-mine workers. We certify the claims. We make the payments for an eligible occupational lung disease, and we collect revenue for the fund. Just our update, we've paid out about 2 billion rand to claimants over the last 9 years. And I covered the last 9 years because that was since the major reforms took place under the new management that was brought in by Minister Motsoaledi. And Chair, you'll recall this both in your previous terms as Chair of the Portfolio Committee, as well as the Deputy Minister of Health, for the major inputs that we've made to the delivery of services to current and ex-mine workers with respect to occupational lung diseases. We finalized about 60% of the claims over the last 9 years. We've had unqualified audits since 2021-22. Members of the Portfolio Committee who have been here for some time would recall the disclaimers prior to 2012. We've grown the fund from 2.8 billion to 5.9 billion, despite the payments. And we have an active research program bringing science to bear, particularly on aspects of computer-aided diagnosis for chest x-rays, especially TB and silicosis. And we're working with that with Stop TB and the academic partners. Now, the strategic outcomes is finalizing the legislative reforms, and hopefully, Chair, we will bring that back to your committee later this year after it's gone through the State Law Advisor and the Cabinet process, because this is very important. And we have members of the mining companies, the Minerals Council, and the trade unions who are very keen to see the legislative reforms becoming part of the new Act. And then just the maintenance issues with the CCOD in terms of medical examinations, certifications, and payments of claims, collections of levies, and inspections. Just in terms of the new bill, just to remind members, it will repeal the Occupational Disease in Mines and Works Act, which goes back to 1973, but its base was 1912. So it's overall about 113 years old, this legislation that covers occupational lung diseases. It sets up a new governance structure called the Mines and Works Compensation Authority. It registers all controlled mines and works, and we'll talk a bit more about that later on. The levy that will be, we have currently a voluntary levy from the mining companies, but this will now change to a statutory levy to cover administration, medical assessments, healthcare, and social protection benefits. It introduces the limitation of liability, hence future class actions will be very limited in terms of this process, because the current Act did not have the limitation of liability as it is in the Quida Act, under the Department of Employment and Labor. And we are told by Treasury that we should have a separate monies bill because we collect levies. Just in terms of some updates, the Risk Committee used to be a problematic structural governance structure within the MBOD CCOD. It's now fully functional. Our control mines list is 876. That's the master list. But we have 232 active mines and works as at 31st March. The Risk Committee was very functional, so there were 16 new mines and works controlled in the 24-25 financial year, and an additional 23 mines and works went through the process in the 24-25 financial year, but will be gazetted with effect from the 1st of May. Just in terms of the outcomes for the strategic plan, members will note the decline in terms of the numbers over the 5-year strategic plan period. And there is reasoning for that, which I'll come to in a minute. So the baseline 14,000 and then going to 5,000. Number of claims finalized to 2,200. Number of benefit payments made by the fund 2,000. Number of control mines 95 from 108. And we have a new indicator on revenue generation where 90% of the levies will be collected in terms of the mines and works that are controlled. Auditor General would ask about the 100%, but there are small quarries, 3-4 member quarries, and we have raised the issue that we'll try as much as possible to look at the bigger funds. Now, the reason for the declines is firstly, Chair, through your committee and through the political inputs by the Minister, Deputy Minister, and work on TB in the mines, particularly in SANAC. You just mentioned the Stop TB partnership. We must emphasize that occupational lung disease declined drastically in the mining sector, and this is the preventive aspects. As we mentioned, compensation is a last resort, and the fact that the occupational lung diseases are coming down drastically shows the very important inputs on legislative inspection and enforcement inputs that are done by the Department of Mineral Resources and Mineral and Petroleum Resources. And this is very important. In fact, the last Mine and Health and Safety Summit last year in October actually brought the occupational exposure limit even further down to 0.3 milligrams per cubic meter for silica dust. So the social conditions of single-sex hostels with multiple beds, etc., the TB interventions, the ARV interventions, and the dust control interventions have proven a lot in terms of decreasing occupational lung disease, and hence our 5-year MTF projections in terms of the strategic plan are for downward notifications in terms of occupational lung diseases. The other issue is the mining sector is contracting, or alternatively, more technology is being used in the mining sector, which is also leading to a reduction. Problems we've had, Chair, in terms of challenges. We've had problems in terms of internet, water supply, electricity supply issues, and we've gone for 2 years now, unresolved issue with public works and infrastructure, and it might be that we would call on the although the minister has written to the Minister of Public Works and Infrastructure, this is still unresolved. This building is approximately 80 years old, and basically significant condemnation from the Department of Employment and Labor, and this might be the other portfolio committee that you might want to call on in terms of the issues that we are having with delivery of services. Very importantly is Minerals Council funding, voluntary support of approximately 70 million per annum, which has really turned around the MBOD-CCOD, and we want to acknowledge the members that are present here together with the Rand Mutual, who have given us a lot of support. We've had multiple consultative workshops on legal reform, and we are hoping that this becomes part of the parliamentary calendar for this year. And then the financial, technical, and human resources, which we are very much dependent on at the senior technical levels, who are funded from the Minerals Council. So the partnerships I just want to acknowledge, Chair, overall is the ex-mine worker associations. They are present here today. The trade unions in the mines and work sector, Rand Mutual Assurance, Minerals Council, provincial and neighboring country governments, who you have recognized as well, Shea Miso Trust, which paid out 2 billion Rand to 20,000 claimants over the last 3 years, and continuing to do some excellent work in terms of social justice, banks and social partners. And I'll talk a bit more about the data exchanges that we're doing with the banks and social partners such as SASA in the APP. Academic programs in a very rich research program, which is bringing science to bear on the work of the MBOD-CCOD, University of British Columbia in Canada, Cape Town and Witwatersrand, and recently Eduardo Mondlane in Mozambique, and of course the SOP-TB partnership. Chair, that's the end of the SP. I'm going to go on to the APP, if you'll allow it. Over.
Dr. Kisna-Same, okay. Right.
Is the APP showing on slideshow, on slide presentation?
Yes.
Okay, thanks. Thanks, Chair. So the APP is a bit longer. I'll hopefully make it within the time you've allotted me. So the highlights is that we are up to date with our annual reports. Again, this was part of the disclaimers historically and the unqualified processes, because we were seeking permission each time from your committee for non-submission of the annual reports. The business processes shows the performance improvements, notwithstanding the unqualified reports in terms of certifications, claims, total paid, and total certifications for the year. We are very much an online system now, and we have an individual mine worker lookup tool called the xmineworker.com site. But we do recognize that many of the mine workers don't have access to the internet and data, but this is a lookup tool now, which is individually based. We then have where organizations, ex-mine worker associations, constituency officers, etc., could use the minersbenefit.com tool, which then gives you access, won't tell you amounts, but will tell you whether a mine worker or an ex-mine worker has a benefit. And this is the most recent, Chair, that in the last financial year, we rolled out a similar system to SARS e-filing for collection of revenue, where it's an online tool. A control mines and works registered with us fills in the assessments based on levy shifts. The invoice is generated automatically, and within 5 minutes later, you press a button and payments are made to the Mines and Works Compensation Fund. So really must thank, with support of Minerals Council, South Africa, we've developed many of these tools, and the digitization project of our records was done with the input of Rand Mutual. And as members will know, we have an online claims management system called the CCMS. The Risk Committee, we've introduced a new risk determination methodology, which was gazetted with effect from 1st April 2025. We do pay pensions. There's about 20 left, and Mr. Masongani will talk to that later on in the financials, and that's in line with state grants. And then we've increased the benefits tremendously in terms of quantification of the individual benefits, 91,000 from 76,000 and 200,000 from 170,000. And this has been partly because of good actuarial valuation reports that we've actually managed to increase the benefits. This is the personnel category. We still have in the lower categories vacancies, but the bulk of the personnel are actually below level 7, mainly administrative. And if were it not for the funding from Minerals Council, we would not be able to have a lot of the technical and senior professional resources provided for the fund to run a 5.9 billion rand fund. This gives you some examples of certifications per month. The blue is this year, the last financial year, compared to the previous financial year in terms of the process. So that shows the improvements on certifications, the improvements on payments, claims certified over a time period from 2015, and this was the period during COVID, but we've more or less reached pre-COVID levels in terms of certifications, thanks to Dr. Bachali and Dr. Rabada and the team of certification doctors. The claims finalized and payments shows the real amount increase, both quantitatively, which has remained virtually static, but the fact that we've now increased the amount has shown the figures that have gone up considerably in terms of new claims finalized. And I'll apologize to members of the Portfolio Committee. We had noted that we had left out 2 slides which related to certifications, claims paid, and claims value. This helps Portfolio Committee members and probably NCOP members, which shows the details in terms of provinces like the Eastern Cape, that we certifications between 2024 and 2023. And you can see the numbers declining in terms of certifications, and that was the earlier point I made. Claims paid, because we are also reaching out to tracking and tracing activities in terms of additional claims paid in terms of colleagues. So, for example, 2,076, but and that's partly through the outreach activities. Free State, we had some outreach activities last year, and Mpumalanga outreach activities as well. And then the claims paid value in terms of 151 million to the Eastern Cape, for example, last year. Free State, 67 million, Northwest, 39 million. So despite some setbacks with outreach activities, because that's an unfunded mandate, we're still managing to keep up the good work of reaching out to ex-mine workers. This is the revenue slide. We had a major revenue collection correction through the actuarial valuation in 2018, and you can see gold virtually declined by 50% and has remained virtually stable. So notwithstanding this decline in levy payments to the Mines and Works Compensation Fund, we still grew the fund considerably from the 2.8 billion in 2012 to 5.9 billion currently, notwithstanding this correction of the levies. I'm going to hand over to Kerat, my colleague, Chair, through you, to take us forward on the financial performance of the fund. Kerat, through the Chair.
Thank you, Dr. Kisnasamy, and good morning to the Chair and honourable members. Looking at the financial performance for the period up to the current year of 24-25, you can see that the levy revenue has decreased in line with what Dr. Kisnasamy has just elaborated to, with reductions of levies. So from 130 million in the 22 year down to 105 million in the current year. On the next line there, the interest income, you can see that the increase in the interest rates following COVID has actually, our interest income has more than doubled from the 208 million initially to where we're now at 476 million.
Chair, somebody is not muted.
Mr. David Makanda, please mute your phone. Go ahead.
Thank you very much, Chair. The transfers relates to the pensions, and there, as Dr. Kisnasamy indicated, there we've got a reduction because of natural attrition. This is from the previous Act, from 466,000 now down to 167,000. The movement provision, that is, as our provision has been decreasing in the last 3 years, we've had that movement through the income statement as an income. And I think the expenses, the majority of the expenses, of course, relate to the unwinding adjustment on the provision. And I think everybody quite happy to see our surpluses in excess of 150 through to 220, with two large years in between. Thank you, Dr. Barry. Next slide. In terms of the balance sheet, there's 3 items that I want to highlight here. I think firstly, the investments, how we've grown it from 5 billion rand fund now to virtually 6 billion, 5.9 billion at the end of March. And then if we look below the line, we can see the accumulated surplus, which basically shows the net asset position of the fund, almost doubled from 1.6 billion in 2022, now at just over 3 billion in 24-25. The provisions, as I mentioned to you earlier, slight reductions, and it seems to have now stabilized around the 2.8 billion rand mark. Thank you, Dr. Kisnasamy. Back to you.
Okay, thanks. The provisions, Chair, relate to the payments that we make for the compensation claims. Thanks, Kerat. So the focus areas for the annual performance plan would be the maintenance of the activities through the collection of levies, certifications, and payments of claims. And essentially, this gives us the figures. I'd given the overall targets in the strategic plan over the 5-year period, but this tells us the period for next year. And I'd given some of the explanations for the declines that we are expecting. So this is certifications going down to 9,000. Claims finalized to 5,500 from 6,203. And we are going through the audit right now, but we have met all targets for this year. But Auditor General will be auditing our figures, and that will be presented then in the annual report. So claims finalized, then the number of benefit payments made, 5,000. Number of controls, mines, and works inspected, 85. And the percentage of levies received from control, mines, and works, 85% to be stabilized for next year. So again, this will go through the audit by the Auditor General. I'm going to hand back to Kerat, through you, Chair, for the financial performance in terms of the MTEF. Kerat?
Thank you, Dr. Kisnasamy. So just looking at over the MTF period, the tax levies, we are increasing the levies slightly through at an inflationary adjustment over the period from the current 105 through to eventual 123 million in the outer year. The interest rates, the members might notice that it's sort of hovering around the same 470, 460 million. Even though the investment is growing, we anticipate a slight decrease in interest rates over this period, hence why it seems to have stabilized around that number. The other income number, it's a once-off Section 74 income that we received. That's already, actually, I can confirm that was received in April this year, with regards to uncontrolled mines whose levies we could not get, and then we were able to get that Section 74 income from the department. Transfers, we've alluded to that earlier, and we can see the decreases going further in the outer years. The expenses for budget purposes, we do anticipate a slight increase in the provision over this period. So the expenses indicate a movement in provision as well as the unwinding charge, but still every year profitable over the MTF period. Next slide, please, Dr. Barry. Again, for the balance sheet, I'm going to focus again on the three main items of the fund. The investments, we are looking to see in the outer year very close to 7 billion from the current 5.9 billion. That is despite all the payments and the increase in payments that we expect over this period. And then again, below the line, the accumulated surplus, which shows the net asset position from the current 3 billion to the outer year of 3.5 billion, with provisions, as I indicated or mentioned, we anticipate a slight increase from the 2.8 billion in the current year through to 3.3 billion in the outer year. But overall, the fund total asset position to reach the 7 billion mark for the first time in the 27-28 year. Thank you, Dr. Kisnasamy. Chair.
Chair, it shows that we very much a going concern, but of course, I'm going to discuss later on the unpaid claims, because that's an issue in terms of it. So in terms of working with other departments, the provincial departments of health and neighboring country governments, and the chair will recall that unfortunately we slowed down a bit in terms of neighboring countries, but we did spend some time in terms of outreach activities with the provinces, which I'll mention. Working quite closely with the trade unions in mines and work sector, and many of them are present, including the trade union federations at this meeting today. Minerals Council South Africa and Rand Mutual, the Shemiso Trust, the ex-mine worker associations, and the mining companies. Chair, this is still a major issue for us of the unpaid claims, which I had mentioned before to the portfolio committee, currently amounting to 1.3 billion. So we have the money, but we can't track and trace the individuals. And although we have tried desperately, but the main issue is that 66,000 claims are before the year 2005. And this is really a problem because very little records were kept by the mining companies. Because of the migrant labor system, ex-mine workers went back to places like the Eastern Cape, Lesotho, Mozambique, etc. And that's one of the big issues that we have in terms of the data sharing. One of the issues with the Mineral and Petroleum Resources Department is to get hold of clinical records so that we can actually do some work on closure of these files. You can see since 2012, when the new management came into being, we virtually have no backlogs in terms of unpaid claims. So we've tried as much as possible to stick to the 3-month rule of month 1 lodgement of a claim, month 2 certification of claim, and month 3 payment of a claim. This is unpaid claims and value by provinces and selected countries. Again, this is an additional slide to the portfolio committee, and we do apologize. We thought this was very important to bring to account. So overall, there are 7,800 claims that are unpaid in South Africa. We don't know where in South Africa, amounting to about 200 million rand. We've got names in terms of the unknown category of 36,500, amounting to 800 million. And this is the substantive work that we have to do still in terms of saying that here's a claim registered, it is a compensable claim, but how do we pay it? Eastern Cape, 7,500, 123 million. Free State, 2,273 million, 74 million. Gauteng, 1,600. We currently have an outreach program in the West Rand, 47 million. KZN, etc., Northwest 4,800, approximately 100 million unpaid. So this might be of interest to portfolio committee members, but we are trying to do our best in terms of reaching that process. So the first issue was back office data sources, and we've had tremendous success, which led to more payments through working through the health facility system within the Department of Health, and then working through the major banks. We do have a guidance note from the POPI regulator, information regulator, for exchange of data. And we've done very well in terms of matching records. Most recently was the, we also are linking up with Home Affairs. We've just signed a memorandum of understanding with Home Affairs, and we'll bring that into us. But you can see that we've worked through many of these social protection funds and the banks, and has actually done tremendous yield. So that's a back office exchange. Front office, we go to do physical tracking and tracing. We go on outreach activities. This is in March this year, which is now continuing into April and May, led by the MEC for Health in Gauteng, where we've gone to 5 districts in Gauteng. This is funded by the Minerals Council and the Provincial Department of Health support. And we've had some success with lodgement of claims, paid out about 800,000 rands. And these were registrations that we are still going through in terms of the process. And then some of these registrations of living mine workers will now be assessed for a benefit medical examination coming up in May. We are preparing for a BME process in the West Rand. This is the examples of outreaches last year in October in Mpumalanga and Free State, where we paid out 168 claims in Free State, noting this is mainly gold mining, and that's the big difference between gold mining and coal mining, which is mainly in Mpumalanga, and the small numbers paid out in Mpumalanga and paid out. So this is physical outreach that we do in terms of reaching out to our people on the ground. The call center is the other input that we take.
Go back to a previous slide.
Sorry, Dr. Dlomo?
Go back to a previous slide.
Go back to the previous slides.
That slide is showing that you were there in Free State in October 2025.
Oh, yeah, that was an error which I hadn't corrected. I do apologize. Thanks for picking that up, Dr. Dlomo. It's actually October 2024 and November, December 2024. Apologies to the members and to yourself. Thanks for noting that. But these were the outreaches that took place last year, and currently in March 2025 to May 2025 will be the outreach in the West Rand. But I will make this correction on the slides. The inbound calls, the call center support, where ex-mine workers or current mine workers or beneficiaries can call in on a share call system. And also the call center also tries to complete packs online and then sends them to the CCOD for payment. So the 3 areas are background data exchange, background call center support, and physical service delivery, where we go on outreach issues. These are unfunded mandates, unfortunately, but we are trying to reach out to some provinces. And we also have a program later this year, which we will inform the members of the portfolio committee through your office chair in terms of whether members would want to visit an outreach. I'm going to hand over to Mr. Masongani in terms of the voted funds. This is the monies that we get through Parliament, through the Ministry of Health and the Department of Health in terms of paying for the services, my salary and the staff at the MBOD CCOD, excluding the inputs from the Minerals Council South Africa. Mr. Masongani, through the chair.
Good morning, Honorable Chair, Honorable committee members and colleagues. So I'll be presenting the voted funds budget for the year ended 31 March 2025. So actually, these are funds allocated by the National Department of Health to MBOD for day-to-day running of the office. So under compensation of employees, we were allocated a budget of 37.5 million rands, out of which we spent 36 million rands, which is 96% spending, which resulted to 1.5 million underspending. So the underspending was due to vacant posts that were not filled by year-end, pending the final approval of the Department of Public Service and Administration. So under goods and services, we were allocated 21.9 million rands, out of which we spent 19.7 million rands, which is 90% spending, resulting to 2.2 million rands underspending. So the underspending was attributable to almost 1 million rands audit fee saving for the 2023-2024 audit year. And also the other reason for that underspending was 1 million rand that we budgeted for forensic investigations that we could not spend by year end due to procurement processes which were still underway, and that has overlapped to the new financial year. So under transfers, we were allocated 4.4 million rands. So that comprised of 1.8 million rand for payment of monthly pensions. So the monthly pensions, we pay them due to the old Act provisions. So currently we are left with 16 pensioners. So as the years goes by, that provision decreases. So the other 2.6 million rand was a recovery for revenue loss in terms of ODIMA Act Section 74A. So all those funds were transferred to CCOD for utilization. So under capital expenditure, we were allocated a budget of 6.4 million rands, out of which we managed to spend 359,000, which is 6% spending, resulting to 6 million underspending. So that underspending is attributable to the delay in procurement processes. So we were in the process of procuring office furniture, office equipment, and other essential equipment. So by year end, we couldn't finalize those processes. So that resulted to that significant underspending. So all those procurement processes have overlapped to the new financial year. So overall, we were allocated a total budget of 70.5 million rands, out of which we managed to spend 60.6 million rands, which is 86% spending, resulting to 14% underspending. So the reasons are just what I've just indicated above. So next, okay. So the next slide is about the voted funds budget for the MTF period. So that is covering 3 years from 2025-2026 financial year to 2027-2028 financial year. So for the current financial year, which is 2025-2026, we have been allocated by a total budget of 70.2 million rands. And then in the next financial year, 2026-2027, we are expecting to be allocated 74.2 million rands, which will increase to 82.7 million rands in the outer year of 2027-2028 financial year. Thank you, and over to Dr. Berry for conclusion.
Thanks, Chair. The last 2 minutes that I have, just to acknowledge again the Minerals Council South Africa and Rand Mutual Assurance. We are working with the State Attorney's Office for recovery of funds where we have bad debts. Now that we've got a proper register of control mines and works and going the legal process to recover funds. We have ongoing training of health professionals in the mining sector as well as the non-mining sector in the provinces so that they can recognize and pick up occupational lung diseases and note how to refer them to the MBOD CCOD. Then we are working with the multiple stakeholders, role players and partners, and appreciate what they do to enhance the services and operations of the MBOD CCOD. And we have an active research program. Just to note, the support of the Deputy Minister and Minister of Health, the Director General and Executive Managers, and multiple clusters at the National Department of Health. We're working with the Department of Mineral and Petroleum Resources and Employment and Labour, provincial and local governments and neighbouring country governments. Minerals Council, South Africa, Rand Mutual, the mining companies, many of them are present here, trade unions, pension and provident funds, and social partners such as I've mentioned before, SASA, the financial institutions. We have members of the Audit and Risk Advisory and Risk Committee present, and their input has been invaluable in guiding us in governance. Thanks to the MWCF staff and the seconded professional and technical personnel, especially the teams in finance, information technology, and the MBOD through Dr. Rabada and Dr. Michali, the Deputy Commissioner, Ms. Mama. Thanks to the parliamentary liaison team, Mr. Cutler has been ever willing to support us. We've had some errors and mistakes, and he's tried to correct them. And of course, the Secretariat from your office, Chair, Ms. Majalamba. And lastly, thanks to you and the members for allowing us this opportunity to make the input on the SP and the APP for the compensation, the Mines and Works Compensation Fund. Thanks, Chair. Over. I think I've kept to my time.
Yes, Dr. Kisnasamy, you tried. Thank you very much with those little bit of glitches, but you kept to your time. It's very interesting listening to your presentations, and there are some members here, portfolio committee members, who have a special interest on this program. Some of them, we've really called them ex-mine workers, honorable members. They just love to listen to this. We want to actually express our thanks to the Mineral Council of South Africa, Rand Mutual, and I think mining companies for not only continuing to support this program going forward, but also for upgrading your systems, making sure that a mine worker recruited this year is much more different than a mine worker recruited in 1965 in terms of the care, in terms of the health programs and assessments and regularity of those programs. We wish that to keep to that and really make sure we don't go back to, and the mistakes of the past can really assist us not to repeat them. So we would really, and thank you to all those. There are some members here in this platform, citizens of the world, who are here keenly listening to what are we going to do going forward in terms of caring for a former mine worker who's today not really receiving what is due to him or his family and is already passed on. How can we accelerate this process while we are moving on managing? I had promised that I was going to start with Honorable Van Staden, because at 12 o'clock, he has to shift to another program. We'll be enriched by your questions, Honorable Van Staden. We'll get responses later, but even if they give it to us, we would have gained from your knowledge. So the first member will be Honorable Van Staden, followed by Honorable Clark. The third will Honorable Dr. Leroux. Fourth, Honorable Mutubatsi. Let me scroll again and see if there are any. Those are the 4 hands I've seen so far. Any other member I have not seen on the system, and do you want to speak? Okay, let's start with Honorable Van Staden, then you can ask and leave because your time is really running out now. Please, we'll welcome you back. Your meeting and lunch, and come back at 2 if you can. Thank you very much. Honorable Van Staden.
Thank you, Chairperson. I only have one question, and it's regarding the unpaid claims, which is coming before 2005. I just want to find out if there's a certain cut-off period for this, or is the claims are just put in the databases and the money put aside for if it's sometimes in future you find the claimant to pay out the money. I just want to get clarity on how do you go around that in the administrative process regarding that, because I'm of a point of view you can't bank money forever in the hope that the claimant comes forward eventually. So if you understand what I'm trying to say, I just want to know that how you're going around that and how you administratively handle that outstanding claims, which is for such a long period of time, to see to it. But if a claimant comes forward eventually, but the money gets paid to that claimant. Chairperson, thank you I will leave now, but I will be back as soon as possible and I will join the meeting then again. Thank you.
Don't leave, Honorable Van Staden. Dr. Kislasamy, please, in the next 3 minutes, try and respond to this question. He can benefit from your response at least, yeah. Please, Dr. Kislasamy.
Thanks, Chair. Honorable Van Staden, no, the claims are not prescribed. So we are holding the monies, and I pointed out 1.3 billion is now currently still sitting in our bank account. So as soon as we find the individual or a beneficiary, we can also pay the beneficiary of the individual, but it's quite a long process in terms of traditional marriage certificates, children, etc. But it's not prescribed. And I thought your second issue was related to VAT or tax issues, but I might be mistaken. But the only VAT will be on bank charges. But these are not costs that are accrued by the individual. We cover those costs in terms of the administration of the fund. It's covered from the fund itself in terms of the administration of the fund. But the claim is not prescribed. So there's no time period. If we can pick up a claim from 1965, we can still pay the individual or the beneficiary. I hope that helps, Honorable Van Staden. Thanks, Chair.
Thank you, Chairperson. No, it helps. Thank you very much.
Okay, thank you very much, Dr. Honorable Van Staden and Honorable Dr. Perry Kislasamy. Let us then follow up with Honorable Clark, who will be number 2, followed by Honorable Dr. Leroux. The 4th hand is that of Honorable Motubatsi. 5th is Honorable Teko. Let me see if there's another hand. I don't see any other hand yet. Okay, let's go with those now. If there's any other one that will come in, Honorable Clark, followed by Honorable Dr. Leroux, Honorable Motubatsi, and Honorable Teko 5. Thank you.
Thank you, Chairperson, and thank you for the presentation. And being a member of this committee for some time now, I must say we've seen a huge improvement in terms of, systems that were implemented in terms of mine workers. And that is very reassuring, to know that we have proper systems in place when it comes to this issue. And there's just a couple of questions I'd like to ask, and some of them are clarity-seeking questions as well. I just wanted to find out, when you do testing for TB, do you automatically test for HIV as well? Just a clarity on that. And when we speak about track and tracing, I remember when the Honourable Dr. Tembakwaya was on this committee, she always mentioned that maybe you should also use the system of the IEC to try and track and trace. I don't know if you have ever taken that suggestion on board. And then if you could just let me know what succession plans are in place and what exists in terms of filling your key positions when need be. And then in terms of the average claim that is submitted, what time frame period does it take to pay those claims out, and what bottlenecks do exist if so? And then also, what strategies have been put in place to improve the levy collection? I mean, you have given some explanation, but is there any strategy in place? And then also, have you looked at any best practices from similar compensation systems, how to evaluate and to adopt some potential change? Thank you very much.
Thank you. Honorable Dr. Leroux.
Thank you, Chairperson, and thank you to Dr. Kislasamy for his presentation, and yes, and to his team. I think I would like to echo my colleagues' sentiments that it is very positive to see good systems being put in place, and also positive audit outcomes over the last few years. And so I want to compliment Dr. Kislasamy and his team on that. I just wanted to ask a few questions just around the fund, and I mean, and the large amount of money that is available in that fund. I mean, I see. So perhaps one practical question was just, and I know that we did mention this last year when we spoke, and I just need to be perhaps reminded. But in terms of just the practical process, if we can just be walked through what happens if somebody. So I understand there's 60,000 people that have already been assessed, and that particularly from before 2005, who have been seen or been assessed as qualifying for compensation, but we haven't been able to find them or to get the money out to them. So if I understand that correctly, and that is about a 1.3 billion rand kind of that we are holding aside for those 60,000 people. But in terms of please tell me if that is correct. But then secondly, I mean, if people now present to a hospital and they are a mine worker, could it be helpful to understand the process if a doctor suspects that there's an issue, or there's at the mine worker's office there's an issue with the patient's lungs, and how does that process work? How do they get assessed? So where do they have to go? And I understand that you said it should take about 3 months, but what exactly is the process for that? We spoke about those who have already been assessed, and we sort of, there's about, if I remember it correctly, between 5,000 and 6,000 people that get assessed and paid out every year now that the system is working well. But have we got any idea of any estimates of how many people are out there that actually haven't been assessed, or that we think have got mine-related lung injuries that are sort of out there but haven't benefited from this, or haven't been seen and haven't got to you yet? So what number of people do we think might be out there? Then in terms of just there was one of the slides showed how there has been a decrease in sort of number of people claiming, but also in sort of, it seems like the measures that are being put in place are helpful. How many of those, how much of that decrease is, do we know, can we estimate how much of that decrease is because we're not finding people? And then it would be helpful to know, we spoke about decreased particles allowed in the mines, in the air. So it would just be helpful. I'd be very interested in hearing what things around TB prevention have been put in place. Have we put people on TB preventative treatment? How have we managed in terms of TB, in terms of kind of environmental or working conditions, et cetera, et cetera? If that it would be helpful to understand that a little bit better. And then I think finally, just again, I'd like to be reminded, but my understanding was that the money in the fund can only be used to be paid out to people, but aren't being used for the running, and that is why the Department of Health, the government is allocating about 70 million rands a year to the team. I wanted to find out, is there anything that we could do legislatively that would allow for some of that 7 billion rands to be used to run the fund, instead of it needing to come from the public purse, as it were? And secondly, with the fund growing so significantly, I mean, at this stage, if we've got 60,000 people who haven't paid out, and it's 1.3 billion, I mean, at this stage, it seems like this fund is going to go on forever. Is it not maybe time to bring down the levies a little bit for the under pressure mining sector? Or is that fund being kept there to try and find those people who are not being found? But it just seems like at this stage, if it's nearly 600,000 or nearly 1 million people that we'd have to find to pay out to the fund, and are we ever going to find them? And is this fund not just going to get bigger and bigger and bigger and bigger without actually benefiting, everybody that needs to be benefited? So I hope that makes sense as a question. But is there any way also legislatively that we could allow for perhaps for some of those funds to be used to run the fund and to do the outreaches, et cetera, that would help for us to get more people paid out? Thank you very much.
Honorable Mutubatsi, thank you very much.
No, thanks very much, Chair, for the opportunity, and I welcome the presentation made by the team. Just 2 questions. Are there any dates or outreach programs for the mining areas in the Northwest and maybe to the other provinces? In particular Northwest, because Northwest is the mining area, Rustenburg and the Klerksdorp area. Secondly, with the recently launched TB program by the Department of Health in respect of the 5 million target to look out for those people and with their families, are you aware of that? And surely you are aware. But what is the collaboration between yourself and the department in making sure that or supporting the success of the campaign in respect of TB program? Thanks very much.
Honorable Keko, come through. Thank you.
Thank you, Chair.
You notice that there's
Good.
another hand after you, Honorable Dr. Lechape. Okay.
Okay, noted, Chair. Thank you. Let me acknowledge also the presentation by the fund administrators as led by the good doctor. I think, Chair, our appreciation goes to them in lessening the number of those that stand to benefit. But Chair, I have some questions to ask regarding what they have just raised with us regarding a building that has been disqualified by the Department of Labor. My question is, were they bringing that to us just as information, or are they seeking our advice, or just wanting us to say yes or no, okaying the process? What has been the procedure regarding that? Do they have a risk strategy that may be talking to that? I think as a portfolio committee, ours is to just note what have they brought to us regarding the building, but not taking the committee to the issues of procurement and whatever. That's another process for them as administrators. But it's good to know so that we follow up the process. If there is any wrongdoing, we are able to hold them accountable for those wrongdoings. But it's good to note. I wanted to check whether there are any means by them to get those that they are tracing. The track and tracing, I think it's a difficult process. I liked what they have just brought to us to say some of the claimants or some of the beneficiaries of the fund are people that do not have access to internet and whatever process, because if you can remember, the ex-mine workers were those that were coming from far provinces outside those mining areas. What I wanted to bring to the attention of the meeting as an advice to them is that can't they also approach Home Affairs when they are doing the track and tracing? The advice that was brought by the former member of this portfolio committee is another strategy to trace. Home Affairs is also an important stakeholder to this exercise. You'll remember, Chair, that in some of the cultures, you can't say this is the real spouse. It's even difficult for you to say, I am the legitimate spouse to the one who is ought to benefit. So that is why I am saying Home Affairs, it must also be brought to book regarding what they are tracking and tracing. Also a suggestion that is there no means that they can also approach local radio stations, because what you say in the radio gets a lot of coverage. So that is another way to them to go quickly reaching out outside the normal arrangement of having an outreach program, which is sometimes costly and time consuming. I wanted to bring that attention to their attention, Chairperson. Thank you. And also the issue of assessment. It's good that the fund also covers the current mine workers, not the ex, but also the current, so that everyone who has been working in mines understand that he or she stands to benefit. But at whose cost is the assessment? Is it the department or are there service providers privately that they are using? I just wanted to ask those few questions. Thank you very much.
Last, Honorable Dr. Letlhapa.
Thank you, Chair. My question is just in relation to the people that have submitted claims that have not been paid. What effort is being put so that those claims can be paid without saying don't verify, don't check out fraud? Do we have people that go out to try and help to finalize the claims, or is it up to the claimants to prove their bona fides and we give them reasons why we are not going to pay and they must meet them? I don't know if that question is clear, Chair, as to whether we're really assisting those that have claimed to be able to pay, so that the attitude of the fund would be to pay where possible and not to try not to pay where possible. I hope you don't work like medical aids. Thank you, Chair.
No, mine, thank you very much. Mine will really paint a scenario, Dr. Kisnasamy, that is actually very emotional. You know, I started grade 1 in 1965. Now, in 1965, there could have been a mine worker who was already working, probably 30 years old. That mine worker is now 90 years. If having been exposed to mining, that person is long dead with the silica dust and other things. And therefore, there's a battle for his family to really be getting what is due to them. And you are right, your systems are allowing that if there's legitimate spouse, trace all that, but they have to prove that that father was working in Carltonville, then you end up paying. But really, how long is this piece of string? Why can't we come to an end of determination? I hear you can always extend and extend, but you know, when you listen to those who have been paid, they give a story that this gives a bit of respect within my household, that our father once worked in the mines. Here we see the fruit of that. For that family, for that 90-year-old who's long dead, and the families are still struggling to get to what is happening. I mean, this is an average of all those 2,000, whether they're sitting in Shai, they are sitting in Libode, they are in the Northwest or in Botswana, everywhere. How do we, don't you think we need to really have an imbizo that comes to final determination that what resources do we need to put in place to trace them and track them and get them to submit documents and get them paid off, and once off and we are done with this? You can't have a person who was working 60 years ago, family has not been able to trace, the person is long dead, the person is about to die, because there's an average, but some of them who are younger than that are dying also. They're struggling to get this payment. That is, we don't want to undermine the effort that we have done, but what we have done is good, but not good enough, because there's still a lot of people out there, especially those that we now know that has to be paid, we don't know where they are, but there are those who have not even submitted their claims and they are legitimately to submit and be paid. Now, it's a really very, and I can tell you to this, honorable members, was I was once involved with this process somehow. A 200,000 to a family makes a big living. Some of the people have been saying, I got 200,000 from the payment. It was good enough because it allowed me to refurbish my house. It then allowed me, it left me with about 50,000. I bought goats, and those goats are in my yard. And every 4 months, there's a new offspring from the goats, and I can make life going on. So I'm not rich, but I'm not extremely poor. I'm fine. I'm managing life. It's a legacy for having worked in the mines. Now, this issue, Dr. Kisnasamy, is a real sore point. Now, to be associated with it, all of us in various forms, and we really can't find a final solution to this matter, is a real great concern to some of us. Let us give you back, and then those who are assisting you to really answer and support you with responses. Thank you very much.
Thanks, Chair. I'll apologize. My video is not working, and that's there's a block in the department on Zoom and video. So I do apologize to the members that they can't see me. Chair, let's start with your very last issue first. It is an issue now that our systems are in place. We've had unqualified audits. I think the time has come to decide on what do we do about this. As I mentioned, I think in the induction program that you invited us to last year for the members of your committee, this is a process that goes back over a century. And because of the difficulties with migrant labor systems, especially African workers, and the difficulties of neighboring countries, no documentation, no records of service, I think an imbizo is needed, and I probably will have to have a discussion with you offline between you and the minister as to how we take forward this process to conclude it with Minerals Council support, the trade unions and the ex-mine workers associations. Because it is a worry that this money is still sitting on the book, and partly related to Dr. Honorable Leroux's inputs as well, which I'll address in a minute. So I think let's take forward the imbizo issue very importantly as one of the outcomes from this portfolio committee presentation, and then decide for a 2-day meeting probably later this year. So I really want to take that forward, because now that our systems are in place, our financials are in place, we know the details of the individuals because of the electronic databases. I think we've got to come to a decision about how to actually manage this on a final drive in tracking and tracing and inputs. The difficulties are, of course, with deceased claimants, which you mentioned, your 1965 experience of grade 1 and a 90-year-old today. That it is going to be a very important issue about how we deal with the deceased claims. So I really want to take that as a very valid input from yourself as the chair, and an imbizo on unpaid claims. And remember, Chair, there is the unpaid claims in our fund, but there's unpaid claims in a whole lot of other funds. And we've raised with Minerals Council through Mr. Lesufi, and Ms. Harrington was taken over from Mr. Lesufi, about convening a mine workers indaba, because overall there's about 30 billion due to ex-mine workers in terms of unpaid funds, provident funds, Sentinel, unemployment insurance funds, etc. So it's a similar issue. But let's start with what's under our control and influence and take it forward. We don't have much time because we still have time to go to 1 o'clock. So let me start with, I answered Honorable van Staden's input on a prescription period, and that's there's no prescription, and that's partly related to then the inputs made by yourself and Dr. Leroux, which I'll answer as well. Honorable Clerk, once more, thanks for your sensitivity on being part of the previous committees and inputs that you've made, and also acknowledging the work that we've done to rescue this fund. On the testing for TB, the service providers, if a mine worker is at the mining companies, there's a formal program in terms of HIV, TB, and other occupational lung diseases. It's called Masuyisa TB, but it's now moved on to chronic diseases as well. So there's a very active program for current mine workers delivered through the mining sector and supported by the Minerals Council, and it really would cover TB as well as HIV and other chronic diseases, diabetes, hypertension, etc. For the ex-mine worker program, on our outreach activities through the benefit medical examinations, we rely on the province to provide a wellness unit that would also do wellness counseling and HIV testing. So it's not formally part of the protocol, but it's an important issue we are raising, and we'll take that back with Dr. Machali, and it's partly linked to the other issue on the national TB program that's just been launched about 2 or 3 weeks ago, which Honorable Matubatse has reached out about the collaboration, which I'll come to later on. So you've raised an important issue, but we don't provide that direct service in terms of HIV, TB, except to the mining industry for current mine workers and wellness programs through the provinces where they would help us at the outreach. The IEC was an important issue. We've not managed to crack that. We've just signed a memorandum of understanding with the Director General of Home Affairs on access to documentation, birth and death registrations, death certificates, and we're going to be implementing that starting in May, because that was just concluded towards the beginning of April in terms of the MOU. We would have to reach out to the IEC. It's quite protective of its inputs, and probably either through Home Affairs or directly to the IEC. We'll try once more. We tried this once before, but it did not work, and we dropped that issue and went for the other activities through the banks, etc. But the IEC will have updated voters registration, and we felt that was important. But it must be noted that a third of our ex-mine workers are from neighboring countries, Lesotho, Mozambique, Eswatini, and Botswana. And there are also difficulties in terms of documentation and activities. And we will have to ultimately look at a Southern Africa-wide process about how do we actually work through digital IDs, biometrics, and work with the Shiamiso Trust, which has got quite advanced systems as well, where they've gone through this. So I think that's an important issue, which we'll pick up once more on the IEC. Succession plans are important. Members might know that I have reached retirement age with an extension from the minister. And we are in discussions with Dr. Pillay. I'm not too sure how they're managing the process, but we have to prepare the search. There are colleagues who are highly proficient in terms of the preparation of the senior management team, the deputy commissioner, the director of finance, the MBOD, CCOD teams, which many of you have met. And we leave a very competent team in place, notwithstanding the issue about working through the Section 3A entity and bringing that in terms of the legislative reform. So there are succession plans in place, but we'll have to discuss that internally through Dr. Pillay and HR and the Minister's Office, because the appointments for the director and the commissioner, the deputy commissioner, and other officers in terms of Odimo is done by the minister, but the Public Service Act kicks in terms of the chief directorate position also, which I hold in terms of occupational health and CCOD. But your point is noted in terms of succession plans. Lower down the issues in terms of other colleagues, because we're going to much more an information technology-based system. There are inputs in place on training of staff and online processes, training of service providers, and certification committee doctors, etc. in terms of training. The average claim submitted time in terms of the current framework, which was in a previous strat plan APP, which was month 1 lodgement, month 2 certification, and month 3 payment if eligible. And generally, I think we've achieved, we are tracking that. We've got a tracking system in place, and I can make that available to you offline. And we've removed it from the APP because we were meeting our targets very much in terms of the average claim submitted. Bottlenecks, of course, and that's why you see in terms of the unpaid claims for the last couple of years, there's very few compared to the big 2005 issue, which I pointed out about the 66,000 claims, prior to 2005 and the early years prior to 2012, when the fund was in crisis, disclaimers, and no systems in place. So currently, month 1 lodgement of a claim, month 2 certification under Dr. Machali, Dr. Abada, and the team, and month 3 payment under the Deputy Commissioner and the Director of Finance. Bottlenecks were related mainly to the infrastructure, and I'm glad Honorable Sheko has raised the issue about, is it a request, is it information, and I'll come back to the building. But it's partly related to the water supply, the electricity supply, and the internet connectivity issues, which goes through CETA. We've had major problems all around in terms of this infrastructure that we haven't boarded the committee with, but I brought the infrastructure of the building The fire escapes don't work. And as you've noticed in the health sector, we've been having repeated fires in health facilities. And our biggest worry is to have a fire at the MBOD, CCOD. Fortunately, our documents are protected now by offline storage and electronic means. And we do have business continuity plans in terms of if there were problems. But the problem is loss of life and loss of limb in the event of a major disaster at the MBOD, CCOD building in Braamfontein, which is a public works building. So the bottlenecks are problematic, which has led to some of the declines in service delivery in terms of the back office support that the building provides. But I hope that helps with the average claim issues. The levy collection strategy, we have a complete database, I told you, of the plus minus 800 gazetted operations and the active gazette, the active mines and works of 300. Of course, we're increasing the numbers of controlled mines and works now, working with the Department of Mineral and Petroleum Resources in terms of the risk issues. We've got a new risk strategy, which is co-chaired with the Chief Inspector of Mines and Dr. Machali, and hence the activities. So the first issue was the database. The second issue was we have a debt register now, which is why we've had these unqualified audits. Previously, we had also a qualified audit on revenue, but we've shown the Auditor General that we have the ability to collect. And in the instance of inability to collect through the accounting financial services side, we've now gone to the State Attorney's Office, and letters of demand are beginning, including court cases that are beginning to start hopefully bearing fruit in terms of levy collection. But of course, the key area is a voluntary process, and the Minerals Council has played a key role in the work that we've done. The mining companies themselves acknowledge the work we've done, and therefore the voluntary levy that they contribute to of 70 million per annum, notwithstanding paying the formal levy to the fund. So I think it's a win-win situation of, firstly, the trust relationship, the Minerals Council work behind the scenes with the executives. In fact, the chair in his previous role as deputy minister met the executives of the Minerals Council, as well as some of the chief executive officers of the major mining companies in South Africa. So it's been a positive influence, but of course, there's always the one or two bad apples that we need to then take the rule of law in terms of recovery of debt. So the first issue is we've got a debt reduction recovery strategy. We've got the debt book and debt register, and now we have a formal collection process led by Ms. Mampo Baolo and the team, notwithstanding the inspections in terms of that process. And overall, we're currently sitting at around, as we pointed out, 90% collection of levies. So we're not allowing levies to fall by. The main issue was where companies close down or acquisitions and mergers where we are not notified, and we're also taking a process of noting that with the companies. And some of the debt is what we call old debt that we are beginning to actually go after. In terms of best practice, we are planning a study visit. Unfortunately, occupational lung diseases in terms of other mining jurisdictions, Brazil, Canada, Australia, don't have the levels of caseload that we have. In fact, when I've presented at international conferences, they marvel and wonder as to how we allowed this to happen, that you could have 200,000 occupational lung diseases, 120,000 TB, 20 to 30,000 silicosis, 10,000 coal workers pneumoconiosis, 10,000 asbestosis. How did we allow this to happen? So there's not an equivalent organization that deals with occupational lung diseases worldwide, but we are working with the World Health Organization, Stop TB Partnership, which is quite involved with TB and silicosis and other occupational lung diseases, and the International Labour Organization and the International Social Security Agency. We are due to prepare for a study visit that will probably be externally funded to actually meet with the ILO, WHO, and ISA to actually work through the issues around, because we have got some good practices, but it might not be the best practice, and we're trying to pick up on that. Our counterpart in QAIDA, in the Department of Employment and Labor, unfortunately don't see as many occupational lung diseases because of the overlapping legislation, and mainly deal with injuries. Most social protection systems and compensation systems deal with occupational injuries as opposed to occupational diseases. And in the northern countries, the main occupational diseases now are mental health related as opposed to physical health related issues of cancers, lung diseases, etc. So we actually don't have some benchmarks, unfortunately, but we will take your idea up in terms of discussions with some. And if you've got some ideas, we'd be welcome to let us know from the own work that you might do, or colleagues within the Democratic Alliance. Dr. Leroux, you're quite right. This is a fund that's growing. We unfortunately tried 5 years ago to seek whether we could use part of the interest, which has been building up, and to pay for the administration as opposed to the state. Remember, the state has provided this service from 1912 in terms of the red ticket examinations, the ex-mine worker examinations, the current mine workers. It was only till the Mine Health and Safety Act came into being in 1996 that the mining companies took over the funding of the medical examinations. So medical examinations for white mine workers were done by the MBOD, and medical examinations for black mine workers was done by TERBA, and of course funded by the state, in terms of its process. So it is a very difficult past. Legislatively, I'm told that it'll take the equivalent time to get the new legislation in place for the Section 3 entity as opposed to an amendment. But I will discuss that again with Dr. Anban Pillay about if the legislation for the repeal of the Act and bringing the new Act into place is going to take quite long, then it might be that we need to just do an amendment on this part to use the surpluses from the fund to actually help with some of the administration, because that relates to partly the chairperson's point about the track and trace, the medical examinations, the outreach activities, which are all unfunded mandates and currently being supported either by provincial program or by the Minerals Council South Africa. So you're quite right. The fund, strictly by the legal definition of the fund, can only pay for the actuarial valuation and bank charges and pay for the benefit. It cannot pay for anything else. The state has to pay for everything else. And thanks to Minerals Council for helping with the additional support. On the seen and assessed 1.3 billion, it's for 75,000 plus minus 75,000 unpaid claims and 66,000 before 2005. And we've dealt with part of that about an MBZO later this year that could be convened with the Portfolio Committee on Health in terms of what do we do about this. So I hope that this thing. So it is quite correct. These 75,000, approximately 75,000 were seen, were assessed. And the reason why they weren't paid on time, because the system had collapsed essentially, since 1973, when black mine workers were brought into the system in a fairly big way. Noting my induction process that between 1912 and 1973, essentially it was white mine workers that accessed the system, with some black mine workers resident in South Africa. In 1973, there were some changes, but overall, it's a very difficult process in terms of working that. And I think the MBZO will help to say, how do we take on this enhanced process? Very little documentation, TERBA records unavailable, and for many of the mining companies, no records kept. Although health records should be kept for 40 years, we don't have that situation in place, and I'm not too sure unless once we get to the MBZO, maybe we could pick up some of these issues, both in terms of health records at clinical health facilities, public health facilities, clinical records with the mines, and then there's a whole range of mines like Aurora that have closed down, and we're not too sure what's happened to the records. The records were meant to be kept with DMPR, but unfortunately, we can't access those records either. The process at a health facility, I don't know if Dr. Michali or Dr. Rabada wants to comment. Dr. Michali or Dr. Rabada, because of the service provider networks that you're doing, I can hand over to you all through the chair.
Thank you, Chair, through you. And thank you to the honorable members. So we do have a service provider networks. So we try to cover the whole of South Africa, especially the labor sending areas. We don't have a process in the SADC countries, but there are organizations that are helping us. Some governments have got a structured process of these benefit medical examinations. In the provinces, for now, we only support, we have 4 provinces that has, they've got what we call one-stop service centers that were launched about 6 years ago by Deputy President Motlanthe back then, but we are technically supporting those. They were supported by Minerals Council, Chamber of Mines at some point, by Global Fund, but once those funds ended, then there was some collapse, but we're trying to resuscitate those and keep them alive. We do ongoing training programs. Right now we're doing Mpumalanga just to make sure that these benefit medical examinations continue. However, mining companies are very helpful. They even take care of their ex-mine workers. So with the understanding, again, that they understand how to diagnose occupational lung diseases. So with all the TB programs, HIV programs, chronic disease programs, all the medical healthcare providers are trained on how to diagnose occupational lung diseases. And so we have a system that Dr. Berry has mentioned that is supported by Rand Mutual and Minerals Council, which is a submitting system, and there's a feedback system, and we have an SMS system that goes to the clients just to notify them that the certificate is ready, and when payment is also effected, there is that SMS system. So we've really improved from the handling of physical submissions, going to provinces, service providers, mining companies. We now, everything that we do now is electronic, and the submission, we have plus or minus 30% of service providers that still submitting. We have quality challenges with the chest x-rays that are being submitted and the spiral, because for the certification committee doctors to certify a claim or to adjudicate on a claim, we need, we use ILO or International Labour Organization classification systems, and we also use spirometry. That is also the standards that we're using, European and American standards, and the South African standards are also aligned, but once we have quality issues, then we can't certify, and those examinations become useless. But the processes are sort of seamless. Like I said, the private service provider network we've developed, we just, maybe in the next 2 months, we are going to increase or widen that network. But so far, we're trying, and we've improved a lot. Thank you, Chair. I hope I've covered the processes, even though it's just ad hoc. Thanks, Chair. Over.
Chairperson. Now, just additional issues to Honorable Leroux. We've battled in terms of the undergraduate program, in terms of occupational health is very weak in the health professionals curricula. And I've not managed to stimulate that agenda other than my prior work at UKZN many years back. At a postgraduate level, we've requested registrars in public health and registrars in occupational to rotate through the MBOD CCOD. Again, that's not been an issue. I'm not too sure if the portfolio committee chair is going to meet the medical schools at some stage or the health professionals. And unfortunately, with such a large mining sector playing such an important role in the GDP or workers' health in general in occupational health, very little is done in terms of training, undergraduate rotations, postgraduate rotations, etc., through units such as the MBOD, CCOD. It could include specialties like pulmonology, radiology as well, but definitely occupational health and public health should have been mainstay disciplines. So again, maybe this is a request to the portfolio committee, if it's meeting the health professions or the HPCSA, maybe to raise these issues that we are raising about curricular changes, which identifies the points that Dr. Leroux is making about if you don't train, then you don't identify and you don't know how to input and submit to the MBOD. Estimates of those not assessed. Honorable Leroux, you've raised a very important epidemiological point. We've got, this issue is, there's a big problem with latency. Fortunately for TB, I mean, it's a difficult disease, but it presents acutely, and you could get to an intervention diagnostically and treatment. The occupational lung diseases take 10 to 20 years to manifest because of latency, and invariably take the 90-year-old that the chairperson has mentioned, who thinks he or he's getting shortness of breath, dyspnea, because of old age. All the time it's due to having a fibrotic lung disease, silicosis, or coal workers pneumoconiosis, etc. But they won't recognize that unless they come to a diagnostic process. So you've raised a very important point. We don't, unfortunately, have the estimates of those not assessed because of a collapsed system that has not provided the service. And while originally there was a cradle-to-grave model in the original Miners Thesis Act and the original MBOD, CCOD, or DIMWA Act in terms of including postmortems, these services are not provided because of no funding. And therefore, you've raised an important point. So the direct answer to your question is we don't know the numbers of people out there, notwithstanding our tracking and tracing and provision of benefit medical examinations. And as the chairperson mentioned, Shashai, Mafeteng, Manzini, etc., to really get out to these places is a very difficult process. And for the mine workers to come from villages to Shashai, Maputo, etc., is actually a long haul, notwithstanding the difficulties. Even, to come from Libode to go to the one-stop service center, occupational health center in Namtata is still a major issue. So the direct answer is we don't know how many have not been assessed. We don't have the exit medical records. We're putting that in place as of later on this year in terms of all medical records from the mining companies being moved on to the MBOD, CCOD system, including exit medicals. And that's an ongoing process that we are discussing. So the point of not assessed, we don't know. But the numbers that went through over time, approximately at the height of the gold boom in the 70s, there was about 1 million to 1.5 million people working in the mining sector. Decrease in numbers not due to finding people, that's linked to your estimates of unassessed, as well as the outreaches might not. We've tried to target the outreaches to labor sending districts and labor sending areas, working closely with the Eastern Cape Department of Health, Northwest Department of Health, Free State. These were big mining areas. And then KwaZulu-Natal, Mpumalanga with coal, Northern Cape with iron and asbestos, etc. Very few in the Western Cape in terms of the numbers, as you've seen from our data. So you could be correct that the decrease is due to not finding people, but we did some massive programs from about 2015, funded by the Gold Working Group at that stage, then linked to the Sheemiso Trust and then the Minerals Council. And we reached between 80,000 and 100,000 ex-mine workers. And there are colleagues in this room from the ex-mine workers associations, Mr. Kaba, Mr. Vamajele, Mr. Moises Uamiso from Mozambique, Vamajele from Eswatini, Mr. Lita Klaas and team from the Eastern Cape. One of the good colleagues in the Marcelo Lolo, Honorable Lolo from Northwest, led the program in the Northwest Department of Health when she was still an official of government. So we've tried to do the outreach activities and try and track and trace. But the decrease, you're quite right, might be people are coming through, but the main decrease might be also that people have died and never came into the system because of the databases. In terms of TB prevention, and that partly links to Honorable Matubatse's input. Firstly, there was the TB in the mining sector program funded by the Global Fund, which was from 2015 to 2019. The strategic plan of the Department of Health from 2024 as TB in the mining sector as a strategic pillar. The high-level United Nations program 2018 in New York brought in TB and silicosis as a risk factor for TB. So there's multiple processes in place in terms of highlighting TB prevention strategies. And therefore, we think that also the Project Masiise in the mining industry, led by Dr. Balfour, actually did some major, and Dr. Moyo really brought in the TB prevention. So the social circumstances, you're quite right. But the dust control levels have been important, and that's through DMPR in terms of the Mine Health and Safety Act. We've long beaten the drum about occupational exposure levels, and fortunately that finally saw the light of day in terms of the 0.03%, but it's still a target by 2034. So, but the numbers have come down from the 0.1 milligram per cubic meter, aspirational 0.05, and now aspirational 0.03 milligrams per cubic meter. So working conditions and dust control, and of course, social interventions of moving away from single-sex hostels, etc. And the TB prevention strategy, we're still working through INH prophylaxis with the TB cluster. We work quite closely with Prof. Norbert Njeka. And very importantly, TB in the mining sector is a pillar for funding from the Global Fund SANAC program, which will kick in later this year in terms of that program. And thanks to the Ex-Mine Workers Association led by Mr. Kaba in terms of raising the profile. And at the Stop TB Partnership, TB in the mining sector is well recognized in terms of it. So there's multiple pillars that are moving in on TB prevention, notwithstanding the issues around silica dust exposure and other occupational lung diseases. I spoke about the legislative change, and we'll discuss that with Dr. Pillay about whether, if the process is too long for the repeal, then a legislative amendment, and whether that would be easier to bring to come in. In terms of the fund, you're quite right. We are showing a 3 billion surplus in the outer year now. In terms of the fund, we have brought down the levies considerably, but we don't want to be, in case the interest rates, because our main investment income now comes from the interest rates that are quite high. And if there are changes in that, then that might bring down our figures. If we do pay out, that will affect the actuarial valuation, notwithstanding the numbers coming down. But what we have done is increase the benefit amounts. And, originally we were paying around 40,000 and 70,000. And in a matter of 10 years, we've now, moved it up to 100,000 and 200,000. So notwithstanding the class action settlement in the gold mining industry, which has added another 2 billion, and many of them overlap with us in terms of additionality to the ex-mine workers in terms of restorative social justice. So you're quite right about that. We have brought the levies down considerably, and hence the mining industry has acknowledged that in terms of the process. Since 2018, with the correction in the levies, the mining companies have benefited to the value of 1.2 billion rand in levy decreases, notwithstanding the funding that they give us through the voluntary levy, which is also considerable at 70 million per annum. Honorable Matubatse, outreaches in the provinces, Dr. Rabada, do you want to comment in terms of the outreach program? We have a set outreach program in terms of funding constraints, And there are provinces we haven't covered, hence we went to Mpumalanga, which was the first major outreach last year in October. My apology to the chairperson for the incorrect date. And that was October, November, and then of course October was Free State and November, December was Mpumalanga. And this year we went back to Gauteng, which we hadn't done an outreach in conjunction with the province. So we work quite closely with the province. But I don't know, Dr. Rabada, if you want to comment on the program, because we still have Northwest, and there's also the Eastern Cape knocking on our doors in terms of the process. We haven't touched Northern Cape since the One Stop was launched in 2014. Dr. Rabada?
Thank you, Dr. Kismasami. Also greeting the honorables. I think I'll just keep it short to just say that currently we are going through a program in Gauteng where we've done registrations. So the sole purpose of registration is to check if the ex-miners have got money owed to them through provident funds, pension and provident funds, I think the first one. And then number two was just to check if they also qualify for a benefit medical examination. We currently have around, I think, 400 people that through that process, we have checked that they qualify for a benefit medical examination. So what we just do is that we do this program, people come, and then once we've checked, we check those who have money that is due to them, and also segregate those who are due for benefit medical examination. And what will then happen is that they will be scheduled for specific days so that they don't wait for too long. That the specialized equipment will then be there to ensure that they are able to get those digital X-rays, lung function tests. And I have to just stress this one in partnership with the Gauteng Health Department. I think Mr. Jigwana has been very pivotal in making sure that the program is where it is. I think once we've done those benefit medical examination, we'll then see how many people have got these occupational lung diseases. And I think Dr. Berry has already alluded on the fact that these diseases are latent, so people wouldn't know. And therefore, that's why we do it every 2 years. So there are people, of course, who qualify for BMEs, but because they have done it, in the interval has got to be more than 2 years. So some of them had BMEs, and their time had not elapsed that they qualify. So that's why the number at this point in time is 400. And we will then go to Northern Cape, and we're exploring also Limpopo. But I just thought just to bring to the honorable members that we are currently now in Gauteng. Thank you.
So, Chair, we have a rotation of provinces because of funding constraints, but quite willing to discuss with honorable members about provinces such as Northwest, where we had an extensive program 2 years ago, which has yielded some results, and there are still some activities undertaken in Northwest through Prof. Tumbo and other colleagues in the Northwest Department of Health. Collaboration with the TB cluster and the campaign, we're very much part of that process. And in fact, there is a very strong input that Dr. Abada and myself make through the private sector forum with Dr. Charles Mbekeni and other colleagues about increasing workplace programs for TB, because one of the big issues is tracking and tracing those with TB but may not know it, with latent TB. And I mentioned earlier on, TB in the mines is in the strategic plan of the Department of Health. And we're working very closely with Prof. Norbert and Jeka in terms of the activities, as well as the work that we are beginning to do on research on computer-aided diagnostic tools for TB and silicosis. And we will be launching later on this year a research project on use of ultra-portable, or what are called handheld ultra-portable X-ray units. We're just waiting for the protocol development, etc. Prof. Muzi Zungu, who's present here from NAYO, is leading that team on dealing with computer-aided diagnostics, the software interventions, and the hardware with handheld devices, etc. So very much it's in the front line, because the problem is chronic disease like occupational silicosis are slow deaths, but TB is acute, and many of our colleagues have actually died because of TB rather than the issues of the occupational lung disease that underlies the TB program. And reaching out in terms of the outreaches, so it's Northern Cape and Limpopo next. Unfortunately, because we haven't reached either of them, and then we'll look at how we can fund a model to get back to Northwest with the Provincial Department of Health. Honorable Cheko, thanks for raising the issue. No, it was a humble request, which said that since I came in, the building has been in dire straits, but we tried to do with a coat of paint and improving on some facilities. But there was a condemnation. We have an entire file on the Public Works building, which is not fit for purpose. And in the event of a fire, we could have loss of limb and loss of life. So I'm raising it in the sense that is it something our minister has written to the Minister of Public Works and Infrastructure, and we have no feedback in terms of other than saying we'll have to go back through the procurement process. The procurement process for the building takes place to Public Works. We give them our requirements and they do the procurement, and it's gone 2 years and we don't have a satisfactory answer as to the next steps forward in terms of this. So it's a request, and I'm not too sure if the chairperson or the members are picking up other problems in terms of health facilities and Public Works. And it's something that we are raising strongly as the national department, as a structure within the national department. I mentioned the Home Affairs track and trace process that we've just concluded the MOU. Thanks to Dr. Burtis, who helped to spear that entire program with the Director General of Home Affairs, and we'll pick up within that IEC. I mentioned that a third of the ex-mine workers are from neighboring countries who don't have proper systems as well. So we'll have to work through that in terms of new methods. And the point is taken about traditional practices and traditional marriages, etc. And really, it's been a difficult process, but we want to borrow on some of the activities of the Shia Trust, who have tried to overcome some of these issues. And Dr. Quinda is here with the team from Shia Trust. Local radio stations have been a bit of a difficulty because the problem is that it raises expectations. So generally, and Mr. Kaba is here with Mr. Klaas, and we've generally tried to work through community health workers, local government and traditional leaders, and local government leaders, municipal mayors, etc., like a program we're running in the Eastern Cape now, more by word of mouth as opposed to radio, because with radio, we get a lot of people turning up. And Dr. Dlomo, in his previous role, will recall the Eastern Cape, where we were overwhelmed by numbers, notwithstanding, we didn't go on radio stations. So we try to identify those that, as Dr. Rabada pointed out, that we can reach through unemployed graduates on a stipend, going village to village and trying to track and trace, as opposed to radio. But we're still open to that. The main problem was raising expectations, because the key area with mining, it's a concept called risk work. And sometimes people feel that they were a member of AMCU or they were a member of NUM, and they worked as a clerk in the stores division of the mine. Now, they would not be exposed to silica dust. They might get TB, but they may not be exposed to silica dust. But this is the problem. They turn up for a benefit medical examination. And then when we say, did you do risk work? And, they then get quite disappointed that we can't do a benefit medical examination. A benefit medical examination costs us approximately 1,200 Rand direct costs for the lung function test, the X-ray, and the clinical service. So I pointed out the BME costs, which the state has to fund at the moment. Fortunately, Minerals Council is providing some support for a limited number of benefit medical examinations. And we are in further discussions. If an ex-mine worker can go back to a mining company, which creates problems, because they have to travel long distances, they will get a free medical service at the mining company. The state otherwise should provide these services free of charge to the mine workers, and that's the unfunded mandate, which we don't have technical funding support for. There is a service level agreement now that we've gone forward with some limited funding from the state, which Dr. Mitchali has pointed out that there are private service providers now on a fixed fee-for-service basis that will provide BMEs in some areas, notwithstanding the provincial facilities, for example, the work that we're doing with the one-stop service centers. So that's the BME costs. It's an unfunded cost, partly funded by Minerals Council, partly funded by the provinces, and ideally it should be funded out of the Department of Health from voted funds, but that's not possible within the budget. Honorable Dr. Letlape, we try and work on the basis of the worker, giving the benefit of the doubt. So we're not working like the medical aid schemes about how to try and do the worker down. But unfortunately, I'm audited by Auditor General, and we have put in very good fraud detection systems. We have to check all documents, and with the online processes, we've managed to cut down quite a bit. We had a problem 10 years back on administrative fraud with insider trading of changing IDs and changing bank accounts. We had a system of clinical fraud with exchanging x-rays. We had analog x-rays that were being exchanged. And imagine an analog x-ray valued at 70 to 100,000 rands being changed in the file. So we managed to overcome all of those things, the points that you made, and hence we've got unqualified audits, particularly on the payment side. But we can't be reckless. So in terms of a beneficiary, a death certificate, we have to have these things. And unfortunately, that's the documentation that's missing, or a TB gene expert result for a TB claim that Dr. Mitchali and them need to close the file in terms of this. But we have erred on the side of the worker, because these are the workers that help to build Santon. And if you see our track record of having paid out the 2 billion over the last 9 years that I've been in office with the senior management team. I work with the Sheemiso Trust that paid out an additional 2 billion rand. We're currently working with the Mine Minerals Council and the coal sector about a coal class action. So I think our bona fides cannot be questioned in terms of our commitment to the workers that help to build the economy of South Africa, but in its wake landed up with occupational lung diseases. But unfortunately, Auditor General is holding me to documentation. And if I don't have documentation, then unfortunately I can't pay the claim. And hence inputs that came from honorable colleagues on the portfolio committee, the Imbizo, the IEC links, the Home Affairs links, and we'll probably have to look at the issues with SADC countries other than South Africa about how do we reach out in terms of those processes. We've paid where possible. And I hope that Honorable Letlape will take it in the stride that I said in terms of the commitment we've done to occupational health in general and the mine workers program in particular. Dr. Dlomo, in conclusion, you mentioned a very important issue and you gave us a personal history, and thanks for your past leadership in this program and hopefully through the portfolio committee to help us. I just want to summarize firstly that there is the request that we made previously about a joint portfolio committee between DMPR, DEL, and ourselves so that we can strengthen the programs of the mining sector, current and ex-mine workers. There is the issue of the Imbizo, which has been raised in this portfolio committee, which should look at unpaid benefits to mine workers in general, but in particular with my fund. But there are other unpaid benefits due to mine workers, which everybody has parallel systems. And how do we leverage of that? You probably need to have the Fiscal also present at the Final Sector Conduct Authority. And the last request is Public Works and Infrastructure, whether you can help us with a new building. Chair, I think I will stop there and hopefully have answered
Okay, thank you, Dr. Kisnasamy. You have done my job easier. You are summarizing what came out of this meeting. I hope you are still there. I was just saying, in other areas, the compensation delayed is as good as compensation denied. And that is some of our beliefs in terms of this process. Hence, that request for a 2-day meeting, but all the role players, but we need to come to that meeting not to lament. It will be a meeting if we come in there to say, what is the way forward? What are the proposals that can really work for us? Of course, such a process will need funding, not for that meeting, that's one story, but to go out and actually make sure that you don't conservatively trace and track, but you trace widely and massively because you want one day to pay off, not only from the fund that you monitor, but also from the other bodies, other trusts that are paying these funds. We will look into, yes, it is actually something that could have been reported of where are we with the process of the joint portfolio committees. That's something that we need to look into. I would probably think we would need you to write to us regarding these issues of public work so that we can take that as a sort of an issue that we can tackle. Just from this meeting, is not good enough to then take it without giving us the necessary background in a form of a letter. Do write, then we'll take it from there. But thanks for summarizing the way you did. It is something that is very, very key to us. And we thank you for taking 2 minutes of our lunch break, but it was a necessary discussion. Honorable members, we thank all those who participated, including listening leaders from SADC, leaders from Geneva, and leaders from all over in our country. Mineral Council of South Africa, we thank you very much, Babu Lesufi and the team that we came with. We thank all those who are here from the neighboring countries, Eswatini, Mozambique, and other countries I might not have known, all around Botswana and Zimbabwe, for your participation. We are having a work in progress, and we hope to really someday have an impactful resolution of these challenges. Thank you very much, and take a break. Honorable members, we will be back at 2 o'clock. I hope that our secretary will assist the team from South African Medical Research Council to have a link locked in by 522 and put the presentation up by that time. Thank you. Enjoy your lunch. And thanks to those who are not returning after lunch. Enjoy the rest of the day. Thank you.
Thanks, Chair, to you and the members. Goodbye.
Bye.
Recording stopped.
Uthini babu class? Siyakuzwa babu class. Vala lapho umboko wakho. Good afternoon, honorable members. Once more, welcome to our meeting. As we started this morning today, and this time we are meeting now with the South African Medical Research Council. And I have just not seen who's logged in, whether it's Professor Ntusi, who is president and the CEO of the institution, or is accompanied by the chairperson and the board. May I leave it to you, Professor Ntusi? You have 45 minutes to interact with you. We have received your presentation. It is quite a lengthy one. You will decide in your 45 minutes which slides you would prioritize, but the members have gone through it, have seen it. It's just for you to highlight and take us through issues that are pertinent on your annual performance plan, and together with the strategic planning, and issues that are critical on your budget that we must know and talk about. Over to you now, Professor.
Good afternoon, Chair, and good afternoon to members of the Portfolio Committee. Is it possible to be asked to be given permission to share our slides, please? It says that the host has disabled the participant. My colleague, Tendani Tsedu, is sharing from his computer.
I had requested that it be done even before 2 o'clock, Ms. Machalamba.
We've now shared the presentation. Are you able to see it, Chair?
No.
Not yet.
Excuse me, Chair. Could I request the presenters, if they are possible, for them to please put their cameras on? Thank you.
Certainly.
First things first, we need to do the presentation first, then the camera of the presenter. But there's no slide showing as yet.
Share photo. We are sharing. Are you now able to see us?
Yeah, it looks very thin. Make it
bigger.
Like a slide presentation. For now, it is on a particular mode. I don't know what to call it.
How is that now, Chair?
Yes, thank you very much.
Recording in progress.
Wonderful. So it's a great pleasure to be able to share our strategic plan for the 5-year cycle, 2025-2026 to 2029-2030, as well as our annual performance plan for the year 2025 to 2026. I am making this presentation on behalf of my colleagues in the executive of the South African Medical Research Council. So as I do with all
Okay, something has gone wrong.
Just me, or have we lost sound?
There's no sound, Honorable Clerk. We don't know what happened.
Excuse me, Chair. It's Professor Zulka here from the MRC. I see we also have some of our board members on. I'm just double checking from my side. It looks as if we've lost Professor Ntusi.
We are waiting for the presentation to be flighted, and we are waiting for the voice of Professor Ntusi or anyone from South African Medical Research Council to take us through.
So, Chair, if you indulge me, it may be that there was a problem at the MRC. I'm in a different venue. May I share the slides and take you through it? And then if they come back on, they can take over?
Okay, that is Professor Zuke. Please do that. That would be great. Give her sharing rights, Ms. Machalamba. Thank you.
Are you able to see the slides?
Yes, please go ahead. You can see South African Medical Research Council, first slide. Yes.
Thank you so much. Thank you, Chair. I'm going to continue where Professor Ntusi left off. I'm not able to see if he rejoins. So if you notice that he rejoins, you're very welcome to interrupt me, and then I can hand back over to him. Just acknowledge again our commitment to the continued promotion of justice and dignity following the historical disposition during apartheid. So we're going to discuss the SAMRC mandate, and we always reiterate our vision, building a healthy nation through research, innovation, and transformation. And our mission is underpinned by these 6 values that of pioneering, excellence, respect, partnering, integrity, and citizenship, both to the MRC community, the community at large, our nation, and globally as well. This is our structure, the SAMRC board, and I acknowledge the chair of the board, the vice chair of the board, and any board members that are on the meeting today. Of course, our president and CEO, and then the members of the executive medical management committee, many of whom are in the meeting today. I think the rest of them are on site at the MRC. This is our board members, and again, acknowledging the presence of board members who are on the call and thanking them for their work and their commitment to the SAMRC. This is our executive management committee led by our president and CEO. There you see myself. I'm the vice president, extramural research and internal portfolio. And then the other members of the EMC cover grants, innovation and product development, finance, human resources, legal counsel, our chief research operations officer, and then quite unique to our organization, an executive director of transformation. I'm going to go through some of the staffing as it stands. This is as of the 31st of March, 2025. You can see the vast majority of our staff are Black African, colored makes up 23, 11, Indian and white 8%, and our foreign national contingent is 4%. The SAMRC is 70% female. And then this is the EMC, which is 50% African, colored is 2 and 2 are white. And then you can see also on the side the difference in female and male, 62% of our executive management committee. This is our senior leadership. You can see the demographic distribution on the left, and then female to male distribution on the right. I'm just checking in the meantime, Chair, if our president has managed to rejoin, or if you're happy with me to continue.
I haven't seen him joining, but let other members tell him if he joins, he must just indicate he's in. Continue so long.
Thank you so much. So part B is our strategic focus, and to remind ourselves that the annual performance plan, the budget, and the materiality and significant framework was approved by our minister at the beginning of this year. So just a few pointers. I realize that the font is quite small, but you do have a copy of all of these slides. And so we discussed also the critical role that the SAMRC has played since the beginning of COVID-19, the resources invested, the teamwork and solidarity that came through during the pandemic, and how we take that now into the future where we deal with pandemic preparedness and responsiveness. Our president and CEO was appointed on the 1st of July 2024, and he's responsible for implementing the strategic plan, which will start in this year and take us through to the end of 2030. And it is our great honor and privilege to invite all our stakeholders on this call and beyond to join with us as people on this journey, and to also point out areas of improvement, collaboration, and partnership. And the SAMRC board fully supports our strategic plan and annual performance plan. This is a statement from our president and CEO, and speaks to the fact that our country's health is a critically important part of economic development. The strategic plan, which is coming to an end now, was our guide, how we deliver on quality research, high impact science, and make sure that health science actually flourishes. And this next plan is now our focus to conduct and fund research that is based on local development priorities as well as disease burden. Transformation in science and in scientists and the scientific community is part of our strategy. Our
The slides have
partnerships.
been read. Take that the slides have been read. You cannot give
I'll
us
take it that the slides have
word
been
for
read.
word.
Thank you, Chair. Thank you. This really just summarizes a commitment to move forward in this particular regard. I feel it's important to highlight some issues relating to the USA federal funding cuts. This is, as we see it, also an opportunity to reimagine global health and how we do that. And our president and CEO is leading a group at the moment that is focused on mitigating the current situation, but continuing to deliver high impact science. There are on the side 4 particular areas that need funding support, and he is leading a ministerial advisory committee that is involved in all of this at the moment. These are the constitutional, legislative, and policy frameworks. We've undertaken a very detailed analysis. Again, this is very small font, so I will leave it to you to read through, but speaks to the strengths, weaknesses, opportunities, and threats that face not only the SAMRC, but the research landscape. And then in even more detail, we undertook a pestle analysis, looking at the political, economic, social challenges and barriers, and then technology, environment, and legal areas that are facing us, and how we deal with all of these into this next 5-year plan. Part C is measuring performance. And again, we focus on our strategic health priorities, that of disease, of health promotion and disease prevention, the quadruple burden of disease under maternal, child, and women's health, and then communicable disease. And then these other 3 that are critically important: health system strengthening, especially as we think about responsiveness going forward, public health innovation, and then biomedical research. So program 1, each of these programs are going to be preceded by our impact statement. And so this is how we administer health research effectively and efficiently, and in accordance with good corporate governance practices. And you can see there that the important one here is to strengthen these processes to obtain a clean audit opinion from our Auditor General. And so this is the strategic plan. This is our baseline, is a clean audit, and our 5-year target continues in that realm, and the expenditure is capped at 20%. We have annual targets here that I've shown you in the columns on the right, but towards the left is where it was in 21, 22, etc. You can see the numbers there are 16 to 19%, with the estimate performance at 20%, and for the MTEF period will remain at 20%. The quarterly targets, obviously the target at the end of the financial year is that of a clean audit and 20% across and then at the end of the year. Our Program 2 impact statement is to promote the improvement of health and quality of life and advancement of science in South Africa. See there some of the numbers. The baseline strategic plan has now been increased into the 5-year target. I'm not going to read each of these areas out, but you can see it is around producing scientific excellence, generation of new knowledge, as well as funding for health research. The MTEF targets here are also outlined in 2.1, 2.2, and 2.3, and you can see the targets outlined there for you. We break these down into quarterly targets, and so these are the targets that we have across the board, and these speaks to more granularly to things like our proceedings, abstracts, book chapters, as well as in first author, middle author, and senior author, as well as research grants that are funded by the SAMRC. Program 3 is supporting health innovation and technology development, and this speaks to supporting a thriving health innovation ecosystem, developing impactful health solutions for South Africa, for Africa and beyond. You see there our baseline. I see that Ntobeko has just joined. I'm just going to finish this one up and then I can hand back over to him. So this is our baseline strategic plan and then our 5-year target in both of these areas. And this is the annual targets looking at innovation and technology products, both funded by the MRC as well as disclosures made by MRC employees and students in this particular area. The quarterly targets, again, the more granular element where we divide these into our quarterly targets. At Program 4, I'm going to see if Ntobeko is able to unmute and speak.
I'm very
Ntobeko?
happy for you to continue.
I'll continue and then we'll just regroup towards the end. Thank you very much. So this is Program 4, Building Sustainable Health Research Human Capacity in South Africa. You see our impact statement there speaks to funding and supervision support so that we can create the next generation of not only scientists, but science leaders in the broad field of health. Here you see all of the numbers. This speaks to PhDs, speaks to postdocs. We look at females, Black South African citizens, the awards that we're giving, and the amount of postgraduates that have graduated or completed. Again, I take these slides as read. Here also very detailed, not only for the previous period, but for the next 5 years. And the targets continues again in the previous years and what we are proposing going forward. Here we see the quarterly targets for next year and broken down into the 4 quarters, but the annual targets across the middle there. So Program 5 is research translation into policy and practice to improve health. This is critically important and speaks to how we take the research that we have done or have funded or have encouraged and train this into policy, practice, and public decision making. So this speaks to the number of policies, practices, and guidelines that reference our research or are co-produced by our intramural researchers or speak to the committees that our researchers are on, and of course conferences, seminars, webinars, and continuing development points that are supported by the MRC. And you see the previous quarter and now the 5-year target going forward. Again, here it is broken down into the various elements, so more granularly, the quarterly targets for the next year. And then finally, I know this was really quite fast, but again, as I said, we take these slides as read. In this one, we look at what the various programs, what is changed or unchanged, and those slight changes areas, the justification for each of them on the right. financial performance. Again, I realize this is quite small, but hopefully it is, you can see them on your own computers. And this is also for the last 4 years, from 2021 until now, and then taking us on the right into the new estimates. So key risks, one always has to be aware of the risks and then understand them and mitigate for them. So we've highlighted the risks in each of the 5 programs. And of course, you note there the issue of funding. We had already considered that when we were preparing this prior to January 2025. And then the key mitigation measures in each of the areas. Kind of things that are very important these days are things like cybersecurity training for Program 1. Program 2, we have a very strong research integrity office that deals with issues here. Program 3 is looking at external partnering. Global 4, different ways and methods of diversifying our capacity development strategy. And then Program 5, key mitigation, is the oversight and leadership that is provided by our executive team under our president. So I'm going to pause there. Hopefully our president is able to address any questions. And I thank you very much, Chair, for the opportunity to be able to have presented. Thank you.
Thank you very much, Vice President. You came in and you were actually able to move. It was not like, oh, this is Professor Ntusi's work, I'm not part of it. Thank you very much. Do you have another slide, another presentation to flight into? Let's do them back to back. Thank you very much.
Chair, I'm going to hand over to Professor Ntusi, but we do not have another presentation. We are open to questions now. Professor Ntusi, you may go ahead.
I would like to share very briefly on the animation. Look at the animation. Chair, are you able to hear us?
Yes, I am able to hear.
Wonderful. So I've got another very brief presentation, 5 minutes, that I would like to share before we open up for discussion. And I'm just going to share my screen.
Go ahead. Thank you.
Can I ask for permission to be able to share, please? It says host is.
Yes, I've given you the co-hosting rights.
Thank you so much. It still says host as disabled. Participant screen share.
I think the problem is on your side because I've given you the co-hosting rights.
Let me try again. That's your slide. It's right here.
There was gift to tobacco.
Oh, okay.
Any luck?
Just a minute, Chair. Thank you. Just send them to you.
I've now made you a host. Maybe you'll be able to share.
Chair, it's Liesel Zulke again. They're going to email it to me because there seems to be an issue on that side and I can share it from here. I don't know if you'd like to take any questions in the meantime while we wait a minute or two. I can.
We'll have one round of questions, so rather let's complete presentations, then do that after.
Thank you, Chair. I think I should be getting it soon.
This is not translated. Okay. I'm not sitting on the box. It says incorrect. It says both are set. It's gone. There's nothing in my box. She should receive it. It's just so
Professor Ntusi, if you invite a female in that meeting you're having there, it will work out better.
I suspect so. Oh, there we go.
Yes.
So wonderful. Do you mind just going to slide number 5, Liesl? Thank you. So, Chair, I just wanted to make a brief comment about the existential crisis that is affecting the health research sector in this country. And this relates to the US funding withdrawals for support of research, which are completely unprecedented and truly a black swan event that nobody could have predicted. And this is made worse by the fact that the executive orders and the stop work orders that followed were effected with such rapidity that there was no time to build in any mitigation. And South Africa, probably more than any other country, besides the fact that we are the only country that has an executive order against us, faces a far more disproportionate impact of these funding withdrawals than any other country for two main reasons. Firstly, the funds flow to South Africa to support research, either through the Overseas Development Assistance Program or through the National Institutes of Health. And South Africa has for many years, because of the very large burden of HIV and tuberculosis in our country, been the largest recipient of ODA funding through programs like PEPFAR, USAID, and CDC. And most of that funding was stopped summarily, resulting in over 24,000 healthcare workers who have been unemployed in this country, and thousands of researchers who've had to be retrenched from their jobs. But the other factor is because South Africa, a victim of its own success, has for many decades been the largest recipient of research investment from the National Institutes of Health outside of the US. And annually, we receive about 1% of the NIH's budget coming to South Africa. And so when one adds up the funding losses from the ODA support of research, as well as the NIH awards, either as direct awards to South African research groups or as sub-awards via American research groups or as part of network studies that are supported by the National Institutes of Health, all of which have got their largest footprint in terms of sites in South Africa. We are effectively losing a $600 million investment a year. And this is, if you can move to the next slide, please, Lisa. And so the impact of this funding withdrawal is having a huge impact on employment and livelihoods, as we are seeing researchers losing jobs as many universities are starting to retrench. There is a threat to research operations as many of the research programs are being terminated. But there's also a huge impact on postgraduate research training, as many master's, PhD, and postdoctoral fellows are losing training opportunities as the funding that paid for their stipends, their fees, and their training costs is all being terminated. And this, of course, will have an impact on our ability to build the next generation of scientific leadership in this country. Another major threat, which people are not talking about, is how this may fuel in this country the loss of trust in science, as our research enterprise may be seen as an exploitative one, which approaches the most vulnerable in society to conduct research and on a whim can stop the support. And so we really need to ensure that we do away with the narrative of an exploitative national health research enterprise as a consequence of these withdrawals. Next slide, please, Lisa. And so here I've just summarized the funding losses from some of the major research formations in this country. And you will see that there are hundreds of NIH grants in this country. I've not included institutions that have less than 5 of these grants, but you will see that the total funding per year is just under 1.8 billion rands, and with hundreds of staff employed and nearly 200 postgraduate students, which is a gross underestimate. And you can see the number of terminations that have been received, which are now already over 500 million rands in research grants. And it's important to mention that about 78% of these studies involve research on HIV and TB, about 40% of them being basic science studies and about 60% being clinical studies. Next slide, please, Lisa. And so as a response to these funding withdrawals, we really have consulted widely, and the feedback from our stakeholders has allowed us to be able to come to the conclusion that in the short term, we need to raise about 2 billion rands to address 4 key priorities in order to ensure sustainability of the national research enterprise. These are to allow the large research groups who've been very successful over many years to be able to keep key staff who can be able to apply for new grants, to allow them to be able to pivot their research programs over the coming years. Secondly, there are many early career scientists who had just received their first grant from the US, for whom their salaries, their entire research operations, their staffing were dependent on that one grant. And as these are being terminated, their research careers are under threat. And then 3, as many of these studies were interventional studies, as they are being terminated, we need to ensure that we support ethical termination of these and provide resources for follow-up of participants, particularly those who've received investigational products. And then lastly, something I feel very strongly about is that for postgraduate students and postdoctoral fellows who have been training supported by these grants, we need to ensure their ongoing support so that we ensure viability of the next generation of scientists in this country. Next slide, please, Liz. And then thinking about more long-term goals, we obviously need far greater contribution to support both health in this country, but also health research from the South African government. We are working with the NDOH, but also a number of other partners to see how we can model what the Foundation for the NIH in the US and the MRC Foundation in the UK have done very well, which is to leverage the support from government and look at alternative sources of funding to build an endowment that is able to build resilience within the system and to sustainably support health research in the country and region. And as a consequence of our success, we've had very good outcomes from applications for grants from the US. And we've neglected engagements with local philanthropy and the corporate sector for support of research. And this is something we're going to need to do better, but also working much closer with the European Union in supporting health research in this country. Last slide, please, Lisa. And so just to give you an idea of where we are, the SAMRC is leading a process of coordination of raising funds to support the National Research Enterprise. We are doing this on behalf of the government, but also on behalf of all universities in the country, as well as the other science councils that lead health research. And trying to do this centrally by leveraging our abilities in convening, granting mechanisms, human resource capacity support, our fantastic IT platforms, but also our capacity for contracting and legal compliance, our ability for monitoring and evaluation, and to generate timely and accurate reports. And the commitments we are starting to get, we envisage will flow via the SAMRC to support research groups in universities and other research entities in this country. And we bring this detailed analysis of the threat to the Parliamentary Portfolio Committee and to ask you to make the case to government for the urgent support of the health research process in this country, both in the interests of driving human development, but also building a knowledge economy that supports the growth of this country. So I'm going to stop there, Chair, and we will be happy to take any questions that you have.
I don't have we met you before? I don't know whether all our members know you, because
you've met me before, but I'm very happy to show my face. There we go.
Okay, yeah.
I hope you're all able to see me.
Yeah, it's just I can't remember whether we met you this year or after.
Yes, we have.
Okay, fine. No, thank you very much, Prof. Then you can then, yeah, fine. We would like to then take questions. Honorable members, there is the presentation Yeah, no, Prof, we can then close your video for now so we don't abuse you. You'll come back. When you do give us responses, also show your camera. Honorable members, you hear the last presentation was a great concern, but very much comprehensive. Professor Ntusi was able to show us not just MRC, but all other entities, universities that will be affected or are affected by this presidential order. Let me then allow you, honorable members, to raise questions, clarity-seeking comments to the team of South African Medical Research Council. Late to see which hand came first. I can tell Honorable Clerko came last. She's just clicked now, but I've seen Honorable Dr. Carl. If you came first, you are lucky. I saw this list. Number 1, Dr. Leroux. Number 2, Honorable Michelle Clark. Number 3, Honorable Mutubatsi. Number 4, Honorable Dr. Letape. And for now, the last is Honorable Peko. In that order, starting with Honorable Dr. Leroux.
Thank you very much, Chair, and thank you very much to the presenters. And yeah, thank you for the update of the recent challenges with the funding cuts that have happened. I just wanted to ask one quick thing around the goals of the MRC over the next 5 years. I see that there are kind of quite high targets for the number of articles that are being published, and I think that there is concern globally about the articles for article's sake rather than quality articles. And I just wanted to get a sense of what the MRC's take is on that. Obviously it's very different to get published in a big journal like the New England Journal of Medicine or Lancet, rather than a small journal somewhere in another corner of the world. So I think that obviously that's and I think that going along with that is the concern around also relevant research. And so I'd just like to get a sense of how the plans are in terms of just not only the quality of research and the quality of papers that are being published, but how the MRC is trying to focus on research that is relevant to South Africa and relevant to our context and our issues that we have. So that's the first question. The second question is around the funding, the NIH funding. And I mean, we could. It's very helpful to know this is a moving target, so it's a difficult thing to answer. But 21 out of 155 of the grants that have been given to UCT that have been cancelled, for example, have we got any sense of how much worse this is going to get? And has there? I know that it's been so sudden and done in such an unethical way, and a way that's harmful to research. we need a long-term response rate, and so. And long-term studies take time before we get to answers, and so in a sense, to stop a study after 2.5 years when it's a 3-year study is incredibly wasteful. But I wanted to get a sense of the MRC's focus approaches to that, and whether they know of any other studies, especially from the NIH funding that will come through. And I think that the third thing to say, and it's just a kind of a strategic question and a comment. I was quite struck by your focus on racial groups within your as your outcomes, and I understand that is part of the MRC's focus on trying to redress the past, but we also do know that there has been a very, very strong how should I say reaction to that by the current American administration, and so the question for me around that is strategically whether it's a wise way to be publishing that
to a government that is very negative about those kind of approaches and DEI approaches, and whether that might not put your funding under further strain. Thank you very much.
Honorable Clark.
Thank you, Chairperson. Yeah, it's very depressing when you sit and listen to this presentation. I mean, this is one of our entities that really do some really great work, and being stifled by what's happened, you know, from the USA. If I could just ask the following questions, some of them have been covered by my colleague. I mean, could you just give me examples of projects, research, etc., that have been impacted by the PEPFAR funding suspension? And what new funding opportunities, sorry, I forgot to put my camera on. Go. What new funding opportunities have been explored since the PEPFAR funding suspension, and what successes have you had in this regard? And what plans are in place to address each of your weaknesses and each of the threats that you've identified? Thank you.
Thank you. Honorable Mutubat.
No, thanks. Thanks very much, Chair. And thanks for the presentation, welcoming the presentation. I wish to start here, Chair. The opening statement or the preamble by the team from their slide says, the South African Research Council recognizes the catastrophic and persisting consequences of colonialism and apartheid, including land dispossession and intentional imposition of education and health inequalities. And we further say that we commit our capacities and resources to the continued promotion of justice and dignity in the health research in South Africa, close quote. I'm starting here, Chairperson, because I have struggled to extrapolate the participation and research by the institution in what has been presented towards promoting indigenous medicine, to put together what their preamble is, and with the ignorance that I found to be in volumes in the presentation towards the promotion of indigenous research and making sure that we preserve the indigenous knowledge systems. If the team can help me in terms of whether there is consideration, perhaps maybe I didn't see that, in terms of the budget commitment towards what I've just said in respect of indigenous medicine, the human resource that is available or that has been cajoled towards that area, if there's any specific research currently that is underway that is focusing on some herbs or some medicines that are of African origin. You remember that during COVID-19, there was a big of a hype in respect of why don't we go back to our herbs that at some point were considered to have contributed towards helping with COVID-19. My worry is that I don't see any commitment in that respect. And why are we not moving in that direction? Because I find it very contradictory to their statement if that is not the case, and if I have to struggle to extrapolate that within what they're presenting. The second thing, has there been any consideration, seeing that Trump and his administration are withdrawing funding in respect of research? We are within the BRICS family. We must not hide it. And one of the reasons why we're going to get a hiding from the European countries and the US is basically for that reason, and we must not be naive to that fact. Have this team considered the BRICS Health Desk to help and intervene in this regard? And if not, why can that be considered so that we save the load that we have, the work that needs to be done? Thank you, Chairperson.
Honorable Dr. Litlape.
Thank you, Chair. My questions refer to, the first question was, there's a slide that you showed about NHI grants and the distribution to our institutions. It could be helpful to me to frame my question if you could just show that slide. And while you do so, I'll proceed to the other questions.
Not
yes.
NIH instead of NHI.
No, NIH. NHI is bankrupt. NIH has all the money.
NIH. Yeah. No, I was correcting you because you said NHI. And I
sorry, sir.
You are referring to NIH. Yeah.
Okay. Thank you, Chair. I just wanted to ask, because I see a conspicuous absence of historically disadvantaged institutions in terms of benefits or grants from the NIH. Is there rationale for that? Is there any research occurring in our historically disadvantaged institutions? I know Caprisa is part of KZN, but we have Walter Sisulu University, Limpopo University, SMU. Do they get any, are they doing any research? Are they getting any significant funding? The second question is, how can you help us seek for mobilization of funding from the SETAs? Because they are sitting on lots of monies that are for training. And a lot of what you do involves training young scientists, etc. The third question, and it relates to some of the things that are happening in the US, where journals are being asked to explain themselves in terms of being perceived as being biased on particular matters to certain positions. What is the MRC's plan in terms of dealing with cancel culture in research institutions, where areas of disagreements are dealt with by academic bullying and labeling people as misinforming the public, misinformation? Certain sides are not allowed at tables for discussion. If so-and-so comes, if this group comes, we're not coming to the table. What we saw around COVID-19, what are you seeing around tobacco science? What is the MRC's plan in terms of that? And lastly, what are we doing to mitigate for the ethical treatment of subjects of research? I'm asking in particular about the post-study benefits to participants. And would it be useful for us to begin to ask a part of a national budget to be devoted to research in all areas, and part of it proportionally to be devoted to research in health in accordance with the size of the slice of the budget? Because if we're going to fund ourselves, unless we have a stake in the ground about the percentage of investment in research in general in this country, we're not going to be able to be self-supporting. Thank you, Chair.
Thank you, sir. Honorable Khako.
Thank you very much, Chairperson. Good afternoon to you, the members, and also our presenters. Chair, mine is not a question, rather a comment based on the presentation in front of us, and also our observation and findings as a committee that once did oversight in one of the research institutions in the province of KwaZulu-Natal. It is then that I, as a person, understood that South Africa is doing a very good job with regards to research work, Chair. When I visited that center and a story was narrated to us as a committee, including the successes of the center, of that center and other centers around South Africa. Chair, I think ours is to join the council in looking for funding opportunities. We don't have to explain ourselves as a country. What we need to do is to be proactive in order to find solutions. I also appreciate their detailed analysis of the situation, because they are also they gave us a detailed presentation on how that has affected them and the institutions that are dealing with the research. I think as a country, we must join hands and commit to increase the research capacity in South Africa. I just wanted to comment on that, Chair, to say that is the area that we have observed also as a committee on health. Thank you very much, Chair. Thank you to the Council for such a detailed presentation. Thank you very much, Chair. Thank you.
Okay, thanks. While one will support the question asked by Dr. Letlape, but maybe MSRC may not be able to answer it completely, to say when we receive grants and funding and support from NIH, we also equally motivate for Walter Sisulu and Sefako Makgato Invest to receive, but we don't know why they don't receive. Some decisions are taken at another level, but they may comment. It's just that it's a good observation, Dr. Letlape, that we really pointed out here. We probably should not be surprised. Is there a hand? Honorable Keko, your hand is still up, or is a new hand?
It's a legacy one, Chair. Sorry.
Okay, thanks. Just before the end of term of President Biden, there was, I don't know what you call it, a protection order or something for Dr. Anthony Fauci. Little did we know that it was actually to deal with this was Dr. Anthony Fauci is the head of NIH. And so it probably was saying, I don't approve what you are doing, and I'm going to deal with you and the institution that you lead. So these things that are happening there is not by mistake. They have been planned even before the new president takes over. We would like to know, and some of the questions have asked, are you finding dialogues with other institutions that we have mentioned, some of them here, whether what should we do? One is to say to the Department of Health, Science and Innovation Department, please increase for our support for now. We're struggling, we don't know what to do. Or can we find dialogues that are saying to us, let's look around and see whether there's no other country in the East or whether in Europe or EU that could assist us in the short or a long term with the challenges that we do face. Because as you are rightly putting, we are having a quadruple burden of disease. No continent like us has got both HIV and hypertension the way we do. We have not gone out of TB, HIV, and yet we are already swimming into the deep end with hypertension, cancers, and diabetes. So you need to do faster and better. In the event there is some fiscal injection to all of the institutions, but not adequate enough, are you looking elsewhere in the world? But are we probably getting the wrong way, because it is quick and very fast, that maybe we should be building our capacity in such an extent that we have our own in-house built support long-term, because what has happened from the US was going to inevitably happen anyway, whether it was going to be 2025 or 2030, and we should have been on a trajectory ourselves to prepare ourselves to be on our own. Someday, it might have been quite sudden, this one, but it would have been a very wrong understanding that we are going to be forever dependent on them for support. Please assist us with your responses, Professor Ntusi, your team that you lead. And then, the last one, I don't know, in the morning, Financial and Fiscal Commission said your budget this year is like an outlier. You have moved quite a bit from what you were budgeted for last year. And I said, I don't know whether maybe it's related to you foreseeing that there would be less and less funding coming in. Is there been a huge injection, not huge enough? Has there been a significantly big injection from National Treasury to yourself this time around on this cycle of budgeting, or maybe that was an abnormal observation from the other team? Thank you very much. Over to you.
Thank you very much, Honourable Chair. You see that I've switched on my camera. Professor Ntusi has had to excuse himself. He's addressing exactly the final set of slides, and he's hosting a funders forum, extraordinary funders forum this afternoon to attempt to get more funding for the research landscape as a response to this dramatic change in our funding strategy. And so he's asked me to take the questions and also field any comments from my colleagues. I'd like to start, if I may, to acknowledge the comments both from Honourable Member Clark and Trejo, to thank them for understanding and acknowledging the work of the SAMRC and the extremely challenging times that we find ourselves in. And we do appreciate those comments and the understanding of the fact that we are working incredibly hard at the moment to mitigate the issues that we are dealing with. There was one question from Honourable member around promoting Indigenous medicine and the funding that goes to those projects. And I was hoping that my colleague, Dr. Mulder, would be able to answer that. I'm just checking in with Mongezi, if you can unmute, and if Shelley is able to answer that question. I'm happy to answer it if she's not, but I'm aware that she would also be leaving, and she is in charge of our grants development and innovation platform, would be able to answer that question. Let me just check if she's able to do that. You are unmuted, Mongezi. I think there may be a problem because we're not able to hear you at the moment. In that case, I'm just going to start with the questions from Dr. Leroux. Thank you very much for those questions. We feel equally strongly about articles for article's sake. And we try to ensure that our both intra and extramural researchers focus their attention on knowledge dissemination rather than just putting out papers, that they avoid predatory journals, and that they give responsive and appropriate research in the various areas. So sometimes that does mean an NEJM paper, but sometimes, for example, it needs a commentary in the SAMJ because of the audience that you are trying to target. So one of the things that we do within the MRC, even though the targets may be high, is that it is very much nuanced by an understanding of where we need to publish, why we need to publish there, and what the target audience is. And so there's constant training around things like predatory journals, around choosing journals where the target is not clear, and being a responsive and ethical academic. So hopefully that has gone into the discussions that led us to choosing the particular number. In terms of your comments about the NIH funding, there is a clear sense that it will get worse. As you could see from the slide that I also projected earlier, not all of the grants have been terminated. And we are expecting that these grants will most likely get worse and that more will be terminated. We also are of the opinion that some of them may not be terminated at all, especially multi-year grants. But what will happen is that the funds will simply not flow. So it's called a NOA, the Notice of Award, or a Letter of Award, that these will just not arrive. And so your third or fourth or fifth year of a grant will not be awarded. There's also a sense that even UK grants, the ODA funding, Overseas Development Assistance, has also been decreased. And this may result in less grants, for example, from NIHR. Their grants, for example, their two calls that went out at the beginning of this year were both paused. And so there's definitely, it will get worse before it will get better. And that is the long term that we are looking at. We're projecting that in 2026, NIH, CDC grants, even WHO grants will be substantially reduced, if not completely gone. And therefore, we have to think in a much more long-term, independent and resilient fashion. Your final question, Dr. Leroux, was about the racial groups in the outcomes and whether this will affect the DEI target that we have on our backs in terms of NIH, CDC granting. We feel very strongly about those targets in terms of the responsibility to redress the past. But we do understand that that does put a DEI target on our backs. But at this point, we realize that that target is there regardless. And we don't make an excuse for wanting to redress and to award people in a diverse, equitable, and inclusive fashion, because our NIH funding is going to be lost regardless. So thank you very much for those questions, Dr. Leroux. I'm going to pass on to my colleague, Dr. Mulder, just for her to address the issue about funding for Indigenous medicine and Indigenous knowledge systems, which I may just add, we didn't include that in terms of this presentation, but we have included that in the past. But I'm sure she can fill you in on that a little bit more. Shelley, over to you.
Thanks, Liesl. Can you hear me now?
We can hear you well. Thanks.
Okay, wonderful. So thank you for that question. In fact, we've actually prepared a specific section for our annual reports for 2024-25 on how we're addressing IKS. So we're addressing IKS and African traditional medicines in...
On your camera, are you able to switch it on?
Oh, sure.
If it is not possible,
yeah.
Oh, yeah.
There we go. So I'm sitting with my colleagues in the EMC room here. So we're addressing the IKS traditional medicine approach through what we call an ecosystem approach. So we have a number of different ways that we are looking to support this. We're looking to support an entire ecosystem. So what we're doing is we're recognizing that there isn't a strong precedent of taking a traditional medicine through a full scientific validation into clinical trials. And so we're funding two specific projects, both from traditional healers and both, in fact, in the HIV space, to take these products through from really sourcing the medicines, the plants, going through the processing, understanding what the composition is, standardizing the composition, doing the confirmatory tests within the laboratory in collaboration with scientists at our universities, and then taking them through to phase 1 clinical studies. So as I mentioned, we're supporting 2 such projects. We also have within our biomedical research and innovation platform at the MRC, the capability to do screening and toxicity testing on such medicines, and also looking at drug herbal medicine interactions. So that is a capability that's available. And we have funded that program to offer that as a service to traditional healers who want to come and have their medicines tested. This is now ballooned into actually a national consortium, which involves a number of the historically disadvantaged institutions who are all collaborating and who all actually offer a part of the total package in terms of screening for activities, toxicity, etc. And then we also have our herbal drugs research unit at TUT. So that is another unit that we're supporting, looking at scientific validation of traditional medicines. So yeah, that is the way we're supporting. And as I mentioned, getting back to the ecosystem approach, is we're making sure that we can fulfill each part of the value chain so that we can support more of these medicines in future to go through scientific validation into clinical studies. You want me to address the BRICS question? So there was a question around tapping into BRICS funding. So we do, obviously part of the BRICS STI collaboration, science, technology and innovation collaboration. And through that, we have a number of joint programs. So the one is the BRICS TB Research Network. And another is the BRICS STI COVID-19 project. So this is where we have partnered with other BRICS countries to support specific collaborations in the area of COVID-19 research, and previously actually in other areas as well. The one thing to mention about these though is that the funding is still coming from the South African government. So this is through the DSTI's bilateral and multilateral collaborations on the BRICS. So that funding is coming through there. We don't actually receive funding directly from any of these other countries for those projects. We fund them ourselves at this point.
Shelley, may I ask you just to answer one of the questions from the Honourable Member Clark? She asked about examples of projects that had been closed, and I thought you could maybe just give a very brief synopsis of the Brilliant project.
Sure, thank you, Liesl. So this is one project which is substantially a substantial size, which means really a large impact. This is the Brilliant program. It was funded by USAID to the tune of $45.6 million. We had just completed year 1, and we've only drawn down around $3.5 million of that. The rest of that will obviously no longer be coming to the country. It's a program that is being run by the MRC, but in fact, most of the activities are happening with our partners. And those are partners in 8 different countries who are all now affected. So we've had to completely terminate that program. What I can say about that is that 2 components of that we are trying to still pursue. The one is a clinical trial, which we call Brilliant 001, which was to test a number of vaccines in different combinations that have come from other groups around the world. We had already imported those vaccines into South Africa, and we were about to start the trial in February, just shortly after the termination or the suspension order came in. We have been, so Professor Glenda Gray, who runs that program, has been actively fundraising, and it looks like we might be able to secure some funding to still proceed with that trial, but on a much smaller basis. So just 2 sites in South Africa, and a lot less arms to the study. The other component which we are able to pursue now on a short-term basis is the vaccine development, which is happening in South Africa. We have groups at UCT and Wits University who are developing mRNA-based vaccines for HIV. And we are very fortunate that the ALMA Vaccines and Immunization Foundation came in with their relief funds and have offered 6 months worth of support so that that program can continue until we can find additional funding to pick that program up again. Thanks, Lisa.
And thanks very much, Shelley. That's very helpful. And it also addresses, in a way, Honourable Clark's second question was, what are we doing in terms of trying to find other funding, and what are we doing to try and terminate or continue with the studies? So that actually is the type of approach that we've taken. We've either of the other studies that have been terminated, either looked to see what is the essential elements of that study that needs to be completed to protect our participants and protect the science, and then actively fundraised for that specific area. Also looked at different funders. You've mentioned BRICS, but for example, instead of, we don't really get funding from the BRICS countries. We more go in as a collaborative. And so there is, for example, some discussions with our HIV vaccine counterparts that also had their funding terminated, whether we go in together in a new application to a different funder. Here we're targeting Wellcome as a potential funder, also targeted philanthropic agencies directly. European Union was mentioned by our president, Horizon Europe. South Africa is core to that. And so we've been looking at EDCTP funding. So there's a lot of work going on to scope for funding and to package, especially studies that have already started and will now be terminated before their time, into these various funders. What the honourable members do need to be aware of is that funding takes a very long time. From the time that you have a proposal until you actually get funding in your bank account can sometimes take as long as a year, if not longer. And this is part of the problem that we sit in at the moment, that we probably need gap funding to get to the point where we see successes from our applications. Our MRC researchers and the researchers in this country are extremely well regarded, write exceptionally good protocols and proposals, but there is at least a 3 to 6 month interval between writing a grant and getting it awarded, and then sometimes at least another 3 months before any funding starts to flow. The other question from Honourable Clark was around successes, plans, weaknesses and threats, and how we are dealing with those. I probably would say that to answer that question in its entirety would take the rest of all of our time allocated. And so I reflect you back to our SWOT and pestle analyses, where we are focusing on each of those areas and trying to have a series of mitigating responses to each of those threats. Obviously, threats sometimes come singly or they come over time. This is a threat that's now, gone right to the top of our risk register. And we've always talked about diversifying of funding, because we knew, as our chair has mentioned, that this was going to come at some stage. We just didn't realize it would come all at once. So this is where we are focusing our major attention at the moment. But we also look at all of these threats on a very regular basis and consider ways of mitigation. I'm then going to move on to the question from Honourable Letlabe about the NIH grants and HDIs. This is also a very important point for our colleagues to be aware of. So the NIH has always had very rigorous governance structures. It's quite difficult to get an NIH grant, not just from the point of view of the science, but the point of view of the administration that is required. And only certain universities in our country have got the administrative support to manage a NIH grant, and that is not based on our perception, but the NIH's perception. So the NIH does not have grant regulatory mechanisms at some of the universities to be able to apply for NIH grants, which speaks again to the concept of the power that's being held, or that was held by our Global North funding agencies. And so when we look at all our HDIs, none of them are directly affected through NIH because they cannot receive money directly from the NIH. But one of the other issues are the sort of secondary implications, and there will most definitely be secondary implications of the loss of federal funding to HDIs, in terms of that a lot of the universities or institutions, for example, our own, that have got very strong links with HDIs, the funding comes to us and then helps to train, for example, researchers at HDIs. And if we don't get the funding, the training will also stop. So one of the other reviews that we're doing at the moment is to get a sense of the secondary analyses and the secondary impact. And that's why we say, even though it's only these few universities that are the primary loss at the moment, the loss to our entire research landscape, including HDIs, will also be felt. The next question was just about, again, mobilizing other sources of grants or sources of funding, such as CTAS, and we are certainly looking into all of those. There are, for example, funders that don't fund research, but they fund capacity development. And so this is the kind of things that we are undertaking at the moment, and that will be discussed, as I mentioned, at that funders forum as well. The next question was about cancel culture and the distrust in science. And we agree with the honourable member that this is a major issue in the world at the moment in terms of misinformation and mistrust in science, and the concomitant culture that has arisen. Again, something that we deal with and discuss within the MRC on a regular basis. And we are aware that the current issue and the current landscape may certainly make that more difficult and more challenging. And here we're working very closely with our communications team, as well as our research integrity office, and of course also our research stakeholders, to be able to address that. And then the last two questions I'm going to hand over to my colleague, our CFO, to address the issues of the national budget and the changes in our budget from last year to this year. But I would also just like to reiterate the call in terms of our national budget, that what we do, what would be particularly important at this time would be to have support from both all of yourselves, but also our national budget, our National Department of Health and our government, in terms of supporting the MRC and the research environment in terms of budget. So over to you. This is not Mongezi. We're not able to hear you well from that computer. We could hear Shelley very clearly. Apologies, Honourable Minister, Honourable Chair. We obviously have a problem in the EMC room today.
How is it now?
That's much better, thank you.
Thank you, Lizel. Thank you, Chair, and to the committee members. Name is Sibuile Ngongwa. On the question that was raised regarding the budget having ticked up a bit, or being higher than the previous financial year. I think largely the explanation to that would be the fact that in the financial year that ended 31st of March 2024 is the year where there were budget cuts that were announced by the National Treasury around about August 2023. That process, we had to cut about, for the NDOH, we had to return to the National Fiscal about 72 million rands. That 72 million rands, 37 million of it was coming out of SAMRC, and we could afford at the time to take the cut as we were generating enough from our contract funders. So if you compare the budget of 31st of March 2024, it's around about 760 million rand versus the budget for the year ending 31st of March 2025, which is sitting 100 million rand extra. So that gives an impression that there's been a jump, but in reality of it doesn't take into account that there were budget cuts that were effected of 37 million rands. If you adjust or you add back the 37 million rands to the 759, you get about close to 800 million. Then the increase also of a 60 million rand, it is quite in line with the National Treasury increases. So that is my response around that budget increase. And if we look perhaps if there's a need, another impression that could give a sign of increasing budget would be the fact that, which will be a reality of it, if we look from the 2021-2022 financial year, the contract funding was at 38%, but over the years it's been increasing until 31st of March 2025 to almost 50% the baseline and 50% contract funding. But overall is that our budget, it's fairly in line as far as the baseline is concerned, but there's been a jump around contract funding, of which we hear now there is threats around the contract funding. We will expect that it will go down. Chair, the other question that was raised was if there are any other fundraising methods to close what we an in-house help. I think Professor Ntusi did mention the fact that we are looking at various efforts of fundraising, be it fundraising again from the National Fiscus, talking to National Treasury. However, we do realize the fact that we have to fundraise as SAMRC on behalf of the whole science community of South Africa. We cannot take a view that only prioritizes SAMRC. So the efforts are focused on ensuring that we do raise funding from the national government and as well from abroad and other sources of funding, be it through philanthropy causes, both in country and out of the country. And again, we are in a process of setting up the SAMRC Foundation, as mentioned earlier on, to ensure that we're able to generate funding outside of the National Fiscus to boost our finances. Thanks, Chairperson. Anything else?
Thanks very much, Sivu. And Chairperson, I think I've completed all the questions and I hand back to you. Thank you very much for the opportunity. I see our chair is not able to unmute at the moment. I hope that all the questions were addressed. Perhaps if there are any other questions, we are not quite at our time yet. I'm happy to have any others if there are.
I think we have lost the chair. He has written something on the chat. Can we keep the fire burning? Like thanking the delegation from South African Medical Research Council for such a presentation. We got it all as a committee. We thank you for your time. All those that participated in your preparations for this meeting. We thank all of those. Thank you very much.
Thank you very much.
You can leave the platform so that
Madam
we are
Chair?
able to. Yes.
Before they leave, I just have a question. I had a question about post-study care of participants. But in addition to that, I just want to hear from them what their attitude would be if we were to come up with a research levy across all sectors, all employers, just like we have a training levy. That could then ensure that we have enough resources to fund research, or we can contribute to better funding of research. Thank you, Chair.
Can the team identify whoever that can respond to those two questions as asked by the good doctor? Over to you.
Yeah, no, thank you very much, Dr. Letlabe, for that questions. So the issue of post-study, how we deal with our participants post-study, very important as well. Important to realize that each study or trial that has been terminated have different the questions are different, the length that the participants were meant to be in the study is different, and when the study is terminated is different. So in a way, we have to do that individualized to every trial, and sometimes even individualized to every participant to ensure that, because the most important is the safety and the health of our participants. So we do focus on that. One of the more recent trials was the lenacapavir study. This was a prevention HIV injectable preventable every 6 months. I'm sure you've all heard about that study. But that study has actually come to an end. But what we were in now was a follow-up phase. So 2 more years of follow-up just to look out for, advanced effects, further complications, etc. And so even though that is not going to be funded anymore, we will continue to do that, except we will now probably do it remotely, so to decrease the costs. Bear in mind also that the funder is not going to fund this extension. They've terminated and they've said all activities on that particular study needs to come to an end. And so us as the MRC, as responsible, ethical academics, will continue to monitor the participants on that particular study. But for another study, for example, like the Brilliant study, where it was terminated so early on, and they're not significant numbers of participants that came into the study, or there's not a interventional product or a intervention mechanism, the approach will be, as one can say, probably a lighter touch. But we will always make sure that complies with the highest level of research integrity and ethics. And we work closely with our research integrity office around that. Your idea about a levy for resources, we think that this is the time for all of us to think out of the box and to think of more innovative ways to fund health research. We all know that health research, we have put targets in terms of GDP allocations for research, and we don't meet that in South Africa. And this may be a time to consider that and see how we could do this in a different way. We've also talked about the levies that are on things like sugar-sweetened beverages or on tobacco, and how those levies are used. not just for health promotion and prevention programs, but also for health research that led to evidence-informed policies such as that. So I do welcome that suggestion, and I'm sure there are other suggestions like that that you as a parliamentary portfolio committee can suggest to the colleagues so that we don't find ourselves in this position in the future. Thank you very much.
Thank you. Those were the responses to two sets of questions. I think we are done. We can release the team now. Vuyokas will assist us to get the next team. Let's just give a 5 minutes break so that we are able to trace if the chair is able to finish what he has just started. We are left with one presentation now, but Vuyokas must tell us which team was going to be the next one. Let's appreciate the presentations done so far. Thank you, Vuyo. What is it?
Thank you very much.
Thank you. Yes, thank you very much, Doctor.
The next presentation is the Office of Health Standard Compliance, and they are supposed to join at 4. They are starting
They're
at 4.
supposed.
Yeah.
That means, Vuyo, we can take that break. We have a saving of about plus minus 30 minutes. Chair, are you back? Not yet. If that team is going to join at 4, maybe we can, Vuyo, just shift from 4, just some minutes, maybe to say quarter to 4, so that we also make time in preparing for tomorrow's meetings. Can you check on them, Vuyo, whilst we take a break as the portfolio committee? We will, on that time, check if the chair's program has been solved, the problem. Thank you, leadership. We will come back at quarter to 4. Thank you. Thanks, Chair. We see your response. Thank you.
Thank you. See you at quarter to 4.
Yes, it's quarter to 4. Vuyo will update us if the quarter to 4 does not suit the team, but let's take quarter to 4. Let's be back at quarter to 4. Please, members. Thank you.
Anybody back?
Endorsed by ANC veteran Tokis Akwale, who endorsed Bashir as the next president because of his what he called inverted commas transformative leadership style. And Akwale, of course, cited Mashatir's accomplishments in Gauteng, which influenced the provincial government's decision not to enter into the government of provincial unity with the Democratic Alliance in the province of Gauteng as well. So those are the dynamics which are unfolding currently. And what we also understand is that we
Is the chair back, Dr. Litlape? Are you there?
I am here, but I haven't
Okay.
had the chair.
You haven't had the chair.
I haven't had the chair being back. I see he says he cannot unmute his new device.
Okay. Let's. Is there a presentation? I'm getting some voices at the back.
I was told that the chair of the Office of Health Standard Compliance and the team have joined the meeting.
Okay.
Let's
check.
Message from Vuyo.
Okay. Can you check Vuyogazi? So that we can start with the presentation.
Good day,
Hi.
Dr. Kinoshi. Who can I give the co-hosting rights to for the presentation?
Okay, good afternoon, members. I am with the acting CEO, Dr. Matebula, but also the CFO, Mr. Julius Mapata. So I think both of them will be doing one presentation, but they are not sitting together. So if we could give them, Dr. Matebula is in the meeting, and also Mr. Julius Mapata. I just want to make sure he's in the meeting. Mr. Mapata, are you in the meeting?
Yeah, yes, I'm in the meeting, Chair.
Yeah, it's one presentation, but he will do the budget part of it. He's a CFO of OHSC. Thanks, Chair.
Thank you, Dr. Kinoshi. I've given both of them co-hosting rights. Thank you.
Thank you very much.
Thank you very much, Vuyo. Let's apologize to the team because they were advised to join at 4 o'clock, but we were able to save some minutes from the previous presentation. So that's why we invited you earlier on. If you are here, Doctor, can one who's supposed to start with the presentation? The members of the committee are here. The chairperson is connected, but he has a problem with the gadget. He is he's unable to unmute himself, but he is connected to the meeting. We are all here with our administration, and it seems as if you are here. The platform is yours. You may start by introductions, whatever, but we are giving you up to maybe 35 minutes to make your presentation, if that sits well with you. Over to you, Doctor.
Okay, thank you very much, Chair. Mine is just to introduce myself as Dr. Ernest Kinoshi. I'm the chair of the board of the OHSC, and that gets appointed by the minister every 3 years. Some of the board members will join. I've just sent them a message that we are starting a bit earlier than 4 o'clock. So some of them may join later, board members. But I'm also accompanied by the acting CEO, Dr. Matebula. Dr. Matebula is normally the Chief Operations Officer at the OHSC. She's the COO, but the CEO, Dr. Mdaweni, and I'm also tabling her apologies. She's traveling out of the country until the end of this month. So Dr. Matebula is currently the acting CEO. She will do the main presentation. And then we are also with Mr. Julius Mapata, the CFO, who will assist Dr. Matebula when she'll take part maybe halfway through the presentation. It's the same one presentation. and she'll do the budget part before we take questions. I think, Chair, if you allow, I can allow Dr. Matibula to share her presentation and start the meeting when you allow her to do so. Thank you, Chair.
Thank you, Dr. Kinoshi. Let me first start by checking with Vuyokazi if the members are connected. Are the members there, Vuyo?
Yes, they are connected, Mamka.
Okay, thank you. Let's give it back to you, Doctor, in that order.
Thanks, Honorable Keko. I'm also connected. Move ahead, take over. I will come in at the time when they finish the presentation. Thank you very much.
Thank you, Chair. Can the team start with the presentation?
You can go ahead, Dr. Matibula. We can see the presentation.
Good afternoon, Chair, members. Thank you very much for the opportunity. I don't think, okay, I hope the presentation will move. OHSC, as we can see, I'm Dr. Matebula representing the OHSC today. And I'm struggling to see the presentation myself. I've shared it.
The presentation
is on the screen.
It's showing on our side. Yeah. Otherwise, I can ask Julius to share from his side.
Yeah, maybe Mr. Mapata can share. Let me unshare mine. Mr. Mapata, please share from your side. Whilst Mr. Mapata is sharing, just to, I can see it now, Mr. Mapata. Thank you. If you can put on the slideshow. Thank you so much. We are here to present the strategic plan for 2025-2030 and the annual performance plan for 2025-2026. You can go to the next slide, Mr. Mapata. That is just the overview of our presentation. Next slide, Mr. Mapata. Yes, the Office of Health Standard Compliance has developed this strategic planning and the annual performance plan with the 8 policy priorities that were identified. And these policy priorities were identified in consultation with various stakeholders. You'll see as we go ahead how many the stakeholders that we met that had inputs into our strategic planning, leading to 8 policy priorities. And then we can go to the next slide, Mr. Mapata. Okay, just back, Mr. Mapata. Just in summary, the strategic plan, and the same as the annual performance plan, has 6 strategic outcomes, 25 output indicators, and 25 annual targets. Next, sir. This is the board of the OHSC. Next slide, Mr. Mapata. This is the 4th strategic plan, but you'll see that the first and the second one overlapped at some stage, with the office being a new office or the new organization, public entity. Next slide, Mr. Mapata. Just the mandate. The OHSC derives its mandate from the National Development Plan, the National Health Act 61 of 2003 as amended in 2013, Act 12, and also the Midterm Development Plan 2025-2030. And that is the mandate of the office as per the National Health Amended Act of 2013, Section 78. The objective of the office are to protect and promote the health and the safety of users of health services. This is done by monitoring and enforcing compliance by health establishments with norms and standards as prescribed by the Minister of Health in relation to the national health system. Also, we do that by ensuring consideration, investigation, and disposal of complaints relating to the non-compliance with prescribed norms and standards for health establishment in a procedurally fair, economically, and expeditious manner. That is the vision of the office and the mission. We have values, as you can see, and the impact is that we would like to see a safe and quality healthcare services. Next slide, Mr. Mapata. Mr. Mapata, the next one. The same, the policy mandates come from those listed policies and acts. The next slide, Mr. Mapata. Now, there's a linkage in the functionality of the OHSC to the NHI. And you can see because the acts, both the National Health Insurance and National Health Act, are stating that for the NHI to accredit any health establishment, that health establishment should have been certified to be providing quality and safe healthcare services by the Office of Health Standards Compliance. Next slide, Mr. Mapata, please. Now, when our development of our strategic plan started with us conducting some situational analysis, we used SAW, Mr. Mapata. Next slide, sir. We analyzed our strengths, opportunities, aspirations, and results. We also, they are there color coded. Next slide, Mr. Mapata. We also use the pastel analysis to come out with what we finally make it a document for our strategic plan and therefore the APP. Next slide, Mr. Mapata. These are the stakeholders that inputted into our document, that we had engagement with these stakeholders in June and July 2024. And there were 39 of these stakeholders. Next slide. We can go to the next one. Next one. These are just the three organizational structures. Go on, Mr. Mapata. Here we just wanted to illustrate that we were an office that has been in existence since 2013 when the National Health Act was amended, and then 2015 we started being an office, and we started then inspecting in the year 2019-2020. Yes, we did, like all organizations, have effects of COVID-19 as we're just starting to inspect. Hence, you'll see lots of red when coming to inspection. Otherwise, we have achieved in the main. Next, Mr. Mapada. This is just a continuation. Let's go back forward, Mr. Mapada, is the years. Next slide, Mr. Mapada. Next one. Another slide. I won't spend time on the previous because we are talking about the future. Now, the strategic plan, Mr. Mapada. We have already alluded to the fact that we have got 8 priorities as listed there. First one is to progressively scale up the inspection to fulfill the OHSC mandate, to advise the minister and the provinces on quality across the health system, reviewing of the norms and standard regulation and include clinical outcomes. You will understand why we have those priorities as such. Implement the full array of enforcement action, financial sustainability of the OHSC through revenue generation. We want also to scale up communication and brand awareness initiatives, also to strengthen the complaints management as well as alignment of the OHSC mandate with the NDOH and the National Health Fund for regulatory coherence. Those are the priorities, and the priorities, like we have said, are now taking the OHSC from where it has been an office that was being established to a fully functional office. Next slide. We did indicate that we have got 6 outcomes, strategic outcomes, which is number 1, highly effective and financially sustainable OHSC is the same, and then increased communication initiative in profiling the office programs, improves inspection coverage of health establishment, improving the quality of health care services and patient safety through implementation of Ombuds's recommendations, improve access to health care services through registering and profiling of health facilities, as well as enhancing public trust in the safety and quality of healthcare services. Next slide, Mr. Mapada. Now, we have these targets. The target number 1 comes from the highly effective and financial sustainability outcome. We say we have got we are targeting to have, I won't mention the indicators unless Chair, you say so, but just to say the target there is that we want to sustain our trend of unqualified audit opinion, as well as generate income ourselves, revenue. Currently, we are completely dependent on the funding from the National Treasury, and that is not sustaining us because it limits our ability to expand. We are aiming that in these 5 years we'll raise 15 million through revenue generation. The difficulty there is that majority of the health establishments that we have at this point in time, we are sharing the coffers of National Treasury. We are getting from the National Treasury, but OHSC is aiming to charge for fees as mandated by the Act as another source of income. The next one is the OHSC program, and we will do that up to the target of 100%, the same as the improving inspection coverage of health establishment. We say 100%. We say 100% because we are referring to the health establishments that are in our profiling and registered with the OHSC. The next one is the improved quality of healthcare services and patient safety through the implementation of Ombuds recommendation. We said we'll do that. We'll reduce to 70% of safety incidents and adverse events from where we are. And then we also would like to improve access to healthcare services through registering and profiling of health facilities. We want to profile and register 3,948 as well of public health establishments and 4,820 of private health establishments. That is inclusive of the general practitioners. We'll talk more about the general practitioners going forward, and we'd like to enhance public trust and safety and quality of healthcare services to 100% by certifying the quality complying health establishments. Next slide. Now that is our strategy for the next coming 5 years. Coming to the annual performance plan for the year that has just started, 2025-2026. Next slide, Mr. Mapata. We have 5 programs. Those programs are the ones that we have had ever since the establishment of the office. The first one is the administration. The second one is compliance, inspection, third, Ombud, as well as Program 4, Health Standard Design, Analysis and Support, and Certification and Enforcement. Next, Mr. Mapata. That is the purpose of Program 1. Like we have said, is about the support, and it has got sub-programs: human resource, information, communication, and technology, finance and supply chain management, community and stakeholder relations. Next slide, sir. And then each program, we have enlisted the sub-programs. We've also stated their purpose. That is the purpose for the sub-program human resource management, and then it has got those 3 outputs, indicators. Number 1 is integrated human resource strategy. And we want to produce that document this year, this financial year, 25-26. And then we will also monitor the percentage vacancy rate per year. We said each year will be 6 years for the MTF. And then we have an output indicator of a percentage representation of women in SMS position. We want to achieve 50% in this MTF. Next slide. Sub-program information communication technology. That is its purpose. We can move to the next one. The output indicators for that over the MTEF, we say we'll be looking at the percentage of uptime of the critical systems, and we want to achieve 96% there. And then number of enhanced system to support functionality. We are busy upgrading our information system such that it comes closer to the modern way of technology. We are not going to be there as yet this financial year, but that is what we are trying to achieve. And we say we'll enhance 3 in this financial year, next financial year, 3 programs of the system and 1 in 2027, 2028. Next slide. The communication and stakeholder relations, that is another sub-program of program 1, that is its purpose. Next slide. Here we have got 3 output indicators. Number of engagement to profile the OHSC, 24, number of media initiative to increase awareness of OHSC, we've got 4 over the MTNF, and then also number of digital campaigns to profile the OHSC program, 24 of them each year. Next slide. The last one is finance and supply chain management. That is its purpose. Next slide. We want to sustain the unqualified audit, as has been the case since the establishment of the office. Next slide. And then the next program we said is compliance inspectorate. That is its purpose. We can move to next slide, Mr. Mabada. It has got the 4 output indicators. If I think they are too long and looking at the time, I won't read one by one, but those are just in summary is about the percentage of health establishments, public and private, that will be inspected and also have re-inspection in cases where they don't comply with the first inspection, and then also the annual reports. Next slide, Mr. Mabada. The next program is the complaints management and the health ombuds. Next slide. Also, it also talks about the low risk complaints, the time it will take, how many we will resolve, the medium, the rating of the risk of the risk rating of the complaints, and the other resolution, the same as those that will be investigated, their resolution rate, the same as the also the complaints that are to be resolved within 24 months. The next slide. And the targets are put over the MTF as well. Next slide, Mr. Mabada. This is the health standard design analysis and support and its purpose. Next slide. It has got those 3 output indicators, and then we have listed how much we'll do over each year. Next slide, Mr. Mabada. This last program is the certification and enforcement. That is its purpose. Also, if I may be allowed not to read each output indicator, just to state that its main functionality is to achieve 100%, except for the percentage of enforcement action taken against non-compliant health establishment resolved within 90 working days, is because that one has got some dependence on the health establishment that is having an enforcement action being taken to. The next slide. Now, the next slide, I will hand over to the CFO, Mr. Mapata, to take us through. Thank you very much.
Thank you. Can the CEO get in and take us through the finances?
Thank you, Chair, and good afternoon to the honorable members of the Portfolio Committee. I just want to check whether the slides are moving. They don't seem to be moving from my side now that I'm speaking.
Mr. Mapata, assist, please. I now know you.
Is
the one struggling. Sorry.
Yes, I was sharing earlier. Now the slides are no longer moving now that I unmuted myself. I will try. Thank you, Chair. They are now moving. On this slide, we just wanted to demonstrate that we are working on a 191 million rand budget for 2025-26, which is a 5.6% increase on the 2024-25 budget. On average, over the MTF period, the budget increases by about 4.7%, just below 5%. And going to the next slide. And on this slide, Chair, we just wanted to show the distribution of the budget, that there is 5% in 25-26 of the budget goes to the Compliance Inspectorate, and with all the other programs. And on this slide, it will show that the core functions of the OHSC receive on average 62% of the budget, and the support functions receive 38% of the budget. And on this slide is what I was just explaining now, just to list what the core functions are: the Inspectorate, certification enforcement, complaints management, and the health standards design, analysis, and support. And the support functions are listed on this page. In terms of the employee distribution, 38% of the total staff complement is in the Compliance Inspectorate, with the other programs receiving the difference. Now, on this slide, we just wanted to show that 73% of the total staff complement is in the core functions of the OHSC, and 27% of the total staff complement is in the support functions of the OHSC. And on the next slide, given the nature of the work of the OHSC, which is largely dependent on human resources, compensation of employees makes up the biggest allocation, followed by the goods and services, together with the capital expenditure. And on this slide, just to emphasize or confirm what I was indicating, that 71% of the budget is compensation of employees, and 29% is for all other services. And these are the key considerations I've already indicated. The staff complement of the OHSC will increase from 142 to 143 over the MTF period. As I indicated, 73% of the 143 is in the core functions of the OHSC, and 27% in the support functions. And there are a number of areas of concern. Firstly is the area related to the re-inspections, where the number and location of facilities to be re-inspected is unknown, as it depends on the compliance status. So during the course of the year, that's where we try to accommodate all of this, but at the time of planning, these are normally not known. This also applies to the risk-based inspections that are triggered by the early warning system and any other media alerts, as well as in unpredictable costs pertaining to legal fees, And we have also noted that the complexity and duration of complaints investigations will differ on a case-by-case basis, and that can also take a bit of time. So it's one of the unpredictable areas. And that is the conclusion on the budget update. I'll give back to Dr. Matebula to finalize on this last slide. Thank you, Chair.
Can you do as such?
Yes, Chair. Apologies, Chair, I was talking muted. My apologies. Just the remaining 4 minutes, just to indicate that we are busy finalizing the development of the inspection tools for the emergency medical services, as well as the mental health hospitals for both public and private sectors. The development of inspection tools, as you can imagine, Chair, takes anything between 18 to 24 months or beyond, depending on the availability of the end users, the stakeholders, experts in the field. We rely on them. And then we also, as an office, will produce a recommendation report with practical and impactful guidance aimed at supporting the health establishments and the provincial health departments in addressing the common challenges and improving service delivery, because of our experience ever since our existence, we have established where the gaps are and what it is that can be done. And then we also would like to continue to inspect and certify the health establishment in our mandate to protect and promote the safety and quality of healthcare users, and assuring quality through assessing whether health establishments and healthcare providers comply with prescribed norms and standards. We also would like to conduct risk-based inspection in public and private health establishment to monitor safety and quality healthcare for users and respond and act timelessly to the reports on indicators of risk and breach of norms and standards, regulations. OHSC will continue to work closely with the health ombuds to resolve complaints of non-compliance with the regulated norms and standards. OHSC will invest in agile information and communication technology system to realize efficiency and effectiveness in business processes. The board, together with management, will continue to provide the range of skills, expertise, experience, and ethical leadership to develop a balanced approach to how it will deliver on its mandate. That is in conclusion, Chair. Thank you very much.
Thank you very much. Thank you very much, Doc. That was the presentation by OHSC. There were those that joined later. We also welcome them to our meeting. Earlier on, we had Dr. Ernest Kinoshi and Dr. Matebula. And Mr. I've just forgotten the name. Who was Mr. Matebula, who was sharing the screens. That was the presentation. Do you have anything to say, Dr. Ernest?
Yeah, Chair, I think this is a presentation that we have prepared with the Executive Committee as the board. And I think we are in your hands, Chair and members, for any questions or any discussions, comments that I think we will try to field together, the three of us. And if there are any, I see one or two other executive managers have also joined us. And as I said before, some of our board members have also joined, but we will field the questions as a team. Chair, over to yourselves.
Thank you to the good doctor. That's why I was welcoming those that joined later. It's because we are the ones that disorganized you because you were ready for 4 o'clock and we wanted you before that time. Members, there you are. That was the presentation. But Vuyo will assist me in acknowledging hands. I may be unable to do so, but your time is now, members, to indicate those who would like to have a bite on the presentation. You may comment, you may ask some question, you may do whatever. Over to you, members.
I can assist you now, my chair. You have really been of great help. I can now take over with the following hands that have already come up. The first one was Honorable Michelle Clark. Second hand was that of Honorable Van Staden. The third is Honorable Dr. Leroux. The fourth now that has come up is Honorable Mutubatse. I would imagine, okay, then the next one is Honorable Leklape. I would imagine the chair who has been holding the fort will also be asking question. I don't know. Honorable Treko is not asking.
Yes, Chair. I'll be the last one. Over to you now. Thank you very much.
Thank you very much for assisting me. I took a bit of time to learn how to move from one gadget to the other, and that's why I've not renamed it. Now I'm like Honorable Mutubatse failing to rename a gadget. Let us start in the order of Honorable Michelle Clark, followed by Honorable Van Staden, third Honorable Dr. Leroux, fourth Honorable Mutubatse, number 5 Honorable Dr. Leklape, and the last one Honorable Treko. Thank you.
Thank you, Chairperson. There's just a couple of questions I would like to ask. I think my camera is now playing up. I'm just going to, oh, there we go. There we go. Okay. The first couple of questions that I would like to ask in terms of the presentation, which of the OHSC's core functions does it want to automate? Regarding facility self-inspections, how do the results from self-inspections correlate with the OHSC's findings of facilities? What measures does the OHSC have in place to prevent dishonesty and within these self-assessments? How does the OHSC ensure compliance from facilities that were previously found wanting? And how often are facilities re-inspected? Of the re-inspected facilities, what percentage has improved? What is the progress on decentralization? And what is the reason for the shortages of inspectors? And I also noted, you know, in terms of that line item, the achievements weren't achieved in terms of the strategy. And I just want to find out when do they anticipate to fill these vacancies, and are these vacancies funded positions? Then, Chair, just on a note of comment, I just want to congratulate the OHSC for getting an unqualified audit, and also just to highlight that, you know, the issue around the Rahima Musa Hospital between the OHSC and the Ombudsman. We visited that hospital last week. And Chair, I have to tell you, I cannot believe the improvement at that hospital. I think as a committee, it would be very good that we go and visit that hospital. From the recommendations that came from that inspection and investigation and what has happened at that hospital since that report was released. It's unbelievable. The change, the positive change we noted at the Rahima Musa Hospital. Thank you, Chairperson.
Honorable Dr. Leroux. Oh, sorry, Van Staden. Sorry.
Thank you, Chair. I thought I had a name change, but thank you very much. No, I see on the slide that the slide which shows the the number of staff members in the OHSC, which says 73% of the staff members doing inspections and 27% administrative functions and stuff. But I just want to know, out of the staff members, 143, and I know you have a shortage of inspectors, what is the number of inspectors you have currently to conduct inspections at public hospitals and private hospitals across the country? And I think, Chairperson, what is happening, what we saw over the weekend in the news regarding the fire at the Tembisa Hospital, I think it's time, it's now my 6th year on this portfolio committee, and never we have asked the OHSC for a inspection report of which facilities across the country was inspected and by what date, and which facilities complied and which did not comply. I want to ask that we get such a report from the OHSC so that we can see what is going on with the inspections, how is the facilities doing, are they complying to the law, because of the fact that the NHI law is very clear that before a facility or a public hospital or a private hospital can be part of the NHI, they must comply to the OHC compliance certificates. So that is my main question, if we can get such a report from the OHC. And regarding the Tembisa Hospital, what happened this past weekend at the fire there, the provincial department now say that the emergency section, which was, the fire was happening, were renovated last year. But when other reports came back and said that they only received a 72% compliance from the OHSC. So if you can just get clarity around these matters and a comprehensive report about the inspections that were complied and who did not. Thank you, Chair.
Our name change now, Honorable Dr. Leroux.
Thank you, Chair. Thank you for the presentation. I just wanted to check one thing. I noted that you spoke about in your strategic plan and looking forward, part of your outcomes you're going to look at are actually going to be looking at clinical outcomes and not just sort of compliance with the tick box. A lot of the things that you analyze are looking at more administrative and kind of structural issues. And so I just wanted to check, when are those clinical outcomes going to be starting to be measured, and what clinical outcomes are you looking at adding to your inspections? Thank you very much.
Honorable Mutubatse, you are next.
No, thanks very much. It was quick this time. Now, just on one issue, I just want to focus on NHI. Because for me, that would be the focus of what we should be assisted. We're moving towards 2030. In terms of the compliance, percentage-wise, where are we? Or where we should be in terms of the institutions that we have, within the country, if I can be helped in that regard. And as a member of the public, when I come into an institution, especially with regard to moving towards NHI, is there any package that you can be able to simplify and set and say, these are the things that we expect this institution to have in compliance with the NHI requirements? Thanks, Chair.
Thank you, Honorable Dr. Letlape.
Thank you, Chair. Maybe I'll just usurp the colleagues' time to occupy the space. The first question from me is about financial sustainability. The OHSC speaks about the revenue streams, being able to charge a fee. How would that be negotiated with Treasury in terms of income retention, because I know that in the public sector, there are hospitals that charge fees, but they've got to pass the income to Treasury, and Treasury can then decide how is that aspect going to work, and what would be the legislative requirements to make it work. Second question is, the introductory remarks have always been talking about OHSC and NHI, linking to NHI in terms of health services, accreditation of facilities. Just clarity, and you know, there was a mention about concentrating on GPs, etc. When we talk about accrediting, are we accrediting the physical infrastructure, or are we accrediting the healthcare professional as well? If there's a separateness, who's responsible for public safety? Because as a patient, you know, you'd hope for an appropriate facility, and more importantly, appropriate professionals. What would the OHSC be guaranteeing in that process? Linked to that is the question of the human resource plan for the institutions. Is it something that the OHSC would look at in terms of compliance in relation to size and capacity of the health establishment, what the appropriate staff complement should be, or that's something that belongs elsewhere? Then how long would a certificate of compliance be good for? Is it for life? Is it an annual thing? Will there be a revisit, recertification, or reinspection? If so, what would be the frequency of that cycle? Now, when NHI is implemented and you have GPs that are accredited, that are credentials or accredited, whatever the term is used, what happens to the ones that are not accredited? Are they still able to practice? Or there would be coexistence between NHI and medical aid? Can they continue seeing medical aid patients? And the people that are outside that, professionals that are outside that, good with their statutory bodies, but not having been able to be accredited, or accredited, not having able to get a contract, how would that issue be managed? And what are the consequences for non-compliance? If you have a facility that is not compliant and it was being paid by NHI, what happens then? Are they suspended from payment? Are they removed from seeing patients? What is envisaged in terms of ensuring compliance and consequence management? Lastly, you know, I'm just concerned about the fact that you've only been able to do 20% of what you're supposed to do for that year. How is that aspect going to be dealt with in terms of ensuring that these things are done timeously all the time? Would there be a live self-evaluation where the facility is expected to self-report on all the measures that are out there, including adequate human resources? By that I mean, if I lose staff, will the public be able to know that I'm short-staffed? I've got no physiotherapists, I've got no rehab people, I've got no mental health practitioners, etc., etc. How would those aspects work? And how do we ensure that the OHSC is a structure for the nation, not a structure for the public sector or for the NHI? Thank you, Chair.
Thank you. Honorable Heko.
Yes, Chair, thank you. I am trying to establish facts here on the issue of NHI pilot sites. Were they able to check their compliance? Those establishments that were identified as pilot sites. Coming closer to what the honorable member has asked the previous one, on the issue of how long does their compliance certificate take. When they answer that, they must also add the question that asks how long do the inspectors take in a, maybe, let's say, a standard clinic and maybe a district hospital. How long do they take to issue a certificate? Another question is, how do they motivate those facilities that overperform? In a hotel situation, I would see stars. What is it that I can see that this institution or facility is compliant? How do I sense that as a taxpayer, just a customer to that? What should I see for me to say, no, they have been here? Also, how do those the management of the very facility, are they able to contest their findings? Sometimes you have someone and you don't agree with is there a way that their findings can be contested? I think I wanted to check on those, Chef. Thank you very much.
Thank you very much, honorable members. To the team led by Dr. Kinoshi, on page 12 of your document, there is a statement. I'm not answering these questions of the members, but it is coming in there on page 12. It starts by saying, let me read. There's this thing that talks about the policy. The certificate of compliance is valid for 4 years, which thus requires the OHSC to inspect all health facilities establishment every 4 years according to the definition of a health establishment. Now, it goes on to say here, we are not able to synchronize your health inspections in terms of accreditation, and you would want that to be aligned, because the other process is 5 years vis-a-vis the 4 years that is here. Now, there's something I didn't understand, but it is clearly written here that you inspect every 4 years. After 4 years, then you have to go and re-inspect. My challenge is on the presentation you made, that you are sitting at about 29%, but your ambition is that you'll be at 900% in this financial year. Now, how possible is that to be sitting at 29% and suddenly you jump to 100%? Number two, you are, what is that? Is it to do with the new ones that you have never examined, visited, or you are also putting those that you want to re-inspect? Now, somebody can wrongly or rightfully accuse you of delaying the implementation of NHI, because in the NHI Act, it says only facilities that have been accredited will then be allowed to implement NHI. Now, if you are accrediting at 29%, you have to go back and re-inspect, and you are far from getting the 100%. Absolutely. You are talking about, you are only sitting about 2,000, and the country has got more than 51,000, both private and public. So what is your plan in this regard? Are you actually planning, because you will be approaching the Department of Health, to expand your workforce? And also you are talking in this document about decentralizing your FOCs. But decentralizing offices when we've got the staff members of 20, again, is not going to solve your problems. So there's too many problems. So all members are asking regarding this. I want to say, I am not correct to accuse you of delaying NHI implementation, but I'm not saying it's going to be done today, tomorrow. But at the time you want to get all facilities ready for NHI, according to your pace, will be far behind in terms of that. How do you assist us to understand where are we going in terms of this? Dr. Kinoshi and the acting CEO. Thank you very much.
Thank you very much, Chair. And
yeah, before that, let me thank you and the Office of the Ombud. I wrote to the Office of the Ombud regarding the Fryhead Hospital, and I've since got a reply. There's a challenge there which I would like it to be attended to. I am a complainant together with other members of the public, but I will provide further information if it's needed. This is the second time we have a doctor dying in that hospital. One died last year, and this one is another this year. So something needs to be investigated as to whether these deaths have nothing to do with the workload or the treatment that staff members are exposed to there. Thank you very much. Over to you. Sorry about that.
Thank you very much, Chair. And I think I must start by apologizing that some of the questions came in so fast that maybe we would not all have taken them down correctly because of the speed at which they were coming in. And we're relying on how fast we can write them. But if we are not completely answering members' questions, I think we can be corrected. Chair. Some of the questions, I'll go through some of those that I can deal with, and then I'm going to leave the rest to Dr. Matebula, Mr. Mapata. But I see the executive manager in the office of the Ombud has also joined, so she can also assist from there. But also, if Ms. Molekwa, senior manager, Ms. Molekwa is in the meeting, she can also assist. But I will, starting with member Michelle Clark, I think there was a question of which ones of the core functions of the OHSC are we prioritizing for automation? And I will start with an overall answer, but the CFO and the COO may add to what I'm going to say. The OHSC has got a very strong IT section. Some of the functions of our IT functions are outsourced, and the inspections rely a lot on IT, including not only the targets but also the measures by which we measure an institution, so that there is so that we don't there's as less bias as possible, but also the reporting thereof are already automated, and I think that increasing automation makes it easier for us to inspect much faster. Where it would take 5 days, we might take 3 days now because of the automation. The intention is that there would also be smart inspections. We call them smart inspections. Dr. Matebula can explain further what we mean by that, which are planned to assist in ramping up the inspections so that we can certify health establishments as quickly as we can to allow NHI to accredit them for, let me say, doing business with the NHI fund. And so I think it's something that we are prioritizing. I think there was also a question of how do we make sure that institutions are not dishonest when it comes to inspections. That has happened in the past. I think in a past meeting of OHSC with the portfolio committee chair, you'll remember, it was asked that how do we make sure that an institution, when they know that they are coming to be inspected, they don't borrow equipment and other things that they have from sister establishments just to please us, and thereafter they take the equipment back. Let's say emergency toilet that they don't have, and then they manage to fool us. There are also most of the inspections are announced, but we also do unannounced ones as well. And we do re-inspections as well. So when an institution has been inspected, I think the CFO referred to re-inspections where if we have gone there, we can come there again as soon as we can. But for more than that, of course, we rely also on the integrity of the institutions themselves when it comes to inspections. And also we stress the importance of why we do inspections and ensure compliance. We're not there only as police, just to police institutions, but also to assist them in improving the quality of care that they give to the members of the public, but also the safety as well. So, and each institution that we inspect, we issue a report on where they comply and where they don't, but we also assist them in developing a quality improvement plan that will ensure that they move from one level to the next level. And we come back and ensure that they have moved, they have to report back to OHSC on their improvement of where they did not comply. So I think motivating them to know why the inspections are done, I think has won most of the institutions and the hospital managers onto our side as well. There was a question of decentralization, I think also from member Clark. And the decentralization has not yet started, but it needs resources, and it will start progressively. We may start with 2 provinces where we know that there are a bigger number of establishments, of health establishments. And here we're thinking about Eastern Cape and KZN, because we already have a presence in Gauteng, which also has one of the highest health establishments as well. So this will, we hope, will start in this year, but we are planning it hand in hand with the OHSC. It will start small, not with all the programs, the 5 programs of the OHSC, but mainly the Inspectorate Program 2, and to some extent also Program 3, Complaints Management, because we think bringing the services of OHSC closer to the people, especially when it comes to complaints as well, I think will also assist as well. So it might be just those programs that get decentralized in the initial stages. There was a question of shortage of inspectors. I'm going to leave that to Dr. Matebula to deal with. There was a question on vacancy filling. I will also leave that to Mr. Mapata and team. But we know that most of the vacancies that are not filled are those that are not funded as well. So we try to fill those that we have funding for. So if one looks at our staff establishment and sees vacancies, it is those that are that need funding. So they are there in the structure, in the organogram, but are not funded at all. I think that was what I could get from Member Clark. I think from Dr. Van Staden, Dr. Matebula, you'll respond to the one on inspections and inspectors as well, the numbers of out of 143 total staff members, how many at the moment are actual number of inspectors that we have, and what is the ramping up that we want to do? Dr. Matebula, you want to deal with that immediately? You can go ahead and I can come in later.
Better, Chair, you finish all what you are going to do, then you go to other members when you have finished with what you are going to do. Yes.
Okay, that's right. I think there was Dr. Van Staden's second question. What is OHSC's inspection report on the HSCs that are compliant? How many are compliant? And now I can't see, and especially in view of the fact that some of the institutions, even those that are compliant, we recorded them as being compliant, like Tembisa Hospital you mentioned, still have fires. Can we have inspection reports? Do we publish inspection reports? And maybe Dr. Matebula, we have recently been discussing inspection reports that will be made public. Dr. Matebula will give more detail on that. I think Dr. Leroux and I think asked a pertinent question on clinical outcomes. Which ones do we plan to start with? Because we in our just to explain here, so far in our tools to inspect and also what we look for, we have not been we're looking for many other things, everything actually, except checking clinical outcomes. We intend doing this, but we will not be doing it alone as OHSC. We plan to have partners in this, in planning how we are going to do clinical outcomes and measurement. And Dr. Matibula can give more detail, but we will have partners in who assist OHSC, because OHSC at the moment hasn't got capacity to do a clinical this. But I think coming from the health market report, I think it's something that we have put in our plans to commence with. Dr. Matibula will also deal with the member Mutubat's question about where we are percentage-wise with which institutions are compliant, percentage of institutions that are compliant, and also the packages of services. In I think the member Mutubate asked, which package of services will NHI provide? This chair will not come from the OHSC, but from the NHI and NHI fund. Which services will they cover in the public and private sector? I don't think I'm not aware. It has not been determined now, but it is being spoken. It's part of the work that the NHI unit is working on, and it will come in due course. I see Dr. Anban Pillay and others from the National Department of Health are in the meeting, and they may assist in answering that question. Dr. Letlape's question on financial sustainability. Whether it's being negotiated with Treasury. Yes, it is true that there have been talks with Treasury and from our side, led by both the CEO and the CEO and Mr. Mapata. The DDG and National also be involved. So we have got a scenario that we've set up a scenario with what we have. This is what we can do. And for us to do even more, we can do this much if we get this kind of assistance, and assistance in the form of filling of posts, especially the specialized posts that with the skills that we need, especially to determine more standards and tools for the professionals or the health establishments that we don't have tools for currently, and to fast track that process of making sure that we have tools, standards and measurement tools. We need some assistance. So we have indicated to Treasury what we can do currently with what we have and what we can do after. There was a talk about getting funding, generating our own funds. The plan is that at the moment, the OHSC from the inception has never charged for services that it provides to health establishments. Unlike other entities in government, like the SIU, they charge when they come and do any investigations in your department. The Auditor General charges a fee for auditing departments, and many others that I can mention charge a fee as well, but OHSC hasn't. So we have already made a request. Obviously, we have to start with the National Department of Health, but also with Treasury, that we need to start that. It needs legislation, yes. So it's an effort that we can't do alone, but the process has started. It would need regulations to be passed. in this direction. The regulations will obviously need to be sent out for public comment, and so that we can charge a fee for inspections of facilities that we are going to inspect, and for any other service that we provide as OHSC. This will be in addition to I don't replace, but in addition to the allocations that we get from Treasury. We hope that the fees that we collect will be we will be allowed, that the OHSC will be allowed to keep, so that they can fund all the other services that they provide, instead of going back to Treasury. How long will be assessed? I think Dr. Letlape also asked, how long will the certificate be valid for? It will be valid for 4 years. I think the chair read from a section in the document as well. So each certificate will be valid for 4 years. The cycle of inspections will, therefore, we're planning that there should be 4 years. That means every year we should be able to inspect 25%, about 25% of all establishments. So if we inspect 25% of all the establishments, if the establishments are 50 or 51 establishments in the country, which is the current estimate, it means we have to inspect 25% of them. If we cannot do that, it will mean that in 100% we would have inspected all of them within 4 years, and we can then do a re-inspections because the certificates are valid for 4 years according to law. That's how they are. What happens to establishments that are not compliant? Dr. Matibula will deal with that. There are measures that can be taken, that will be taken, including even but she'll deal with that. What are consequences of non-compliance? I think Dr. Matibula will deal with that. How will OHSC ensure that compliance performance improves from the low of 29% that is reported now to 100%? I think the chair also asked that question. And the team will detail the ways in which smart inspections will be introduced in this financial year. I think we started with that, so that and using IT to improve inspections, but also we've got a self-assessment system. Where institutions will be given a set of questions and the documents that they must submit, and there will be a way of checking whether these self-assessments that have been made are correct or not. So they have to submit them. The process has started already in its infancy, and the inspectors can then go out to verify what the institution says it is there. And this, I think Dr. Matibula will give more detail, is what is being discussed between the OHSC senior team headed by the CEO and the NHI unit on how to deal with institutions that are not, first of all, to do what they call conditional accreditation by the NHI fund. That would be valid for 1 year. That is for institutions that are not yet regarded as fully compliant because they have not been inspected, but the accreditation by the NHI is based on the self-assessments that have been done by the institutions with the assistance of the OHSC. And then where OHSC is happy with the self-assessment, and it will pass it over to NHI unit to assess them, whether they can provide a conditional accreditation. And I think that would ensure that most of the institutions are able to be accredited, even if it's a conditional accreditation by the NHI fund, so that they can start funding and not be shut down simply because they have not yet been inspected. So there is a process that will they can give a little bit more detail. I think just the last one on the chair, I'll skip the others, so give them to the team. I think on pilot side from a member, but the one chair about what about possible accusations that the OHSC is delaying accreditation by the NHI fund for accreditation? And I think the answer lies in what I've just said now. The speed at which we hope we are planning, not just hoping, but planning to increase inspections, but also to use other ways of achieving accreditation. And these plans are an ongoing discussion between the NHI unit and the OHSC senior management to ensure that accreditation is not delayed simply because of processes within the certification stage in the OHSC. So that we don't, that is OHSC doesn't get burdened with accusations like this one. But I think more information will come when we are next with the portfolio committee and to give them even more detail about this. Maybe if I may hand over to Dr. Matibula, although I see Chair Member Mutubati's hand is up again. Chair, can Dr. Matibula go on, or maybe you want to attend to Member Mutubati?
Oh, no, I was waiting for the guideline from the chairperson. Prof.
Yes.
Get the responses first, all the responses. Have you, Dr. Kinosh, and your team exhausted their responses?
No, I want to hand over to Dr. Matibula and the team to see what the other questions that I left out. Dr. Matibula, please go ahead, and Mr. Mapata can follow, and whoever else.
Thank you, Chair. Thank you for the questions. Just to expand on the automation, the systems that are being automated. The inspection tool has long been automated. However, post-inspection, the data just sit as raw data is not converted into a meaningful information that has to be done manually. That's what we are trying to automate so that the system generates information from the data that it has. As well, we are also automating the development of the certificate that is already in the process of it being finalized. We have automated the self-assessment, especially when coming to private acute hospitals, and it automatically generates even the quality improvement plan. Generally, we want to be able to have a system that will analyze the data. We collect volumes and volumes of data, as you can imagine. The correlation between the findings of the OHSC vis-a-vis the self-inspection, I think Dr. Kinoshi has alluded to the fact that previously is no more that common. Previously, when the health establishments were not complying in the main, there used to be a disjuncture, but of late, because people understand that self-assessment is meant to help one to improve the services and close the gaps, they seem to be we seem to be getting closer, especially because they are using the same tool as the one that the OHSC uses to to inspect them, find out they are measuring the same things. So it looks like we are improving there. The re-inspection, once we inspect a health establishment, if it's found not to be compliant, to issue a non-compliance notice that is stating clearly the areas that the health establishment didn't comply with, or the functional areas, and then with the expectation date to comply with the findings. But if the health establishment, that is after we inspect, then within 20 days, the health establishments need to respond 20 days after our inspection. And then we also review or look at what the health establishment has submitted, respond within 20 days. That is in accordance with our procedural regulations. Then we issue the certificate once we are satisfied with what has been submitted. If a health establishment on spot is found to be compliant, we must state that so far there can't be 100% compliance, because our approach is incremental. We just want to have a feel that the health establishment is safe and they provide the quality, and we have got a grading where we say this one is complying or not complying with excellent grading. This one is complying or not complying with good, because the non-compliance in the main will be with what we call non-negotiables. But each one, we have got 3, we've got non-negotiables, we've got essential, we have got vitals, essential, and non-negotiable. If you fail the non-negotiable, there's no way you can be compliant. Then the vital and the essential also has got a threshold that we can tolerate for you to be less than 100%. And then the shortage of inspectors, I think Dr. Kenoshi fully covered that, but there was a question by Honorable Van Staden on how many. We have got currently 45 inspectors, and then we have got 72 posts of inspectors that are vacant, unfunded. The difficulty, first of all, is that as a unique office, we don't have readily made skill in the entire OHSC, be it the development of tools, be it the inspection. All these people need to be trained, and they're not there. So we have to recruit them and train them. And secondly, as have already been alluded, is the shortage of financial resources. And then maybe still with the Honorable Clerk, we just want to take note of the comments about Rahima Musa, the improvement there, and the fact that we have sustained our unqualified audit. We appreciate your comments, Honorable Clerk. The vacancies, the structure, we have got 323 posts, but only 143 are filled. 3 are vacant because we can't find people, the management posts, the executive managers are not, we can't find people. Like I have indicated, the skill is not there, but the rest is because of the lack of funding. Coming to Honorable Van Staden's, the other question was about the report. All our reports are found in our website. We are about to put up now what exactly Honorable Van Staden is referring to. Once it has gone through the board, the biannual report, meaning the institutions that were inspected in the past 6 months, it will be there. It will be found before the end of this month. And we do for the past years, they've been there. Yes, in the main, you find that we just indicate which hospitals or clinics were inspected, but there wouldn't be any indication of whether they are complying. But in our annual inspection reports, then you'll get the details of which ones were inspected and their compliance. And then I think that one is done. Then we move to Dr. Letlape, I think, it was Dr. Leroux. The clinical outcomes, I think Dr. Kinoshi responded sufficiently, but our approach is as per what the NHI is looking at, because NHI unit is really having focus on the clinical outcomes as well. They've identified a few like pediatrics and geriatrics. And we were thinking also, Dr. Leroux, at looking at the national priorities in health, like the TBs, the HIV, and the mother and child programs as a start. That's what we are thinking we will be doing. But like Dr. Kidoshi is saying, we'll need experts and other capable people to assist us in that we raised as we also engaging stakeholders during June, July last year. And we had a feel that stakeholders are interested in assisting us accordingly. Then from Dr. Letlape, it was Dr. Kinoshi covered the income retention, and it is in the National Health Act as amended that the OHSC will get money as appropriated by the Parliament. In addition, the OHSC. In addition, the OHSC will also get funding from self-generated. It is in the Act, it's legislated as such. So like Dr. Kinoshi is saying, the relevant structures have been communicated to, and we have the support. Another question was, who are we accrediting? We don't accreditate as OHSC. We certify health establishments, not the professionals. The professionals then still fall under the relevant bodies for accrediting them to be practicing. The NHI will apparently be doing both, because the facilities would have been certified by the OHSC, and then the NHI will look at whether the professional has been accredited to function by the relevant structures. We don't look at this point at the human resource plans in detail. We just establish how many, what is the staff establishment of the health institutions and what is the vacancy rate. That's all we are looking for, simply because we actually don't know how many people or of what profession or worker should be in each health establishment. That was tried using the WISEN, and it seemed to be giving problems because it was more of the first world. It didn't talk to the third world. We hope that will still come from national department. Yes, the 4 years, yes, we have to, our certificate life is 4 years, but extendable by another year. That is in accordance with the Act. And then it can go to 4 years, but within by that 5th year, the health establishment has to apply to the OHSC for an extension. And then whether the health establishments that are accredited by NHI that are found not to be or that are found not to be meeting the requirements by the OHSC, and will the NHI close them? I think we'll leave that to the NHI, but looking at our situation, we find that most health establishment, especially the public ones, you find that is the only health establishment in the community. Therefore, closing it may not be practical. The next one was the self-assessment. I think Dr. Kinoshi, you responded to. And then the next one was from Honorable Tego, the pilot sites. So far, the Office of Health Standard Compliance has inspected all levels of categories of public facilities, and including those that were identified as a pilot site. And in the main, I don't have the actual figures, but in the main, they've complied. There was a question, I think, I can recall, of the compliance rate. The compliance rate is as informed by the health establishments that have been inspected since 2019 when we started. We started with the clinics and then followed with the CHCs and the district hospitals. Later on, we started in 2021. Okay, the district, regional, and CHC, we started in the financial year 2021-2022. And when we started with the clinics only in 2019-2020, the compliance rate, we are talking now about the health establishments that were inspected. At that stage, we had 95 that were inspected, or 647 that were inspected. And then the compliance was at 15%. But now we are talking about having inspected a total of 4,000 combined with private, 4,527. And the compliance rate as of this past 23-24 financial year is sitting at 79%. So there's a good improvement with compliance, because now health establishments are starting to understand the purpose of having quality health care.
Dr. Machebula, just improve on your speed of the time of response. Okay, just try and improve that.
Thank you, Chair. I think we have covered all. Yes, Chair. We also note your comment about Fryhead Hospital, and Dr. Jacobs is here. Maybe I don't have information about that one. Maybe Dr. Jacobs, you can come in. respond to the Vryheid Hospital issue that the chair has passed to yourself.
Thank you, Dr. Matibula, and good evening to the honorable members and to my colleagues. Honorable Chair, we have received your complaint and it is currently being processed by the Office of the Ombud. Thank you.
May I allow, thank you very much for that. May I allow Honorable Mutubatse, he wanted to clarify the question that he was asking. I think let's note that and give him a space. There are certain things that should be done by department, not by Office of the Health Standards Compliance when it comes to NHI. But maybe let him clarify and then you can respond again. Thank you. Honorable Mutubatse.
No, thanks, Chair. Maybe having said what you have said, maybe this can be a suggestion moving forward. If perhaps maybe OHS can think of developing a simplified checklist, even for us, members of the public, on issues that we need to actually look into. We must not just have a blanket accusation that this particular institution is not NHI compliant. Maybe as part of a collaboration, because this is a national project, we can help one another do that, develop that checklist so that when I go there as a member of the portfolio committee, then I must be able to say, all right, these are the things that perhaps needs to come in to fast track NHI to be in place. I don't know. That is maybe at some point we might invite them to come and deal with the crash course for us members of the committee, so that we don't go there blank when we make this accusation. Thanks, Chair.
Yeah, let's request Dr. Anpan Pillay, not today, on your response on Thursday. I think we are coming on Thursday. Just to make a 5-minute presentation, what is your expectation of the Office of the Health Standard Compliance? If I were to do that, some of us are aware of it, but let's not assume that all our members know. They found the Office of the Health Standard Compliance up and running. They actually have the non-negotiables that they have to look into. Some of them have heavily weighted as compared to the others. Maybe that will assist us. We may not actually get into a fully blown workshop, but give us that snapshot of what are your expectations and what does it mean when they say the Office of the Health Standard Compliance comes back to say that facility is accredited silver, gold, diamond, platinum, and all that. So you would actually be able to assist. Don't cover everything, but give us some way of understanding where we are on this process. Thanks. Is that possible, Dr. Pillay?
Thanks. Yes, I think it's possible. Thank you.
Okay. All right. Honorable members, I want to thank all of you and also thank this last presentation from Office of the Health Standard Compliance. It has been a really marathon of activities. Tomorrow we are better off. We don't have 4, we have 3. But I want to thank you all for having been here right through until now. We are finishing. We are starting again tomorrow, and we will also go and look into 3 other entities. I thank you all of you for your participation right up to this moment. And sorry for that glitch. I was not aware my other line is not linked to the electricity. Now I'm fine. But and thanks for Dr. Honorable Keko for standing in for me. I would want to wish you a good afternoon, evening, until we meet again tomorrow at 9:30. Thank you very much and good night.
Chair, just a question. Is it the same login details or will it be a different login tomorrow?
Ms. Machalamba, assist us.
I've already emailed the login details for tomorrow, Chair.
Okay. Yeah, we are busy, Ms. Machalamba. We don't look at our WhatsApp all the time, but thanks for that. So there will be a new login details for tomorrow. And thanks for that. Good night. Bye-bye.
Good night, everybody.
Night.
Night.
Night, Chair.
Good night. Thank you.
All right. Oof. Meeting must